Good morning, everybody. Thanks for coming. Appreciate everyone coming out at 8 in the morning. We're going to get started for this symposium sponsored by Priovent. And we have a couple of speakers first, and then we'll have a panel discussion about the results where we'll present some questions to a panel here up on stage. First speaker doesn't need much of an introduction, as I think everybody knows who he is, but Dr. Rohit Aggarwal from the University of Pittsburgh will be presenting on the top-line results of the VALOR trial for brepocitinib in dermatomyositis. So please welcome Dr. Aggarwal.
Thanks a lot, Priovent and Gcom, for inviting for this talk. We'll be talking about brepocitinib in dermatomyositis, the results from phase 3 VALOR trial. Just want to see. Yep, okay. So here are my disclosures. Okay. All right. So first, let's talk about what brepocitinib is. It's a first-in-class oral selective combined TYK2 JAK1 inhibitor. It's oral, once daily, selective inhibitor of catalytic domain of tyrosine kinase 2, which is TYK2, and JAK kinase 1, this is JAK1. So it's a dual TYK2 JAK1, uniquely disrupts the key cytokine pathway of both TYK2 and JAK1. Therefore, it suppresses type 1 and type 2 interferon and multiple cytokines that have been implicated in pathogenesis of dermatomyositis, which includes IL-6, IL-12, and IL-23. As you can see in the diagram here, it is mechanistically distinct from a non-selective JAK inhibitor, a selective JAK1 inhibitor, and a selective TYK2 inhibitor, but because none of these combines the type 1 and type 2, as well as the multiple cytokines implicated in dermatomyositis, such as the brepocitinib do. As you know, all of these cytokines, including obviously type 1, the most, and type 2, have been implicated in dermatomyositis pathogenesis. So what are the key differences? We have many non-selective TYK1 to 2, 3 inhibitor. We have JAK1 to 3, and we have JAK1 to 2, which is brepocitinib, JAK1 to 3, which is tofacitinib. We have single isoform inhibitors, which is upadacitinib, for example, JAK1, and there are other JAK1 inhibitors. But when you non-selectively block multiple JAK1, it doesn't block TYK2, and the same as if you block JAK1, you're only blocking one of the key cytokine. But what's unique about brepocitinib, it really combines all the key cytokines, especially type 1 and type 2 interferon blockade, but also IL-6, which is very important, as well as IL-10 and IL-12 and 23. The clinical development of brepocitinib, I want to highlight, this is not the only trial the brepocitinib has done. Actually, there's a lot of phase 2 data on brepocitinib, which proves significant exposure to brepocitinib, as well as safety data and tolerability data. We're not talking about those data because that's not really relevant to this is a myositis conference, so I will not be presenting the data. But just to note, there are more than 2,000 patients that have been treated with brepocitinib with excellent safety and tolerability data. And there are multiple phase 2 and phase 3 development programs that are in process, that are underway on brepocitinib. So first, what Priovent did is this proof of concept study on 5 patients, which is really excellent data. Brepocitinib achieved robust clinical response. These patients had a predominant skin disease, very high CDACI, he's talking about 30 to 40 CDACI, and dramatically improved in a matter of 4 to 8 weeks. And then they did some basic science data, which clearly shows significant suppression of type 1, as well as type 2 interferon signal within 4 weeks. So this is the study that really led to the next phase 3 study, which I will be presenting. Now, if you look at the type 1 and type 2 interferon pathogenesis in dermatomyositis, what you notice is all myositis-specific antibodies have the type 1 and type 2 interferon signal. So it's not really a one particular antibody. Pretty much all of the whole dermatomyositis group really leads to type 1 and type 2 interferon upregulation. So you've blocked type 1 and type 2 selectively, as well as other cytokines that are implicated in dermatomyositis, you're bound to get good results. So we also have had a long journey of multiple clinical trials in dermatomyositis. Many of them have failed. We have one successful clinical trial on dermatomyositis with IVIG PRODERM study with Octagam, which was got FDA approval. But I want to emphasize we have done many other trials in dermatomyositis, including rituximab, Remicade, Stelara, many drugs, but they have all failed. They're all phase 2, phase 3 trials, but multiple of them have been failed. So what's different about brepocitinib? One, it's oral, once daily selective inhibitor of type 2 and TYK2 and JAK1 inhibitor. It's the first positive registrational trial for a targeted therapy in dermatomyositis. We have had one positive registrational trial for a non-targeted therapy, but this is a targeted therapy in dermatomyositis. It's the first 52-week placebo-controlled trial of any therapy in dermatomyositis. It's the first placebo control of any kind of once-daily dosing, oral dosing in dermatomyositis. It's the largest interventional dermatomyositis-specific trial ever done with more than 200 patients. Now, when you look at the results of the previous trial, what you see is many trials have been done. Almost all of them have been not successful, failed, or did not meet their primary or secondary endpoint, except IVIG PRODERM Octagam. But you look at the number of patients enrolled on previous trials, and look at the VALOR study of brepocitinib. I have to congratulate the VALOR team really to be able to enroll more than 200 patients in a single subset of myositis. Many trials we struggle enrolling patients because of being rare disease, heterogeneous disease, complex disease, even when you have multiple subtypes being enrolled. To be able to enroll dermatomyositis specific more than 200 patients in a very short time frame is an achievement itself. So let's go into the VALOR study specifically. This is obviously phase 3 study designed to be a registrational study, a randomized controlled trial. So what we did is we randomized 241 adult patients with dermatomyositis with 1:1:1 randomization stratified by Physician Global Visual Analog Scale for severity, mild and severe disease. And there were 2 doses given. 30 milligram of brepocitinib was given to 81 patients, 15 milligram of brepocitinib given to another 81 patient, and placebo arm got 79 patients there. What was unique about this trial, there was a protocol-defined steroid tapering, and we will discuss the steroid tapering quite a lot because steroid is a major problem in our field. We continue to use excessive use of steroid. We get our patients better, we feel good, patients temporarily feel good, but long-term, 5 years, 10 years, outcomes are very poor when these patients stay on steroid for long-term. So this study will discuss the results have been really remarkable in terms of significant steroid tapering. Now, what was the eligibility criteria? You have to have a definite or probable dermatomyositis as per 2017 EULAR ACR classification criteria of dermatomyositis. You had to have muscle weakness and active skin, which is quite unique. You have to have both the organ hit, means you have to have a threshold of skin disease above which, and also have a threshold of muscle weakness. And if you have both, then only you could enroll in the trial. Patients who were refractory or intolerant to prior standard of care treatment were included in the study. You were permitted background immune suppression, which was steroid plus minus immune suppressive drug. The primary endpoint was total improvement score as per the ACR EULAR 2016 response criteria at 52 weeks. This was a continuous outcome. This wasn't categorical outcome of moderate or major, but we'll show the results of all the different outcomes. But the primary endpoint was mean TIS over time. Now, what were some baseline characteristics? This is classic table 1, very well-balanced group. You have a 30 milligram brepo group versus 15 milligram versus placebo, very well-balanced. There are a few things I would like to highlight in this chart. Number 1, about 20-25% patient had ILD. We know from JAK data in general, specifically tofacitinib, non-selective JAK inhibitor, that there is a concern about malignancy, there's a concern about cardiovascular risk or thromboembolic risk. So what this slide is also showing, many of these patients had a prior history of malignancy as well as prior history of more than one cardiovascular risk factors. In terms of the severity of the patients that we enrolled in this trial was quite dramatic as well. So if you look at the physician global VAS, it's around 5, which means it's basically it's a moderate to severe disease category. You look at MMT8, the mean score comes out around 16 to around 120 to around 121, which is also very severe disease. When a mean is 120, 121, that means many patients were at 110, 100, or even below out of 150, somewhat higher. So, but if you compare to Vi+Vii trial, which was the previous trial, we also had a mean of around 120. So we know the mean of 120 really hits muscle disease pretty well. HAQ-DI above 1, HAQ is pretty significant. That means patients were pretty much had a significant disability. As you know, HAQ goes from 1 to 3, but if HAQ mean is above 1, it's a pretty significant disability that these patients were suffering. If you look at the CDASI, which is a skin disease activity scoring, anything above 14 is considered moderate to severe disease. And look at the mean CDASI scores here around 18, 19, 21. These patients were on background immune suppression. Many of them, around 79% of them or 80% of them were on 2 or more dermatomyositis medication. Prior exposure to IVIG was around 24%. Now, out of 241 patients that were randomized, I said 81 were randomized to 30 milligram group, 81 were randomized to 15 milligram group, and 79 were randomized to placebo group. And you look at the discontinuation rate, it's pretty low in the 30 milligram group. It's about 7%. Now, in 15 milligram group, you see about 14%, similar to slightly higher in placebo group, 18%. So the completion rate, at least in 30 milligram, was above 90%. As you know, when you have a completion rate of above 90%, that means the drug is probably doing something that the patient didn't want to get off the drug, the physician didn't want to get off the drug, which was, as compared to 15 milligram group, was around 86%, still pretty good, but slightly lower than 90% threshold, and 82% in placebo arm. So if you compare the patients who received rescue, only 15% patient required any rescue in 30 milligram group, as compared to almost double in the placebo group, which is about 30%. Now, this is the primary and all secondary endpoint given on one slide. I'm not going to go over each outcome. What impresses here, every primary, we have one primary, but primary and all secondary outcome measures met the threshold of p-value less than 0.05. And there's not, typically what you see in a trial is one primary and 3 or 4 key secondary. Look at the number of secondary endpoints. We pretty much covered very broadly, and everything met, was statistically significant, primary as well as all secondary endpoint. So let's go a little bit in more detail about this primary and some of these key secondary endpoints. Dr. Ruthan Wiggles will really discuss the skin and safety data. I will discuss more of the muscle and primary endpoint. So first, let's understand, I know there are many trainees in this audience, so I want to just go over one-on-one on the total improvement score. What is this outcome measure? This is a composite response criteria, which includes 6 core set measures of myositis. Number 1, physician VAS, which is a scale of 0 to 10, where physician says how active is the patient's disease on a scale of 0 to 10. Then a patient VAS. You ask the patient how active or problematic is your disease on a scale of 0 to 10. Then there's extramuscular global, which is actually derived from a tool called MDAD, in which you really come up in the end, what is the extramuscular burden? Other than the muscle, what's the extramuscular burden, which mostly in this trial and other studies be skin, some lung, joints, and other problems. Then muscle MMT8. MMT8 is a single semi-objective measure of testing how strong the muscles were. Muscle enzymes, which in dermatomyositis, by the way, is not perfect biomarker. In immune-mediated necrotizing myopathy, I swear by CK. If a CK is high, disease is high. CK is low, disease is low. But in dermatomyositis, it could go with your disease activity quite well, but in about 20-25% patient, it might be totally dissociated from the disease activity. So keep that in mind. Health assessment questionnaire or HAQ disability index, which measures activities of daily living. And in total improvement score depends on the level of improvement in each core set measure. You get a certain point. At the end of the day, you add up all the points in each core set measure, all the 6 core set measure, and that's your total improvement score. And the thresholds when we developed about almost 10 years ago now was minimal response more than 20. When we developed minimal response of more than 20, we knew that's a very low threshold. But at that time, we had no proven treatment in myositis or dermatomyositis. So we wanted to keep the threshold low so that the drugs have a higher chance of meeting the threshold. However, going forward, we have realized that's a pretty low threshold, and many patients who are on actually placebo arm, but actually it's not a placebo arm because they are getting steroid, they are getting non-steroid immune suppression. So many of them actually achieve minimal TIS of 20 very easily. So the other outcomes, if you see other key secondary outcomes, were moderate TIS or major TIS, which is now has been the recommendation to evaluate the drugs. This is my favorite slide. This shows the mean TIS over time. And if you look at the brepocitinib 30 milligram, had a mean TIS of around 46.5, as compared to brepocitinib of 15 milligram, 37.5, and as compared to placebo, 31.2. Now this seems like I have sketched it to teach how a randomized clinical trial should be positive. This is just too good to be true. And I was really, the first time when I look at this slide, what's going on here? This is a perfect outcome that anybody could have hoped. Not only that you have a statistically significant result over placebo, but your middle dose. So look at the dose response curve, the beautiful dose response curve that has been achieved here. Now, let's dive a little bit deeper. So the 30 milligram dose was highly statistically significant than placebo at week 52 with a delta of 15.3 with a p-value of 0.0006. Now, to emphasize, if you have a delta of TIS of 10 or more, that's quite meaningful. 15 or more is really dramatic. But let's also look at this other box on the side here. If you look at the steroid, and less than 2.5 milligram achieved at month 12, 52 week, in 62% patients with brepo 30 milligram, as compared to almost half in the placebo. And off steroid, which is what our goal is to be off steroid, 42% patients achieve off steroid as compared to 23% patients, almost half in the placebo arm. That's why I said this is just way too good to be true, but it's really one of the excellent results, and we are very fortunate in myositis community to have results like these. Now let's dive a little bit deeper, because what TIS mean is a differentiator. It differentiates a treatment versus placebo with statistically significant result. But it doesn't tell you how much the patient got better. What's the thresholds of improvement? So for that, I like to look at TIS 40 and TIS 60. So let's look at TIS 40 and 60 here. By the way, I want to go one slide back and point out one more thing here, is how quickly the patients got better. So look at the week 4 results. You already start to see the signal of separation, increase by week 8, week 12, and by week 16, you have achieved the mean that you wanted to achieve almost there. So you see how quickly this drug is working, which we know from all the other JAK personal experiences that it either works or not, it works faster. But to show this in this type of dose response curve, how quickly it works in a statistically significant way is quite dramatic. Now let's go to the TIS 40 and 60, because if somebody asks me, what are my chances to improve on this drug? I would say that is my TIS 40. So I give them the number, not TIS 60, it's a very high threshold, very high bar, not TIS 20 because that's a low bar. So I tell them TIS 40 is my threshold here. So look at 2/3 of patients improved on with TIS 40 as a cutoff, as compared to 44% in placebo, which is 24% delta. And also, just as a teaching point, if you have a delta of 10, that's good. A delta of 20 is quite dramatic, and a delta of 24% is just amazing. If you look at TIS 60, which is a very difficult target to achieve, 43% patients achieve TIS 60, which is TIS 60 gets you to almost like a remission state. This is very difficult to achieve. And half of those patients achieve TIS 60 in placebo arm. Now, let's dive a little bit deeper, the TIS-40, which is the moderate, and TIS-60, which is the major response. So on the first graph, that what we are showing here is TIS-40, which is the delta of 22.2%. But when you combine the TIS-40 with a steroid tapering, it becomes very important because, as I was saying, we need treatment that you don't need steroid. We need to be like RA. How do we treat RA? We treat RA without steroid. Maybe we give early steroid for a few weeks, 4 weeks, maybe 8 weeks, and that's it. We don't keep using steroid for RA. We need to achieve that outcomes in dermatomyositis, and I have to say, this study actually showed how those outcomes could be achieved. So if you look at TIS-40 with oral corticosteroid dose of less than 2.5, and then the next graph shows you without steroids. So you have about a delta of 20% in TIS-40 without steroid. If you go to the major one, you see that the delta increases even for major. So in the normal comparison of just TIS-640, who achieved TIS-60 versus not achieved TIS-60 is about 19%. But when you combine it to a threshold of less than 2.5 milligram of steroid, you get to 27%. And when you combine to zero steroid, you get about delta of 22%. It's quite dramatic overall. So 30% patient achieved TIS-60 without steroid. That's very difficult, and about 44% achieve TIS-40 without steroids. Now, what the difficulty with the steroid tapering is when you talk about threshold, that how many got off steroid and how many got less than 2.5, is sometimes difficult to understand because you have to understand where the patient started. So what this slide shows is comparing from where the patient started. So the first graph just shows you who got TIS-40 or who did not get TIS-40. So 54% versus 27%. The second graph shows you if the baseline oral corticosteroid was more than 5 milligrams, what was the delta. The third graph shows you if the baseline corticosteroid was more than 10 milligram, what was the delta. The next graph, 15 milligram, and the last graph shows you 20 milligram. Why I like 20 milligram is because those are our problematic patients. So anything between 10, 15, and 20 are really our problematic patients. That means the physicians are struggling to get their disease under control and have to use steroid more than 10 milligram to keep them at bay. And look at the delta there at brepocitinib 30 milligram had 64% response among those patients as compared to placebo of 19% with a delta of 47.5%. That's quite amazing results again. And also, this question is a very valid question. Which type of patients improved? Those were antibody positive or those were antibody negative? Which antibody improved? Which group improved more? Which group did not improve more? As we've already talked about, we know that from our prior science that almost all MSA induces type 1, type 2 interferon and all those cytokines. So my guess would be pretty much all autoantibodies or MSA would improve. Unfortunately, we don't have the data yet to tell you about all specific autoantibody group, but we do have the data on JO1. So we have patients who are JO1 negative, and we have patients who are JO1 positive. The only caveat here is those who are JO1 negative could have other autoantibodies. We just don't know yet because it was not protocol requirement to have MSA positivity or MSA to be captured. So we are doing some more work to hopefully throw some light on it in future. But regardless, if you look at JO1 negative, JO1 positive in all patients, they're quite equal. It's not a proof, but it suggests that perhaps this drug may work on antibody-positive patients similarly to antibody-negative patients. Because antibody-negative, MSA negativity, doesn't always mean it's MSA negative. You could have a false negative. You could have a patient with antibody never not been detected. So there are many other issues with MSAs, but at least it says some suggestion that perhaps this could also work in antibody negative as good as it works in antibody positive patients. Now this slide is really a testament for TIS-40 and 60 that I want to congratulate so many people in this room who contributed to the development of ACR, EULAR, total improvement score, and I can see many of these faces right here. This was developed 10 years ago, and I remember how much work was put into this. This slide suggests that why test 40 is a meaningful outcome and why test 60 is a meaningful outcome. So if you look on your left, you have patient global impression of change, and on the right, you have a physician global impression of change. So overall, if you ask the patient, did I get better or not? And did I got any worsening? So you ask patient say, I have some worsening. I do not feel any better as compared to the start of the trial. I feel somewhat better. I feel much improved, and I feel very much improved. The same question is asked the physician. Do you think the patient had any worsening? Do you think the patient had no change, or slightly improved, much improved, and very much improved? And you look at here is test 20 does not cut it. The test 20 is any worsening and no change. Those patients were above test 20. But when you get to test 40, which is what this trial achieved, you see the patients clearly has distinction between those who improved and those who did not improve or had no change. So this is really a testament of the outcome, the clinical meaningfulness of this outcome, both in terms of patients' overall impression and in terms of physician overall impression. So next one is a tricky slide, and I'll try to explain to you. So now what we are trying to think, okay, what can we do better? We achieved test 40, we achieved test 60. That's a response, that's a change from baseline measure. But how many patients we got into a very good state? And this is what this slide reflects. So we came up with this definition of remission. As you know, there's no validated definition of remission that exists. So we kind of had to make up something. And what was decided is to have a physician global of 1 or less, patient global of 1 or less. The out of 10 scale, when the patient and physician both are saying my disease activity is less than 1 or less, and a steroid of less than 2.5. That was considered as a remission. Again, not validated outcome, but just to understand what type of state these patients have. And if you look at 24% patient achieved that remission state as per our definition here, as compared to 9%. So about 2.5 times patients were put into this remission state. Now, low disease remission is tough to achieve. As you know, in myositis, we don't even talk about remission. We don't even have a definition of remission. The reason we don't have a definition of a remission because we don't achieve remission. And so this is a really remarkable data that 24% patient achieved that. Now, when you go to the low disease activity, about 50% of patients achieve, 53% patient achieve low disease activity as compared to almost half at 28% in placebo group. How was the low disease activity was defined by physician global and patient global less than 4 out of 0 to 10 scale and a corticosteroid dose of less than 5, which is reasonable. But again, we need to hopefully look at this data once we have a more validated definition of remission and low disease activity. As you may know, there are some efforts ongoing to develop remission and low disease criteria. So overall, nearly 2 to 3-fold higher low disease activity and remission rates and states in this trial. Now, we talk about the placebo effect quite a lot, and I have a talk on Thursday where I will be talking about clinical trial design. But this slide is quite remarkable in one sense. If you look at the health assessment questionnaire, disability questionnaire over time, you see there's a dramatic placebo response in the first 12 weeks. So both placebo and treatment group decreases their HAQ, and lower the HAQ, better it is. But what happens when you start the steroid tapering? Some of that placebo effects start to wane. And you see quickly, right after as you start to taper prednisone, that the patients who had a placebo effect of really I'm doing very well, and it comes from two things. Placebo effect comes from two things. One is a true placebo effect, which is the bias that comes because of hopefulness and positivity that comes from being in a clinical trial. The second is a true effect of the background immune suppression. So both the effects get combined. There's no way to differentiate between the two. But when you start to taper the steroid, what happens, the background immune suppression effects goes away, and also the hope goes away by week 12 that I think I might be doing better. So it's really, and if you see how the curve continue to separate out all the way to week 52 and maintain that, it's also very dramatic. And if you look at the HAQ outcome of 0.5 or less, 41% patient achieve a HAQ DI outcome of less than 0.5 as compared to 19% in this trial. If you look at the individual HAQ questions, and these are all the questions about activities of daily living, how difficult is it to perform these activities? No difficulty, mild difficulty, moderate difficulty, unable to do so. So this is how the scale is. And you look how much the hack moved almost on every question in the Brepo 30 milligram group as compared to their baseline. So almost all questions improved, including the first question, which is how much pain do you have in past week? Now, you'll ask, what about the interferon signal? Again, the studies are still ongoing, but early suppression type 1 and type 2 profiling suggests significant suppression of type 1 and type 2 interferon as from baseline to week 12, is you see highest in Brepo 30 milligram group, which is what's very consistent with the clinical outcome that we have seen on Brepo 30 milligram group, and somewhere in the middle in Brepo 15 group, and really not any suppression, which is obviously as expected in the placebo group. Now, what about safety? Dr. Ruthann Wiggles will talk about the safety much more in detail, but very quick summary. Overall, no matter how you look at the safety, there was no major concern about safety or tolerability of this drug. So in summary, we have a really positive trial here. So first ever phase 3 positive trial of a modern targeted treatment. We know that we have a phase 3 trial positive in Octagam Produm study that was the first drug approved in dermatomyositis. This is hopefully, again, this is not an FDA-approved drug yet, but hopefully get an FDA-approved very soon. This is an early, as I showed you, as early as 4 weeks, curves start to separate early and then sustain benefit of broad range of primary and almost 10 secondary endpoints. It is also mechanistically aligned, as I showed you, interferon signal beautifully responds in 30 milligram versus 15 milligram versus placebo. Also, we are moving beyond the minimal improvement. We are talking about moderate thresholds. We are talking about putting patients in remission and low disease activity, hopefully with this data, and looking towards as a remission in future and low disease activity as a goal. We obviously need to do a lot of work to develop that low disease activity and remission criteria. And any one of you who are interested in that development, please contact me. We are doing a project to develop that very soon. With that, I want to thank Gcom, my colleagues, as well as VALA study team, as well as the Priovent team for giving me opportunity to present this. Thank you.
All right, terrific. I have slides. It's wonderful to see you all this morning. It's just absolutely delightful to be here in Lisbon with a lot of people who care about myositis. If I could tell you when I started my career caring for patients with myositis 20 years ago, that I thought we would be here discussing the results of a global phase 3 randomized controlled trial that enrolled 241 patients, I don't think I would have believed it, actually. And so just to hear Rohit's talk, and to see that robust statistical significance on 10 endpoints, I think is just really meaningful to those of us who care for patients with myositis. So I'm excited to share this component of the talk with you. Of course, I'll get into a little bit more of the skin and the safety data. But to introduce myself, I'm Ruth Ann Vlegels. I run the rheumatology dermatology programs at both Mass General Brigham and Boston Children's Hospital, and I'm a professor at Harvard Medical School. Here are my disclosures. And I just want to level set with something that I have found very important in the last 2 decades as I care for patients with dermatomyositis, which is that I think we have this patient is doing good enough fallacy in dermatomyositis. So it's really interesting because I move back and forth between Boston Children's and Mass General Brigham, and my pediatric colleagues really treat for remission in juvenile dermatomyositis. And it's really a very different philosophy. And it's often interesting then when I pop back over to Mass General Brigham, and often we're just okay with patients doing good enough, right? And why is that? Because we essentially haven't had therapeutic agents that could put our patients into remission. Just as Rohit alluded to, We don't even have definitions of remission. So we really need to move the needle more in dermatomyositis and think about these therapies we're used to using not as being standard of care, but being more just what we traditionally use. And we need to move past them in our patients. So why is that? So when we see patients with dermatomyositis, we know that they have a lot of comorbidities, but those are primarily driven by uncontrolled disease activity and the standard therapies we're giving them. Both of those together are why these patients have increased risks of cardiovascular events, clotting, serious infections, and malignancy. And so many of you are very accustomed to thinking about this data. We know that chronic systemic inflammation leads to endothelial dysfunction and clotting, et cetera, in these patients. And we know that in terms of our standard therapies, in particular, systemic corticosteroids lead to many, many poor outcomes in these patients. So again, we're just really not treating these patients to put them into remission at this time. So another really important pearl that I've learned in my care of dermatomyositis patients, but also thankfully was actually published by the Hopkins group quite recently, is really that most of our patients are dissatisfied with the care they're receiving, even in centers of excellence, right? So even in groups that are very good at treating myositis according to standard therapies, 2/3 of our patients are dissatisfied with their treatment. And this is even more in patients that have moderate to severe disease. So once again, highlighting that we're really not doing an adequate job with our current regimens. And why are these patients dissatisfied? First, as we all know, they have persistent symptoms despite the therapies we're prescribing. In addition, they are often discontinuing medications due to side effects. And also, which is really unique, and we know this as clinicians, they have this persistent fear or anxiety regarding disease flares, right? And so that's just highlighting the fact that we're not able to put these patients into remission successfully. So this is a really important paper from Lisa Ryder's group. And this really highlighted that multi-organ damage is common in myositis patients after a median of 5 years, even when we use, quote, standard of care therapies. And so this utilized a myositis damage index, and it really looks at what organs are damaged over that 5 years, despite center of excellence standard care. And you can see here that that damage is actually quite high. So 95% of patients with muscle damage, including atrophy, weakness, of course, but pulmonary, GI, cardiovascular, skin, et cetera. So, and again, this is despite standard of care therapy. So of course, I'm particularly interested in the skin, and I just want to highlight that of course we know that cutaneous dermatomyositis is a major therapeutic challenge in these patients. And I love this study from one of my mentors, Dave Fiorentino at Stanford, because this showed that even at Stanford, again, a tertiary care center known for its expertise in myositis, only 14% of dermatomyositis patients achieve clinical remission of skin disease after a year of aggressive multimodal therapy. And also, even patients on IVIG had no association with clinical remission, right? So again, what we're doing even in centers of excellence are not putting our patients into remission. And I want you to remember that number of 14%, because later on I will remind you that this study was able to achieve a 44% clinical remission at a year based on these parameters, so essentially 3 times standard of care therapy. So Rohit already aligned us on really what this molecule is, but I just want to kind of highlight this again, why I think this is so important, because this is really a mechanistic-driven trial, right? This agent was selected for dermatomyositis specifically based on a mechanism that should work for this disease, because we're able to target not only type 1 interferon, but also type 2, and then the interleukins 6, 10, 12, and 23. And another thing for those of you who, of course, follow the broader rheumatology literature, I want to remind you that this TYK2 inhibition is different than deucravacitinib, which is an allosteric inhibitor. This actually is targeting the active molecule. So we're getting both JAK1 and TYK2 via the non-allosteric pathway, which I think is very relevant in dermatomyositis. So thankfully now I don't have to go through all of the details of the VALOR study with you, but I want to make a few key points. So Rohit already alluded to the fact that these patients needed not only muscle disease, but also active skin disease. So this is really crucial and really makes this study different than most of the myositis studies we have. In addition, this is very important in my opinion. You did not have to have a myositis-specific antibody for enrollment. And of course, this is crucial because we know that depending on the laboratory our clinicians are using, 20 to 40%, even more, do not have an antibody. And we need this to be reflective of real life, right? We need to not only be able to get our patients who don't have a myositis-specific antibody into trials, but we need them to ultimately be able to receive drug. So I think this is very, very important, and it was one of the reasons I was really happy that we were able to enroll this cohort into this study. In addition, I think something that Rohit mentioned that I want to spend a little more time focusing on is the fact that this population of 241 patients was highly reflective of who we see in real world in our clinics. So the fact that they allowed patients with a history of malignancy, the fact that a high percentage of patients, which we'll go into, had active cardiovascular risk factors, which we shouldn't be surprised about because the vast majority of them are on systemic corticosteroids. The fact that advanced age patients were allowed, the fact that 20% of patients had concomitant interstitial lung disease. This is really reflective of who we're seeing in our clinics of our myositis patients. So I think that's extremely important. And then I just want to also highlight this forced corticosteroid taper, right? So this is very important because this truly allows us to differentiate the drug effect compared to that, quote, standard background therapy. And again, what Rohit showed you, and I'll highlight in the skin as well, is after those steroids are tapered, the patients actually do better. That delta actually gets larger. And so that really highlights the impact of the therapy. So when we think about skin disease, I want you to kind of follow down this chart with me for those things that are highlighted in light blue, because I want to highlight the skin impact. So if we look at our first blue line, we're going to look at our mean CDASI activity score, and that's right around 20. So this is strongly moderate skin disease at the median, even though patients only had to have a CDASI of 6 or more to enroll. Okay, so this is, impressive skin disease. And if we look at our IGA, over 60% of patients had moderate or severe skin disease activity. And then I'm going to level set because we think about itch or pruritus all the time in dermatology, but some of my colleagues aren't used to thinking about itch scores every day. But the mean peak pruritus NRS, or numerical rating score, an average of 4 puts you in moderate itch. And again, I want to remind you this is, of course, an average. And so we have some patients who enrolled who had bad muscle disease and milder skin disease, and that brings that median peak pruritus score down a bit. But later I'm going to show you those who had traditionally higher itch scores and how those patients did. Then we're going to look at Skindex 16 data, which is a validated quality of life measure in skin. And then I want to highlight again, these patients had a traditional past therapeutic history and current therapeutic history. So when we look below at the bottom, a high percentage of patients, 3/4, were on at least 2 current medications for their dermatomyositis. And notice that 1/4 of the patients had previously been on intravenous immunoglobulin. And again, I know we already reminded ourselves of this, but 3/4 of patients were on active systemic corticosteroids. All right, so if Rohit's favorite slide was the TIS slide, I love that slide too, but this is my favorite slide, right? So here's our CDASI activity score, which really is the best validated measure we have developed by Vicki Wirth, which really allows us to assess how our patient's skin disease is doing in a very validated and controlled way. And again, what do I want you to take home from here? Look at this, by 4 weeks, we've already hit statistical significance, right? That's amazing with skin disease and dermatomyositis. We do not get that from systemic steroids. even in high doses, right? Even in a milligram per kilogram of systemic steroids. So by 4 weeks, we have statistical significance, and this is maintained and, of course, even improved by 52 weeks of treatment. And then even more importantly, on the right, this delta gets larger in the patients who have systemic corticosteroids, and you can see here that double the patients are on less than 2.5 milligrams of steroids at 12 months in the brepocitinib 30 group, and over double of the patients are on no steroids at 12 months in the brepocitinib 30 group, the 30 milligrams group. All right, so now we're gonna think about that clinical remission, and thankfully in skin disease we sort of do, because of Dave Fiorentino, have this definition of clinical remission from that manuscript I already demonstrated to you. Again, reminder that that was 14% at 52 weeks in a tertiary expert center of myositis. And so what is this graph showing us? This is showing us patients with moderate to severe skin disease, so a CDASI of at least 14, and then we're going to try to achieve clinical remission, which is less than or equal to 5. So that's a really low CDASI, right? Like that's a very high threshold, and that's why it's clinical remission. And here you can see over double the patients hit clinical remission of skin disease at a year of therapy on brepocitinib compared to placebo. And again, about 3 times as many as that Stanford cohort. All right, so here's another slide that's vying for my favorite, because of course, itch tortures our patients, right? We know that itch is one of the most profound impacts on our patients with dermatomyositis. Even the scalp itch alone is traumatic to our patients. And what I want to highlight here again is something that I'm not even able to see with systemic corticosteroids. So here we're looking at patients who had at least a peak pruritus score of 4 at baseline. So these are our moderate and severe itch patients, okay? So this doesn't include patients that just had mild itch. And so if you look at those moderate to severe patients, look at that incredibly impressive change in the first 4 weeks, right? So again, this just is highlighting the rapidity of onset of action of this therapy, and then you get additional improvement out to 52 weeks. And then on the right, we're looking at achievement of a peak pruritus numerical rating score of less than or equal to 1, which is a very high bar. You know, this is a similar bar that we're looking at in dermatology in our atopic dermatitis trials, for example. And again, 2 times as high of a response in brepocitinib 30 milligrams compared to placebo. So this is just really impactful how much this is improving our patients' itch and therefore quality of life. All right, so once again, I'm going to kind of level set on what this validated measure is. This is the Skindex 16. This is a validated patient-reported outcome we use in pretty much every dermatology study, atopic dermatitis, psoriasis, et cetera. And it has 3 domains. We're looking at the emotional, functional, and symptom or symptomatic domains. And so just to give you a flavor of what types of things this is looking at, it's really how much the skin itches and burns, how much the skin results in feelings of embarrassment, depression, lack of desire to be with others, et cetera. And again, this is a validated measure used in all dermatology trials. So what I want to highlight here is when we look at our minimal clinically important difference, again, brepocitinib 30 meets that by 4 weeks. And that's just not something we see in our skin disease trials. It's just very impactful that we're seeing it so early, and of course maintained out to a year with just highly impressive separation from placebo. So of course, we love looking at images of our patients and how they're doing. And this is a patient who actually received brepocitinib 15 milligrams, who had failed intravenous immunoglobulin and multiple other prior therapies, who essentially has complete resolution of her eruption by 52 weeks. And notice she's even having early improvement of her damage. Here's another patient showing improvement of a holster at week 12, and then complete resolution by week 52. And here's a patient with more severe, including ulcerative skin disease, demonstrating resolution by week 52. So again, just highly impactful on skin disease. So let's come back to thinking about whether this is generalizable to a real-world dermatomyositis population. And I alluded to this before, but I was really grateful when I was trying to enroll for this study that I could enroll sort of who I'm used to seeing who has dermatomyositis, right? This is really important. So 14% of patients in this trial had a prior history of neoplasm, all right? And this is very unusual for myositis studies. Often these patients are excluded. This is very important. If you are enrolling for any trial, right, lots of patients have a history of malignancy, and we need to make sure we can get these patients the therapies that will get their disease better. 20% of patients, as I mentioned, had active interstitial lung disease. These patients weren't excluded, thankfully. And then let's think about cardiovascular risk factors, because as I alluded to at the beginning, we expect our patients with dermatomyositis to have cardiovascular risk factors because of ongoing disease activity and the inflammatory milieu, but also because of their background therapies, in particular systemic corticosteroids. So 2/3 of patients had one active cardiovascular risk factor, 1/3 of patients had 2 or more, and 17% actually had 3 or more baseline risk factors. So I think this is really important when we move on and think about our safety data, because as Rohit mentioned, the safety data is very clean, despite the fact that these patients were allowed in the study, reflective of our real-world dermatomyositis patients. So I'm just gonna highlight a few things from the safety data, because I know Rohit already alluded to some of these. So when we think about this, this was very important that at 52 weeks, so again, a long study, right, a long placebo-controlled period, the only thing that was higher in the brepocitinib group directionally was infections. And again, of course, keep in mind that many of these patients were on 2 or more background therapies, and 80% were on systemic corticosteroids as well. Thankfully, this did not prevent these patients from completing the trial, and the vast majority were able to remain on their brepocitinib. Now, interestingly, when we think about relevant side effects, the only clots in the study were seen in the placebo group. The only malignancies in the study were seen in the placebo group. I think that's really impactful to think about over a year period. And when we think about what happened in the placebo group, this shouldn't surprise us, because these adverse events are what happened in our dermatomyositis patients, based on their systemic inflammation and their background therapies, including systemic corticosteroids. So myocardial injury, pulmonary embolism, malignancy. Okay, so these are important safety data, and I think are really reflective of the fact that ideally, with brepocitinib, we're improving some of this background inflammatory milieu, as well as reducing the background systemic corticosteroid potential complications. So let's talk a little bit about systemic corticosteroids and what we know, all right? We know from Rohit's group and others that systemic corticosteroids increase major complications in our myositis cohorts. And just if we look at this graph, we think this is sort of how most myositis patients are treated. They get systemic corticosteroids, they do a little better. Later on, they have a disease flare, they get more systemic corticosteroids. Lots of them stay on low-dose systemic corticosteroids. But I want to highlight here, even in the second point from this study, that even low dose of 5 milligrams or less a day causes cumulative harm in our patients. We know this, right? So not only should we be trying to steroid spare, we should actually be trying to steroid avoid. I think that's very, very important. And it's important not only because our patients report adverse outcomes, but because we know when we look at steroid side effects that these are highly impactful in our myositis cohorts. So let's look at who got how much steroids in this trial, right? So on the left, what we're going to look at is the fact that we know patients were able to achieve more steroid sparing if they were on brepocitinib compared to placebo. And we've seen this data already, but essentially twice as many patients were able to get to 2.5 milligrams or less on brepocitinib 30 milligrams, and twice as many were able to get off of steroids completely. And if you look on the right, you can see that even in this trial, which is a very controlled way, that we had a decreased overall steroid burden in the patients who received brepocitinib. This would obviously be increased if we were able to give an agent like this earlier on. And then again, I have been alluding to this, but sometimes we forget that even though our colleagues feel comfortable with systemic corticosteroids because we've been using them for decades, many of the side effects that we fear, systemic corticosteroids are our worst enemy, right? So if we look at malignancy, look at these incident rates. It's much higher for systemic corticosteroids than the JAK inhibitor class in general, for example. And when we look down these, I want to highlight that brepocitinib falls below or within the incident rate bars for all of these outcomes. And for the vast majority of them, systemic corticosteroids are, again, the worst offender. So what I would argue is what we finally are coming to is what I've sort of been hoping for, right, for the last 2 decades. As you care for more and more patients, you think, I'm not really getting these patients where they need to be with standard of care therapies. There's an efficacy gap, right? We're allowing patients to just do good enough, right? To have ongoing disease activity, to have comorbidities and side effects, not only from their disease, but from these, quote, standard of care therapies that we're giving them. So what do I hope for? I hope that we're able to move towards using mechanistically driven, appropriate and effective therapies earlier for our patients, not only to steroid spare, but also to steroid avoid. And again, I just want to thank the investigators and the patients who participated in this trial. I often say, like, we know the current state of myositis when our patients who are sick are willing to enroll in a 52-week placebo-controlled study. That just really highlights the fact that we haven't moved the needle enough in terms of our therapy. And then to have this study read out with robust outcomes on 10 primary endpoints has just really been phenomenal for me to see on behalf of those patients. So thank you so much for your attention, and I look forward to answering your questions with my colleagues in just a minute. Colleagues, are you going to come on up?
Well, I'm glad that you are ushering them forward. So first of all, I just want to thank Rohit and Ruth Ann so much. Come on up for that really wonderful appraisal of the data and taking us through not just the study design, but the efficacy outcomes and the safety findings contextualized in this patient population. At this time, we're going to invite some of the investigators and leads of this trial to the stage. It's a pleasure to be here at Gcom and have all of these leaders in the room together. And we're going to take the next 40, 45 minutes to query them and get their insight not just on this study, but where they see the myositis landscape going. So I'm going to let them introduce themselves in just a moment. My name is Katerina Shaw. I'm a boarded dermatologist. I run the Rheum Derm program at the Children's Hospital of Philadelphia, and I also happen to be a part of the medical team at Priovant. So I'm going to hand it over to Julie, and we'll just go down the line.
Good morning. Good morning. My name is Julie Pack. I'm an associate professor of medicine in the Division of Rheumatology at Johns Hopkins. I'm the co-director and director of clinical trials at the Myositis Center.
Hello again. I'm going to pass it down the road.
Rohit Agarwal, a rheumatologist from University of Pittsburgh.
Raquel Marques, a rheumatologist in pediatric rheumatology from Lisbon Academical Medical Center.
Yasmin Bauer-Ventura, I'm a rheumatologist at the University of Chicago.
Great. And again, I just want to point out these are all investigators of the trial and played a really key role early on in the design of the trial, so we're really delighted and lucky to have them here. So I'm actually going to kick it off with you, Julie, and ask, in your current practice, where do you feel the greatest gaps remain in achieving meaningful disease control for your dermatomyositis patients?
I think that's a really good question because I ask myself that all the time because I'm seeing these patients who are more refractory because we're a tertiary referral center. But I think number one, it would be that these patients, when we see them, they're more refractory and they're already on medications. And what I usually see is that the patient's skin tends to respond to treatment. And then when I see them as a rheumatologist, it's their muscle disease that needs to be treated. But over time, what happens is the muscle gets better, right, after you treat it with medications, including potentially IVIG, but then you're left with the skin that initially looked like it improved, but then it doesn't, it continues to be more active and continues to flare. So the big question in my mind with that type of clinical vignette in a patient who responds initially with skin, muscle improves, and then you're left with more refractory skin that continues to flare, then the question I have is, what can I use from the beginning that actually could treat skin and muscle very well? And I think this drug could potentially do that from the beginning, because I don't have to do this step-up therapy where I'm giving these patients an oral immunosuppressant and then adding IVIG and then potentially adding rituximab. I feel like we do that a lot in the US to treat, dermatomyositis who tends to be refractory. But if I can use a drug from the beginning that I know works mechanistically and can work very quickly within 4 weeks, potentially as you saw in the data, then I think I could potentially reach to this drug even earlier. So I think this is going to be a big paradigm shift for our patients with dermatomyositis, because we can actually say that we can use a drug that's targeted for their disease, and it can work very quickly and also have a durable response. So I think that would be the answer to that question. But I do want to also, the caveat is this trial also requires that a patient be on at least one background immunosuppressant. So I think initially, I would think that we would want to add this drug to oral background immunosuppressant. But over time, I think you're going to see different, combinations of therapy. Yeah.
I just want to add one comment, perhaps, maybe two. Sorry, I often have a lot of comments. The first is, I think as someone who gets a lot of referrals, skin or muscle, I think the biggest challenge is most of the patients aren't adequately treated, right? And so I think that is a big challenge. Often they have recurrent disease flares, they have some residual weakness or some residual skin disease, and as Rohit alluded to, there's many fields of rheumatology, neuromuscular, dermatology where we treat to prevent damage, and we're just not there yet with myositis, right? Like, in what rheumatoid arthritis patient or in what psoriatic arthritis patient are we okay just giving them steroids and methotrexate anymore? We're not, right? We're moving forward and using a more targeted therapy to prevent damage, and I think that's where we need to go in with myositis. And I would just add to Julie's last point, I think, these trials are going to require standard background therapy, but because the trial has a patient on a concomitant immunosuppressive or immunomodulatory therapy, for me would not mean I would need that in real world experience, right? And the reason for that is when I get a better agent, I move on and use the better agent, and I don't make the patient get the steroid or other immunomodulatory/immunosuppressive comorbidities and side effects if I can accomplish what I need to with a more rapid acting medicine with higher efficacy.
I want to add something else that I think it is a big gap, is also the timing to achieve some improvement. When a patient comes to us, again, we are biased, right? We are seeing refractory patients. But when a patient comes to us, we are starting a new agent, and we are hanging that patient for 10 weeks, 12 weeks to start seeing improvement. And then after that, when there is some improvement, it's like, well, let's wait 3 more months to see how far we can go with this therapy. And then 6 months have passed that the patient is still having active disease. So I want to remind everyone that the therapies that we have, they can support our patients somehow, partially, but again, the amount of time that it takes for our patients to start seeing significant benefit, it may be 6 months or later. So I think the gap is not only how much we're able to achieve with these drugs, but also how much time we are taking to provide that partial relief. And I think this is really frustrating, and by the time the patients come to us, they have already gone through this many iterations of therapy. We are talking about a few years, right, trying different agents. So that 4-week improvement, particularly in skin, I think it is something that we have not seen before.
Definitely. No, I really appreciate those insights. Kind of along those lines, Raquel, I was kind of curious to get your input on Right now in your current practice, which manifestations of dermatomyositis do you actually find the most difficult to control with existing therapies?
Thank you for that question. Well, for me, there are mainly two. One is the cutaneous involvement for sure. And one of the reasons is because, in my opinion, the skin involvement is still underestimated comparing with other, I'm sorry, that's from yesterday. Comparing with the muscle disease and other manifestations, I think the skin is still underestimating. And for that reason, it's really difficult sometimes from one perspective to be recognized on time. And the second thing is because although we have amazing tools that are validated, I think, and they are really nice to access our patients from the skin perspective, I think their widespread use is not so implemented like, for instance, the muscle scores. And this is another reason why I think sometimes the skin involvement is underestimated, because it's not measured in a best way. And then, because in my opinion, from the skin involvement, there are two particular skin involvement types that are really difficult to treat, especially for someone that looks after JDM as well, which is the calcinosis and the ulceration. They are extremely difficult to treat. It's sometimes the first manifestation of the disease, and with those ones we have to be in particular attention. And another manifestation of dermatomyositis that for me is really hard is the lung involvement, especially the interstitial lung disease, because as we know, we have those rapidly progressive ones, especially the ones associated with the MDA5 positives, and it's already difficult to treat the lung involvement itself because it's aggressive and is associated with a high morbidity and mortality. But it's even worse in situations where the disease is not early recognized. So even when we early recognize the disease, it's not completely sure that we will be lucky with the treatment. But for those subtypes of dermatomyositis, especially the amyopathic ones, or the ones that don't have the most typical clinical features, they are really hard to treat. And for me, these are the manifestations that for me are really hard to treat, and the ones that make me more anxious when I see a patient, either an adult or a children.
I want to add something
Yep,
here.
please.
Made a great argument for lung because that's the highest cause of mortality. Made a great argument for skin because it's very symptomatic. I'm going to make an argument for muscle. Time is muscle. When patients don't get better over months to years, they're losing a muscle mass on every month basis, slowly but steadily. And that's why getting early treatment, getting more effective treatment up front rather than playing with steroid and non-infective immune suppressive drugs is so important. Because once you lose the muscle, once you have developed muscle atrophy, fibrofatty replacement, it's no coming back. So I think that's quite important. And what do our patients get disability from? The patients complain of not being able to get up from a toilet seat, can't go up the stairs. They can't do activities of daily living. They have difficulty wearing their clothes or shower, lifting a gallon of milk. That's the kind of difficulty our patients have. And when we treat a patient after 5 years with an effective treatment versus 1 year after treatment is a huge difference. Those patients, even if they go into so-called remission after 5 years or 10 years of treatment, they're not going to be the same. They're going to complain of muscle pain. They're going to complain of muscle fatigue. They're going to still complain of disability because time is muscle. Over the last 10 years, they have lost significant muscle. We cut down the disease with effective treatment after 10 years, but the 10 years of muscle loss is not going to come back. That's why early institution of more targeted, effective treatment rather than playing with non-effective immune suppression and steroid is so key.
Yeah.
Oh,
We all want to talk.
since we're talking about muscle, I just want to add, I was like very surprised with the results about the HAC-DI. I knew that improved, but if you look at the components that Rohit presented, the muscle pain was very important for the patients with dermatomyositis. And you know, we talk about how like our DM patients get fasciitis, and that could contribute to pain. But overall, we do see pain with myositis, and that improves significantly. And I think that tells us what's important to the patient. In addition to the muscle weakness, muscle pain is very important for patients to have that resolved so they can continue into, making improvements in their quality of life. So I think that's also important, yeah.
I also want to mention something. I think this is finally a change in paradigm on how we rheumatologists need to start working. We need to work as oncologists. A patient gets diagnosed with dermatomyositis or other types of myositis, and we need to achieve remission as soon as possible. We need to work with an induction therapy kind of framework, because that's the only way we have to prevent the chronic, the long-term damage that will impact our patients, not only functionally, but also with respect to other issues, malignancy, and metabolic disease. I want to again highlight the muscle here. We forget that the muscle is the biggest reservoir for glucose metabolism, for good lipid metabolism. This is the reason why our patients die still, right? It is cardiovascular disease. And we lose track of those issues. So it is really important that we change. I invite our myositis community to start changing the way we approach disease. Instead of doing a stepwise approach in treating these patients, when these patients are diagnosed, we need to be aggressive, we need to be prompt at providing remission as soon as possible.
Maybe a last comment. So, you mentioned like JDM, and I know we're not talking about JDM on label here, but what I think is important is the pediatric rheumatologists have really done an excellent job of showing that if you treat early, you get less damage, right? And this is in particular important with calcinosis, right? We know we treat them early, they don't get calcinosis. In fact, I see much less calcinosis in 2026 than I did in 2020, right? 2025, because we just treat those kids differently now. But what I want to highlight is how are we doing this differently is early, more aggressive therapy, including with off-label JAK inhibition in children, right? And when we mention pulmonary disease, what have we moved from in our Mass General Brigham? We've moved from slow-acting onset agents that were just traditional, we would use them, and again, reaching for off-label JAK inhibition, right? So I think this concept of rapidity of onset and mechanistic-based treatment is very, very important. And one other thing I think may be surprising to some people is for patients who come in with even erythrodermic skin disease, so like full body skin disease, I don't give them any systemic corticosteroids if they don't have muscle involvement at all. 0 milligrams, right? I give them a rapid acting agent that will fix their skin disease over the long term. And this is what I would want to use brepocitinib for in the skin patients. But I would argue that we also give off-label JAK inhibition to muscle patients early to reduce or avoid systemic corticosteroids depending on the severity of their muscle disease. And I think that is where the field is going, and we just need to get there more rapidly.
No, those are all very valuable comments, yeah. So Yasmin, you were a part of this, for years, so I'm just kind of curious, now coming to the end, what aspects of Valor really resonated with you from a clinical decision-making perspective?
As Ruth Ann has pointed out during her presentation, the inclusion criteria was developed in a way that really reflected the patients that we see in practice. I think this is the first thing, was the ability to be able to read these results and say, I have these patients in clinic. These are not very exclusive cases that really differ from our practice. So I think this is really number one, was the ability to transfer these results to my practice, and I'm sure that my practice is similar to many of you here in the audience as well. And number two was the ability to see patients feeling better during the clinical trial. I was able to see this firsthand, and seeing these patients who have had disease for 5, 7, 10 years, and they have migrated through all possible treatments that we have available. And for the first time, seeing patients who have been with me for so long saying, I finally feel better. I'm finally able to function in a level that I don't remember I was able to function. So I think the inclusivity, the ability to reproduce these results to my practice, and was very satisfying to see patients not only, improving the MMT or improving CDASI, but actually reporting joining this clinical trial or finally getting the open label extension of the clinical trial was the best thing I have done for my disease since my diagnosis.
Our center was also part of this trial, and I completely agree with Yasmin. I think we have participated in several clinical trials, and this one really reflects real-life patients. And that's really reassuring for us as clinicians, because we know the patients that we are selecting are actually the patients that we see on the daily practice. So we don't need an extra effort to actually collect patients to this trial. And the other thing is really how patients improved. And you could actually see we have patients from this trial today on the skin workshop, and they are amazing, and they just said that to us. I mean, I've never felt so well in our life, and this is really, really reassuring.
One more thing. One day, one dose, one tablet a day, right? We are talking about patients who have been hours hanging on a stretcher getting IVIG, or having 3 tablets, they're this big, of mycophenolate twice a day and having diarrhea every other day. Is a 1 tablet once a day. This is huge for our patients who have been used to all kinds of therapies and whose lives have been limited because of the therapies they have gotten.
I just wanted to share a comment from my patient. She said, came one day and said, "Doctor, I think I'm cured." I'm like, there's no such thing like cured in autoimmune disease, but okay, I'll take that.
Well, Rohit, actually along those lines, since you have the mic, how do you interpret these rates of the proposed low disease activity and of remission in VALOR? And I know you and the wonderful work of MCTC has really moved this field forward into actually looking at this as part of therapeutic goal and therapeutic decision making. So I'm just kind of curious to get your insight on that.
Yeah, so the whole discussion about remission and low disease activity is very new. This is not how we thought the field will move. When we developed the outcome measure 10 years ago, we thought we will develop minimal outcome, minimal threshold, and that's where we're going to be in 10 years later. Forget about moderate and major, and forget about, there's no point of doing a remission on low disease criteria. So that's what the field has moved towards. We are discussing, actively developing remission and low disease criteria because we feel the acute need of developing remission and low disease criteria. So I think from the standpoint is, first we need to develop validated outcome measures of remission and low disease criteria, which is data-driven, patient-driven, meaningful for patients, but also consensus-driven. And then also the point here is there are remission and low disease criteria is a state. It's different from a response criteria. It's being in a state. You can have a minimal response and be in remission. You can have a major response and be not in remission. So it's a state. It's a totally different concept. And also there are 2 or 3 different types of remission and low disease criteria. First is getting into a remission state on treatment, on active treatment, whatever it is, got me into low disease or remission. Second is getting on remission or low disease off or less than 5 milligrams of steroids. So you stay on your standard immune suppression, but you get down on steroids of 5 or less 5 milligrams. And third would be getting remission off treatment. Ultimate target would be eventually, if the patient is treated for a year, you have had enough immune suppression that eventually will lead to patients being off treatment remission. So these are the 3 states of remission. But what was really amazing to see the data is we thought could be a remission definition based on the data, because you're at the mercy of the data, what you've collected, turned out to be about 20-25% patient achieved their remission within a year. Again, needs to be still validated. But what are the remission rates on a standard immune suppression, multiple immune suppression? This is the data from our centers. If we take 10 years, if I treat patients on an average for 10 years, with multiple immune suppression, about 4 to 5 treatments cycled over the time, with significant amount of steroid, in a center who is the most advanced center in treating dermatomyositis, you get about 10 to 20% of so-called remission rate. So 10 years of long-term multiple drug treatment, long-term 10-year steroid, then you are able to say, okay, 10 to 20% of those patients may get into remission on drug. So that's the difference we're talking about. Here you're talking about remission on patients in 1 year, less than 5 milligrams of prednisone, with achieving patient global and physician global less than 1. And that's the discussion. So I'm really, really happy to see the results of that magnitude.
Yeah, right. Ruth Ann, I would love to get your insight into pending approval. Where do you envision brepocitinib fitting into your overall treatment algorithm?
Okay, that's a great question, and I kind of alluded to some of this earlier, which is that I feel very comfortable reaching for a therapy that's rapid acting and most effective and bypassing some of what some folks would consider standard of care, because I feel very comfortable with this based on the other diseases in autoimmune skin disease and autoimmune rheumatic diseases that I've been treating over the last 2 decades. One thing that I probably should have mentioned earlier, but I think is important, is I think this combination of JAK plus TIC is like very purposely being used in dermatomyositis here, and I think adding the TIC actually matters. And the reason why I want to mention that is what I thought was really cool about this trial is they actually allowed patients who'd failed a traditional JAK inhibitor into the trial. That's amazing, right? And then actually those patients did well on brepocitinib. So I think this is very important because I do already reach for off-label JAK inhibition because it's what I can get my hands on, but I think there's mechanistic reasoning and data from the trial that support that this particular agent will be even better than the experience we have off-label with JAK inhibition. And so this kind of is coming back to your question in that in my therapeutic ladder, if I'm gonna say I have a skin-only patient, I'm never gonna give them systemic steroids, right? And I'm gonna reach for the most effective, mechanistically driven, rapid-acting therapy. So this would essentially be like #1 on my list. Boom. I don't give them methotrexate, which works in 1/3 of patients, maybe, and not putting them into remission, just getting them a little better. I'm going to bypass mycophenolate, which again helps, 1/3 to 50% of my patients, and they still have active skin disease. It's that good enough concept, right? And then I would say in my muscle disease patients, again, I'm already at the point where off-label I can start at a much lower dose of steroid. I can maybe avoid pulses. There's various things I can do to reduce that corticosteroid burden. And then I would argue the thing that we've been learning the most about recently is how to use a targeted therapy like this for patients who have, of course, lung disease, right? Like probably actually the most important to use a rapid-acting agent in of all the phenotypes, right? And having that comfort level to reach for an agent that mechanistically should work and that patient's declining and I need to stop that decline. So I would argue that I will use this in all 3 of those phenotypes and I will feel very comfortable using it without making them fail a bunch of things for 3 to 6 months.
Mm-hmm. Great. Julie, kind of along the lines of what Ruth Ann was talking about, are there any particular patient profiles where you consider brepocitinib particularly attractive?
Yeah, I think, what Ruth Ann was talking about, I think is, in derm, in rheum, we are always like giving a lot of steroids, but I think we really need to learn from our colleagues where, especially in dermatology, like Ruth Ann, who's an expert, about trying to get the skin under remission, when I heard this, without any steroids is phenomenal. I don't think we think about that as rheumatologists, but what drug can potentially do that is a JAK-TIC inhibitor like Brepo, because it works so quickly. And I thought it kind of blew my mind away when she told me about this and how she's approaching her treatment for skin-predominant patients. So I think definitely this is a no-brainer. Like we've been using off-label JAKs anyways for skin-predominant disease, but I'd love to see what the results shown about the muscle disease. Now it takes a little bit longer to work compared to the skin. If you looked at the MMT8, right, around 16 to 18 weeks. But overall, the TIS in the data showed that it also improved really rapidly, in terms of all the components. So I think anyone who has skin and muscle disease, I would certainly think about using this drug. And if they had potentially, more skin predominant disease, I would totally feel comfortable using it, in isolation, as monotherapy potentially. I think if they have muscle disease and they're very weak, of course, we're gonna probably reach to a little bit of steroids to get that under control. But I think time will tell. Maybe we won't even need the steroids, even for muscle. It depends. I think it really depends.
Yeah.
Maybe just a follow-up on that. I'm sure you all have had circumstances where you've had to avoid a bunch of steroids. Like I have multiple brittle diabetics who end up in the hospital if you give them a bunch of steroids, right? Like I see one of my amazing fellows in the audience where we literally had to co-manage a patient with endocrine, and they were like, you do not give this patient 1 milligram of steroid. So what do you give those patients ethically? You give them an off-label JAK inhibitor, even for muscle disease monotherapy, right? This agent will work better than that. But like I've learned from these patients that you can do it, right? You don't have to dump 60 milligrams of oral prednisone into all of these patients to get efficacy. And I think the fact that the TIS responds very quickly, like 4 weeks till statistical significance, emphasizes that. Now, I'm not saying that every patient you're going to be able to avoid steroid in, but I think it's really important that we don't say that you could use this early for only skin patients. I think that's actually the wrong message. 100% for skin, it could be used early as monotherapy, right? But for muscle patients, right, what are all our bad outcomes from? They're from the steroids that we're giving the patients, right? So that is actually where we need to move the needle, just like we have in RA, just like we have in our other diseases. And so I just would encourage that we really think about that early on in muscle disease.
I want to add on, again, I learned from Ruth Ann the idea of treating dermatomyositis with less or no steroids, and I have been doing this for 2 years with no detriment in how the treatment has worked for my patients. So thank you for bringing this up. So again, this clinical trial is provocative because again, it brings you different perspectives that the myositis community has not yet adopted. Our friends in vasculitis have done that. And again, oncology, again, treat it to target as soon as possible, aggressively upfront. And the second thing is that steroids have really become kind of like a cane for us, particularly rheumatologists. I think we were trained to use steroids, but just used to, we don't need that much. And again, our vasculitis colleagues have been at the forefront of challenging that concept. Again, I want to invite the myositis community to think about myositis in a different way. Let's treat it aggressively, and let's try to entertain treatment with less steroids or no steroids at all, because again, I think the way our community is moving is towards that goal. So again, I think we are just used to do things, and we need to challenge these concepts that came with our training.
So I think, I just want to take a step back here. I mean, maybe in our myositis center at Hopkins, we see very sick patients. If you have a patient coming into the hospital who has diaphragmatic weakness and is very weak, I will still reach for steroids, right? So I think it depends on you have to think dermatomyositis is very heterogeneous. So it depends on the spectrum of where you're seeing these patients, right? If someone's coming to the hospital and they're very weak, I think as rheumatologists, we still need to have some access to the steroids, and we're going to use it. But I agree with Ruth Ann and Yasmin that if you're seeing a real-world patient in the clinic, yes, of course, I will want to avoid steroids. But I agree that I think the field is running towards, and I think finally we're running towards trying to do more effective therapies, almost like an induction therapy, and I see that in other trials as well, so hopefully that will change the paradigm.
Yeah, I also want to add to what Julie's saying and what you are saying is two different spectrum. So we do need steroids. I won't say we don't need steroid, but we need to use steroid as an abortive agent, as an agent when you have a patient who's an acutely decompensating patient like Julie's describing, you do need to use steroid, but we need to use it as steroid like a rheumatoid flare. When a patient with rheumatoid, and many of you are rheumatologists, comes to your office with rip-roaring RA activity, you put them on Enbrel, methotrexate, whatever, but you give them a month of steroid. That's a type of steroid use you're talking about to kind of stabilize it, because nothing still works in days. And that does give relief to the muscle patient at least, or joint aspects or the lung aspects. So I don't want to say that zero steroid, at least for those, what Julie's talking about, decompensating patient who needs to be hospitalized. We need to use steroid as what it is meant for, short-term stabilizer. And then a month of steroid is good enough, and then you put them on a more effective targeted treatment so the long-term outcomes can be achieved. That's the kind of a middle game. Now, in the skin, I can understand why you don't want to use steroid. One, it doesn't work, but also, you still may have a little bit more time. But an acutely decompensating patient with a lung disease or acute arthritis with severe muscle weakness of CK of 10,000, you use steroid, but very sparingly would be the goal in going in future. Like we have 10 treatment approved for RA, we still use steroid appropriately. We don't use steroid appropriately in myositis. In fact, if you talk about methotrexate, Celsep, all of these drugs that we think work, try trying those drugs without any steroid for muscle or lung or other manifestation. It doesn't work as good. So what you're doing is really adding on to the steroid by combining immune suppression, increasing the risk of infection, cardiovascular, and all other problems. And you feel good because patient temporarily got better, patient feels good, but we're not looking at what you're really exchanging two diseases, treating the acute disease for a long-term disease.
No, these are all incredibly important points. I want to come back. We've spent a lot of time, going through our efficacy outcomes, the rapidity of onset of action. Ruth Ann, you spent, considerable time in your talk talking about the safety data. But I just kind of wanted to circle back to this and see how you interpret those safety findings, particularly in the context of, the risks that you've seen in your own practice from standard therapies.
Yeah, that's a great question. So I feel like the nice thing here is we have a 52-week placebo-controlled study. Not nice for the patients who had to enter it, unfortunately, but what's required for myositis. But the fact that it's a year gives us a really nice safety data. And again, I know I mentioned this, but I think the safety data was very clean, right? So it's essentially, there was an increased risk of infection in the Brepo 30 group. Keep in mind, most of those patients were on two or more concomitant background therapies, so really on multimodal immunomodulatory/immunosuppressive therapy. And I think it's very important, in particular, to make our colleagues feel comfortable reaching for this agent, that there were no clots, there were no malignancies in the treatment group, only in the placebo group. One other thing I like to highlight, because many of my rheum, derma, neuromuscular colleagues aren't aware yet, is the increasing use of the JAK inhibitor class in the oncology world. I think this is actually really important and relevant. So I often, I got my early experience with this because I essentially sit next to Dana-Farber, right? So most of I work very closely with the Farber, and the head of clotting at Dana-Farber actually doesn't believe that JAK inhibitors cause clotting based on the data. But what was even more interesting, right, is when I have dermatomyositis patients who have severe ongoing disease, and I need to reach for a JAK inhibitor, even in those patients who have ongoing active malignancy, my oncology colleagues are always fine with that. They're like, that's fine, we use these for cancers, it's totally fine. So what's interesting, what's new, is they're actually using JAK inhibition now in patients who have active cancer and are on immunotherapy, and their immunotherapy stops working, right? So in other words, that patient would then die. Now they're giving them a JAK inhibitor in various certain cancers to reprime the immune system to re-respond to their immunotherapy. So literally, using a JAK inhibitor in active oncology patients who now can't respond as well to immunotherapy. And the reason why I mention that, right, is that just gives you the future of where we're going with the use of JAK inhibitors, right? Not only are we not worried that they're causing malignancy, but we're using them in patients with active cancer to allow them to have better treatment outcomes. So, I think this data is very, very clean, and I think it should be really reassuring, even in the background. And I think that's even more important, right? These are myositis patients. They got a lot of cardiovascular risk factors. They've been on a lot of steroids. The fact that they allowed us to enroll patients who have had a history of malignancy, I think, is very, very important for this cohort. So I was really pleased to see the safety data.
That's great. All right, we've had really wonderful discussion. I would like to end with a question. I'm going to start with Yasmin, and I welcome the rest of the panelists to join in. But once therapies capable of achieving deeper disease control, in this case brepocitinib, become available, how do you see a potential shift in goals and expectations for our dermatomyositis patients?
At this moment, because we need to abide to the data that we have from the clinical trial, and again, I'm going to mention to Well, first of all, I'm going to be very happy to transition all my off-label high-dose JAK inhibitors to brepocitinib because I am like really pushing the button there. But I'll mention to our patients that I'm expecting that at least almost 70% of them will achieve, again, moderate improvement. And this has been shown to be significant in terms of quality of life improvement, right? So those are the expectations. And I'll mention to them, hey, for the first time, we are seeing a significant response that is really quick and a medication that has been shown to help with steroid sparing capacity, right? So all those things need to be mentioned related to the data that we have available. Real world data will tell us how will impact our patients in the long run. So I'm excited to see the next 1, 2, 3 years with, again, hopefully on-label use of brepocitinib. But those are the expectations. But the main thing that I want to mention to the patients is what Ruth Ann has mentioned. And this is exactly what I saw as being the site investigator for the trial, is that, hey, it is well tolerated. Most important, even though we saw more infections, those patients were not more likely to get off the trial. So this is something I will definitely bring up front to my patients. This is a medication that is easy to take, has been shown to be beneficial for all these reasons, and most importantly, it seems to be very well tolerated. I think this will be the forefront of my conversations with my patients because they have been really tired of all the side effects they have experienced with all kinds of agents. The safety profile for me, it is the really important message here that we have to take.
So, in my opinion, I agree what Yasmin was saying. One of the things that I would like to highlight as well is the way how you take this medication is oral. They are used to the biologics, having intravenous or the subcutaneous methotrexate, and this is also a very important point apart from what Yasmin was saying, which I also agree. And I'm really looking forward, and I'm putting a step ahead, is to look forward to use this drug also in juvenile dermatomyositis, which you also need also a lot of having this drug available for the children.
So I think I will slightly differ. I think the main thing for me is what's the real world evidence? And I think that's going to come in next Gcom, hopefully. Because, you know, first of all, the clinical trial looks very clean. There is no signal of any safety concern. I totally agree with that. But for me, long-term safety is quite important. If you look at the JAK results of the trial early on, there was no safety signal in the early JAK results. It was tofacitinib post-marketing results that showed there was some signal. Now, obviously, that has been now refuted, but it's a different point. Point here is we need to look at the long-term real-world data. Clinical trial is excellent, that's a start, but going long-term safety and tolerability and outcome data is key. If I want to continue giving this drug 5 years from now, I want to look at the 5-year data. Trial gets you there, we get an indication. The other point here is we're also going to have an honest conversation with our patients. This is about shared decision making. When you have a patient in front of you, there are many other considerations other than just the trial results. Trial results helps you in that conversation, but there are many other factors. There are patient preference factors. There are patient cost factors. There are insurance factors. There are many other aspects that goes around it. What have they failed in past? What have they tried? So what I'm saying is, I think we have a great drug, and we need to use that upfront, but that as an upfront as a really strong option to be used for our patients. But the final answer would come on multiple factors. Specifically, I would say in US and other countries, insurance and costs drive a lot of those factors. And I think we need to see how it plays in terms of the insurance before I could put that as a first line. Because I can put everybody on Brepo first line, but if it's not going to get approved, sorry, I won't be able to do that. So I think this needs to be evolved. We need to see how it plays out. First, we got the trial. That's number one. Second, we need to achieve the second most critical outcome here is FDA approval and the label. That's quite important. And then further other regulatory agency, and then post-trial phase 4 results.
So I'm going to challenge convention here. So, because we're talking about long-term safety, I showed you guys the long-term safety of systemic corticosteroids. I showed you the incidence rates. They're way worse than the other medications we use, and yet we're dumping them in everybody every day, all the time, right? So I only highlight this, right? So, the box warning from tofacitinib does come from the oral surveillance study, which of course has been, picked apart and refuted because of course it's JAK versus TNF. There wasn't equal risk factors in the stratified populations. We could talk about this all day, but we have, many, many years of data of other JAK inhibitors in other diseases that would not have resulted in a boxed warning. So I think the challenge here is we can all point to this and then decide that we're going to dig in our heels and not use an agent early, but steroids are worse every single day, right? And so we just can't rest on our laurels and say just because we've been doing it for a zillion decades, we're gonna keep doing what we've always been doing. They're the worst agent. They have worse malignancy, they have worse cardiac events, they have worse, and isn't going to be my take-home point, but I was as little steroids as possible, if not zero, if possible, of course not in a decompensating patient, and the tolerability and the ease kind of get me across the finish line, but the high efficacy and reduced toxicity from other therapies would be what drives my decision.
So I guess I'm the last
The
person.
last word. Yeah.
So I'm going to speak a very simple onset. Number two is, yes, IVIG works great, and it is FDA approved, so I'm very hoping that this brepo will be FDA approved. But IVIG, it's an infusion therapy. It takes them days to be on it. And I'm sorry, that drug has been around for the 1950s. It works well, but we want modern targeted therapy. I can tell them, well, how does IVIG work? What do we tell our patient? We don't really know how it works, but this drug, we know how it works. To prove it, the interferon signal is dampened with this drug. It was
And they'll hang out for a couple of minutes.
welcome. There are still few people coming in, so we're just waiting for a couple of 1 or 2 more minutes to get started. Okay, good to go, I guess. Well, welcome to this Arginex Symposium. Today, in this symposium, we'll be talking about diagnostic tools to therapeutic targets using autoantibodies as the next chapter in myositis management. I request all of you to scan this QR code because there are questions throughout the symposium, and also to post any questions that you may have at the end of the session. We'll have a panel discussion where we can take your questions. So all the questions are supposed to be posted using the QR code. So please take a moment to scan the QR code so that you can answer the questions during the symposium, but also ask your own questions based on the data. Okay, I'm gonna take the ticker. Okay, so we'll start now. Here's the disclaimer. This presentation is sponsored by Arginex. So what are the key objectives of this symposium? Number one is we want to highlight our evolving understanding of autoantibodies and immune mechanisms in various subtypes of myositis. We want to explore how emerging treatment approaches that targets autoantibodies could address a long-standing unmet need in management of myositis across multiple subtypes, and also review the biology, immunobiology of IgG recycling and how potential approaches that reduce these pathogenic autoantibodies through FcRn-targeted approaches. My name is Rohit Agarwal. I'm a rheumatologist at University of Pittsburgh, a long-standing interest in myositis, and I have with me Dr. Angela Rosenbaum, who will be going back and forth throughout the symposium in this presentation. Here are my disclosures. So here's the agenda. So what we have planned for this symposium is somewhat unique and different. We will talk about a patient's story, a patient's journey, from all the way the patient presentation to diagnosis to the management that the patient has gone through, eventually talking about FcRn-targeted therapies. And also, what we will do is we will have patient story, and then we will share our thoughts about the data or the agenda. So just the last housekeeping, this is a housekeeping slide. Again, if those of you just came in and has not scanned in the QR code, my request is to please scan in QR code, because there are some interesting questions we would like to get your opinion on throughout the lecture, and also then you can post the questions based on the data that we will be presenting today. Can I give a second or two to see everybody got the... Okay, so first polling question, this is just a test. This is your GK test. So opened in 1966, what was the first bridge over River Tejo in Lisbon? Yeah, we're going to have some fun. Please scan the QR code and answer. This is going to be an interesting session. Wow, most people getting it right. Well, they're now cheating because I think we need to give some time before we show our responses because, all right, great. So now here's a real question, which is, which statement best reflects your current view and understanding on the role of autoantibodies in the pathogenesis of myositis? Option number one, autoantibodies play some role in pathogenesis of myositis. Autoantibodies are key driver in pathogenesis of myositis. Autoantibodies are not involved in pathogenesis of myositis, and I'm unsure about the role of autoantibodies in the pathogenesis of myositis. All right, so we have 58% some role and 43% key role, key driver. Excellent. All right, 60-40. More response coming in. Okay. So we'll ask this question again at the end of this symposium, so see if we can change your mind here. So I'm going to invite Dr. Rosenbaum to start the story, the chapter 1 of this story. Thank you.
Meet John Smith, a middle-aged male who is a farm owner and has a history of statin use. John has a past medical history of hypertension and type 2 diabetes. He has a physically demanding occupation with no other relevant family history. His current medications include a statin, ACE inhibitor, anti-diabetic medications, vitamin D supplementation, and over-the-counter pain medications as needed for general aches and pains. In May 2021, John started complaining of general weakness, making it difficult to perform daily tasks, such as lifting objects, for example, a gallon of milk, rising from a chair, and climbing stairs. Because of John's weakness, his primary care physician discontinued his statin therapy in June 2021. However, his muscle weakness continued to worsen. John's symptoms progressed to the point where he fell because he was unable to support his body weight, prompting an emergency department evaluation in November 2021, with a chief complaint of progressive proximal muscle weakness of the upper and lower extremities.
Okay, so this is the first part of our patient story. We will go on with that later and hopefully learn something. I'm now talking to you about the different subgroups of myositis. As you can see on the screen on the right side, we have different subgroups called dermatomyositis, the immune-mediated necrotizing myopathy, antisynthetase syndrome, and also overlap myositis. As you can see in the screen, most of them have, of course, proximal weakness. Some of them have skin involvement, but as you can see, they are quite different concerning the extramuscular involvement, clinical manifestations like interstitial lung disease, myocardial involvement, and even association with malignancies. So if you have a patient who has a dermatomyositis, he's much more likely to have a malignancy than, for example, patients with IMNM. And so therefore, it's a very distinct group of myositis patients and diseases, and therefore it is quite a burden for the patients depending on which muscular and which extramuscular involvement they have. As you can see here in the middle, of course, most of the patients have severe muscle weakness, but some of them have muscle pain, they have joint pain, and the problem for them is with the instability of their gait, they can also have falls, they can fractures, and of course they need orthopedic surgery. And combined with the pain that they have to manage, we often have medical interactions with the different treatments they need and also complications of the treatments. And if you look on the right side, you see that the extramuscular manifestation, like the lung disease or the cardiovascular damage, may also lead to death of the patient. And we have an increased burden of the association with malignancies and infections. If you see that patients have also dysphagia, there may be a risk of getting aspiration and therefore another pneumonia, infections, and more than a third of the myositis patients have an involvement of the pharyngeal muscles. So therefore, we have the problem that for now we have only the glucocorticoids and the glucocorticoid-sparing therapy as the ongoing medication. And the problem is that especially the muscle involvement leads a long-term therapy. So we can't resolve the myositis problem within weeks or months, and we need a medication that's ongoing for several years. So for example, in Germany, we normally tell the patients, you have to be on the medication for 2 years at least, and then we can try to taper it down and look if you get a relapse or if the disease will be gone. So that can't be foreseen in every patient. So there is a need for glucocorticoid-sparing therapy or even more targeted therapies because almost 1/4 of the patients are on glucocorticoids even 1 year after getting the diagnosis. And right now, there is only one, which is IVIG, and all other recommendations are kind of spreading on the glucocorticoid level, and it's sparing therapies. So there is the need, because there is also this multisystemic involvement, that we cannot really control all of the symptoms of the disease, not the muscle symptoms, not the pain symptoms, and also not the extramuscular manifestations. And therefore, there is the problem that we really need some targeted therapies, and we try to show you some of the ongoing studies with a targeted therapy that is hopefully more specific than what we have so far. I'm handing over to my colleague, and you will see later.
So now we go to the second chapter of this patient's story.
As we return to John's story, after his emergency department evaluation in November 2021, he was admitted to the hospital for further diagnostic workup. His physical examination and functional test results confirmed proximal muscle weakness. John was unable to complete any repetitions in the 30-second sit-to-stand test and was only able to perform 2 repetitions in the 1-kilogram arm lift. The physician also noticed he had adopted a wider gait. Manual muscle testing revealed severe weakness in the hips, as well as mild weakness in the shoulders and arms. His labs showed markedly elevated creatine kinase peak. Serum tests were positive for ANA, negative for RF, and negative for SSA and B, and his myopathic EMG revealed normal nerve conduction. During John's hospital admission, a muscle MRI demonstrated multifocal edema and enhancement involving the anterior, medial, and posterior compartments of the right thigh, suggestive of inflammatory myositis. A biopsy of his left bicep revealed mild fiber size variability with scattered necrotizing and regenerating fibers and an absence of inflammatory infiltrates, consistent with a myotoxic necrotizing process. Physical examination, lab and imaging findings suggested immune-mediated necrotizing myopathy, confirmed by an anti-HMGCR positive serum test with ongoing CK elevation and progressive proximal muscle weakness.
So as we finish the next chapter in this patient's history, let's focus on autoantibodies in myositis. So this is a chart of myositis-specific autoantibody across various subtypes of myositis. This gives you an evolution of autoantibody discovery in myositis. As you see, we probably have the largest number of autoantibodies amongst any rheumatological disease. Now, why these myositis-specific autoantibodies are important? Well, they really represent a very unique clinical phenotype. They represent a unique clinical prognostic significance and many other things. But in terms of clinical phenotype, it helps, these autoantibody helps to understand what the patients are going to have in terms of organ manifestation, in terms of clinical features, whether they would have association with malignancy or not, and so on, whether they would have a high risk of interstitial lung disease, whether they would have a peripheral vascular system like Raynaud's, whether they're more likely to get arthritis or severe weakness, such as in case of patients with SRP and HMGCR antibody, are they high risk to get cardiovascular problems, dysphagia, and also antibodies that are associated with dermatological manifestation causing dermatomyositis as rash. So it really helps us when you get these antibodies results back in any myositis patient, you get a moment of aha, okay, now I know what this patient truly has, and I understand this phenotype, how this patient's history or journey is going to evolve. So you really talk about the pathogenic role of these autoantibodies. So these autoantibodies are not just phenotypic signature, not just a biomarker or prognostic significance. We also now having increasing evidence to suggest pathogenic role of these autoantibodies. These autoantibodies can cause myofiber function inhibition, can stimulate interferon alpha and beta, type 1 interferon, also can activate complement pathway, and also can lead to direct antigen inhibition across all the three major disease subtypes, which are IMNM, immune-mediated necrotizing myopathy, DM or dermatomyositis, and antisynthetase syndrome. Now, with that, up until now, we knew that autoantibodies are important, have clearly probably a role in pathogenesis. But Dr. Mammon and group has recently shown to really give a more concrete proof of the pathogenic role of these autoantibodies. So these autoantibodies are now internalized in the muscle cell to inhibit the target autoantigen. For example, HMGCR antibody inhibits the target antigen, dysfunction the HMGCR, leads to lipid droplet accumulation and myofiber necrosis, leading to muscle necrosis and weakness in this patient, as demonstrated by multiple series of experiments done by Dr. Mammon et al. And again, this slide is just showing you this image is just showing you how the cytoplasmic localization of anti-HMGCR antibody within the human myofiber, again, really demonstrating direct pathogenic role of these autoantibodies. Now, I want to review a little bit about FcRn, role of FcRn in recycling of immunoglobulins. So what happens are immunoglobulins are taken up by lysosomes to really lead to the immunoglobulin degradation. But if the immunoglobulins get bound to FcRn receptor, they get protected within the lysosome. The unbound immunoglobulins, IgG, get destroyed or degraded, but the FcRn-bound immunoglobulin gets protected and get recycled back into the circulation such that 90% of our immunoglobulins are recycled. We will talk about the role of how we can use FcRn receptor mechanism to see how we can decrease these pathogenic autoantibodies. And also, these autoantibodies have been shown, multiple studies have shown that these autoantibodies can also be a good biomarker of disease activity, as shown in one of these studies, where 71 patients with IMNM showed correlation with anti-HMGCR antibody with MMT8 and muscle disease VAS. But also, other autoantibodies such as Jo1, TIF1, MI2 has been shown to correlate with ongoing disease activity in rituximab in myositis study. So as we understand, what's the utility of MSA in myositis management? Well, number one, it really confirms the diagnosis. Now, I understand not everybody has MSA positivity, so there are a lot of patients with MSA negativity. But when you have MSA positivity, it really, really nails the diagnosis. Number two, it represents a unique clinical phenotype, so you know what are you going to deal with in this particular patient. It helps you to understand what organ manifestation is going to happen. It helps you to understand the prognosis of the patient. And also, we could, if we had really good sensitive assay, use autoantibodies as a biomarker. And now what we're talking about is the next step in the autoantibody journey, which is pathogenic role of these autoantibodies and how we can target these autoantibodies to relieve our patients from the misery that they have to endure. So now this is a question, this is a trick question. Let's see how, I want to get your opinion on this. As a disease-specific autoantibody, an autoimmune mechanism are increasingly identified and recognized in myositis. Is it still appropriate to use idiopathic inflammatory myopathy or call inflammatory myopathies as idiopathic? As you know, the formal term of myositis is idiopathic inflammatory myopathy, IAM. Should we still use IAM as a terminology now that we know the autoimmunity is really the reason for these inflammatory myopathies? So let's see what your vote is. No, we should not be, okay, 35 yes, sorry. And many are unsure, which is, I think, makes sense. It's very interesting to see how the opinion of the House is so divided. Now, there are advantages and disadvantages. Scientifically, you would say we should change the name. The idiopathic should go. We know it's autoimmune mediated. We can call it autoimmune something, or maybe just inflammatory myopathies, or add autoimmune disease mediated inflammatory myopathy. But there is also a loss. There's a disadvantage of the years of knowledge gain and the familiarity, not for people in the room here, because you will adopt very easily to the new name. The problem is for general physician, general rheumatologist, general specialist. They may not know or adapt to the new terminology, and there is a risk of that knowledge or understanding lost when you change the name. So there's a risk of changing the name to more scientifically appropriate term. So that's why it's an interesting question to see how many. I see almost 50% people in favor, not 80, 90%. And there are people who are, so 50% people are not in favor. And then about another 50% are unsure or in favor. So it's an interesting discussion, and we've been having a lot of discussion about the terminology that we use in myositis and how that's going to evolve in next few years. And Dr. Ingrid Lundberg and myself are trying to lead revision of classification criteria, so it will all play in that project. So over to Dr. Rosenbaum again for the next chapter.
Right now, we are actually turning the page because, as I told you before, we have this broad idea of treating the patients with glucocorticoids. And now we are trying to get an impression if there is some more specific therapy option. So,
turning the page, John was initially prescribed low-dose glucocorticoids for his muscle pain and weakness. However, his weakness worsened and he experienced severe pain, necessitating hospital evaluation for 5 days in February 2022. John received a 5-day course of IVIG and was escalated to daily high-dose glucocorticoids. He subsequently received multiple immunosuppressive drugs. Despite aggressive immunosuppression, CK values continued to be poorly managed, and John's weakness persisted. After being discharged from the hospital, he continued to receive low-dose glucocorticoids daily. Yet his CK remained elevated in the 3,000 to 4,000 units per litre range. He continued to struggle in daily life, to the extent that he was unable to get up from a chair or toilet seat without help from his partner. He trialled multiple steroid-sparing agents over subsequent years, all of which were discontinued due to lack of efficacy or adverse reactions, such as a superficial venous thrombosis he developed in his lower right leg while receiving IVIG.
So as you can see, John Smith is not really happy right now. I'm going on with the recommendations we have so far. I just talked about them some minutes before. And as you can see here, for example, in Germany, we have the recommendation that we treat the patients differently depending on how severe the skeletal muscle inflammation and the skin manifestation is. So for example, for the skin manifestations in dermatomyositis, a lot of patients receive IVIG because it helps the skin much better than the other medication. And for the muscle inflammation, it's rather the other way around. So we really need glucocorticoids and immunosuppressants to get a long-term improvement of muscle strength. So there are people who are completely fine with that therapy, and they can be rescued within 1 or 2 years and get finally to their old strength again. But of course, they're still staged ahead. Of course, we have exercise, we have physical therapy, but all of this is not really targeted, and especially since we know that there is this antibody-related problem in the different manifestations on the muscles, on the skin, and other organs, we try to look into some better options. I brought a slide to you. This is not from a myositis trial, but I thought it was quite interesting because it's some data that was published 2 years ago in myasthenia gravis. And you see there, the colleagues looked at the cause of discontinuation of the long-standing immunosuppressants. And on the left side, you see that due to adverse event, azathioprine was quite a bad choice because a lot of people didn't want to be on that medication because they had severe side effects. And on the right side, you see that there was also discontinuation due to lack of efficacy. So this is another disease, but still maybe show that these long-standing medications may have several drawbacks, and so we need something more targeted for the patients. If we look now in the immune production of the immunoglobulins that we just talked about them before. Of course, we can try to target this production of immunoglobulins at different sites. We have the B cell, which is turned into a plasmablast, and then the plasma cell producing autoantibodies. And of course, we can go to different parts of this process, for example, CD20 blocker or CD19 blocking of the B cell itself, or maybe later downstream look that we get rid of all these autoantibodies. So there are different therapeutic options which are already functioning in other autoimmune diseases like myasthenia gravis and, for example, CIDP. So myositis is the third autoimmune antibodies in the neuromuscular section that is trying to get a targeted therapy on these autoantibodies. So going back, what you just heard about the recycling mechanism of IgG in our bodies, we have efgartigimod alpha, which is a specific FcRn blocker. It is highlighted here in yellow, and it has a very high affinity to the FcRn receptor. So as we heard before, IgG is kind of saved to the recycling process if it binds to the FcRn receptor. But now if you give efgartigimod alpha to the body, it kind of blocks the FcRn receptor, and IgG is no longer possible to bind there. And when we look further down, we can then see with the yellow dot for efgartigimod alpha again, it is blocking the FcRn receptor, so we have much more free IgG, and the free IgG is not going to be recycled but degraded in the endosome. So therefore, if you get efgartigimod alpha in action, you have then a much lower IgG level, and this IgG includes the autoantibodies. Of course, you have to look for the IgG levels so that the immunosystem is not completely degraded down. But of course, you can also get rid of autoantibodies, which is the proposed cause of action of this medication. So now I'm going to give you some ideas on the ongoing studies. We have the Alkivia studies, which is in phase 2 and 3 right now. This is a double-blind, placebo-controlled trial in myositis, so different subforms of myositis, including IMNM and also dermatomyositis. And we have the phase 2 study with a duration of 24 weeks, which was proposed for the safety, and patients were receiving efgartigimod alpha subcutaneously every week, and of course their ongoing background therapy compared to placebo. In the phase 3 study, which is ongoing for 52 weeks, we have the same regimen, efgartigimod subcutaneously every week, plus the background therapy, of course, a stable background therapy compared to placebo. Both of the studies are optionally followed by an open-label extension, and we are on this symposium getting some information on the endpoints and on the levels of action on the phase 2 study presented by year. So as you see, what endpoints were chosen in the Alkivia study, in both of them, the phase 2 and the phase 3, there was a composite TIS score adapted. And the TIS score is kind of a conclusion of several scores that were evaluated in the studies. It includes the most abnormal muscle enzyme, depending on which of is the highest elevated muscle enzyme in the patient, then the extramuscular global assessment, and also the MMT-8 score for the muscle strength, and of course some of the patient-reported outcomes. And this was combined together, so we have this TIS score ranging from 0 to 100 points, meaning that if you have an improvement of around 20 points, that's a mild improvement for the patient, and 40 is moderate, and more than 60 is a major improvement for the patient. So if we go on and look what the phase 2 study already showed us, you can see here the primary endpoint, this TIS score, was elevated by around 50 points in the efgartigimod alpha group. You can see it at week 24 in the green line. And of course, the placebo group also improved, but only with about 35 points. And if you just look at the muscle strength, the MMT8 score, which ranges from 0 for a completely plegic patient to 140, we see an improvement in the placebo group of about 7.6 points, and in the efgartigimod group, we have a higher improvement of about 15 points. So of course, we also saw improvement in the patient reported outcomes, which is down there on the left side of the screen. So we hope that these phase 2 endpoint that could be shown in a rather small group of patients can be now evaluated and having a look on in the ongoing phase 3 study, including 179 patients worldwide. So for the future of this study implications and the impact, of course, we hope that this is one of the first targeted therapies like we have already seen in myasthenia gravis, also in CIDP, where this FcRn blocking action with efgartigimod is already used. We see, as we have experienced with the real-world data in these diseases, that the medication is well tolerated. There is no safety concern with a high impact on the patients. And we hope, of course, that even for myositis, the lowering of these IgG autoantibodies will give us a chance to really read out specifically that the patient can improve and the damage of the organs and of the muscle and of the skin may getting released. So on the Alkivia phase 2 study is now ongoing in the phase 3, but the last summer in July, the enrollment was already full. So therefore, we have all of the 179 patients there waiting for evaluation during 2026. So we hope that this will also be a personalized treatment that we can have in myositis compared to the other neuromuscular autoimmune diseases where it's already working very fast, very early in the disease progress, and with a high targeting the really disease manifestation without having these very broad spectrum of side effects that we know so far. So now I think we can go on and open the book with question and answers. I'll come over to you.
So if you can please scan the QR code. We have the last chapter of this patient's journey that we're going to show. But in the meantime, if you can scan the QR code and post any questions that you may have about the data that has been shown.
Moving forward, there is a two-step management plan for John. First, the risks and benefits of alternative therapy options were discussed with John, including an alkylating agent and investigational clinical trials. Second, John will continue structured physical therapy, focusing on proximal strength and function. John has several options for the next chapter of his treatment journey. What other options could be considered for a patient like John?
So we'll take questions now, right? Okay, so we have some questions. I'm going to try to take the first question here. Is the difference in TIS really clinically significant? And it's quite modest. That's a great question. Actually, it turns out there is some published and some unpublished data that if you have a TIS of 20 as a threshold, and it's not really clinically meaningful, but when you get to a TIS of 25 to 30, you start to see significant clinically meaningful differences. So the threshold of TIS 20 is now no longer being used. That's why we are moving to moderate TIS of TIS 40 as an outcome. In terms of continuous total improvement score difference, if you have a score difference, a delta of 10 or more is clinically meaningful. If you have delta of obviously anything more than 10, then it becomes higher and higher clinically meaningful. So the idea here is in this study, it's a small study, it's a proof of concept phase 2 study, then it did show statistically significant results. That's what you do phase 2 for. You do phase 3 for is mainly to a larger study to see the final results in a longer study. So we are waiting for a phase 3 results hopefully this year.
Wow, there are a lot of questions coming in. I'm trying just to pick one of the older ones. How do you think VYVGART is positioned in the myositis landscape, especially when compared to brepocitinib, which was presented today, and as well as CAR T-cell? Well, this is a very interesting question. Of course, we are expecting different modes of action. As I told you, you can go more downstream, you can go more upstream. And of course, we are hoping that we are getting a broader landscape to maybe we are able to not only say this is a myositis, we can specifically make a turnaround of the autoantibodies. We don't know yet if different subgroups of myositis may need different ways of turning the treatment on. So I think we don't know yet, but of course, as we know from the other diseases like myasthenia, like CIDP, we know that the action is quite fast actually in these diseases, so maybe we can kind of wait until the steroid-sparing therapy, which is ongoing for several months until we have the mode of action really increased, then maybe we can use these new antibody-targeted treatment earlier or maybe ongoing. We don't know yet.
Yeah, I think it's a really interesting question. I think the landscape of myositis is going to evolve in the next several years as more and more treatment becomes available. But there are a few points I want to make. For each disease subtype, we would require, for really managing 90% plus patient of each disease subtype, would require 3 to 5 treatment per disease subtype. We've learned that from rheumatoid arthritis, what we have a single phenotype in rheumatoid arthritis, yet sometimes 10 drugs that are approved become less, and we have to really look for newer therapies in rheumatoid arthritis. The second point, I think, is the way it's going to evolve is you're going to have the traditional treatment because of the cost and insurance and other reason. But we need to use those treatment less and less and without steroid so that we don't keep damaging our patient long-term with the steroid. If that fails, then you come to the targeted therapy. Within the targeted therapy, for dermatomyositis, you may have now more choices. But for other subtypes, for example, FcRn receptor inhibition may work for dermato, but also could work for IMNM and antisynthetase. So you may have a broader indication with FcRn receptor. We also know from IVIG data that it also works in IMNM to some extent. So I think the middle targeted therapy is going to be the mainstay of the treatment. You may have to fail the traditional immune suppression for a month or 3 months to prove to the insurance or the cost benefit, so that the very mild phenotype patient may get better with just methotrexate or CellCept, and those get weeded out. But then bulk of the patient, I think, in myositis, you're going to have a shared decision-making, whether I put you on brepocitinib or IVIG or FcRn receptor. These are targeted therapies that are highly effective, steroid-sparing. Then somebody asked CAR T. The cellular therapy is going to be the next chapter. Not everybody is going to get taken care of. As you see, at best in a clinical trial, you're talking about 2/3 patient. So that last 1/3 refractory patients, after failing 1 or 2 targeted therapy, would go to cellular therapies. And that's going to be that 30 to 40% is the estimate where they might need cellular therapies. Or they may improve to the targeted therapy for a year or 2. Eventually, that mechanism fails, and they may flare, and now may need the more advanced or cellular therapies. So I think we need multiple therapy per disease phenotype. So just having a couple of therapies is not going to be enough. We need to continue our research and explore more.
So we have also some very short questions that can be answered quite easily. One of them is, efgartigimod only lowers levels of pathogenic IgG. No, that's not true.
That's not true.
It levels down all of the IgG, so therefore, of course, you have to check it before you give the medication and look that it's not too low, because otherwise there may be some interference with immunogenicity.
So, Dr. Rosenbaum, I have a question on this particular question for you because you have a lot of experience in giving FcRn receptor inhibition in neurology, of course. When you give these drugs, do you check their baseline immunoglobulin
Yes, we
routinely?
do that always. Yeah.
And is there a level below which you would not give FcRn receptor inhibition?
Well, we are talking about a level of 2, something like that, right now, where we are getting kind of cautious and then rather switching to another.
So less than 2 grams?
Yeah.
That's quite low to begin with. But otherwise, if the level is 4 or 5, that's not an issue.
You'll start with that.
Very nice. Thank you.
So there is another, do we have data on seronegative patients?
That's a great question. We do, so far the data I'm going to present on Thursday, so you have to wait for the final answer on that. But this is a phase 2 study. We have very small number of patients with autoantibody negative data. So that data has to be looked very cautiously. When you only have 10 patients with antibody negativity, what does that data mean? So I think I would be very cautious and wait for phase 3 results to really look at the antibody positive versus negative data.
So there's another great question. MSAs are not exclusively positive in myositis. We have confirmed positive also settings recently shown in rheumatoid arthritis, etc. What do you think about that?
So there are false positive MSAs, and also some of the rheumatoid arthritis who may have anti-synthetic antibody, do they really have rheumatoid arthritis or truly have anti-synthetic antibody? The work done by several colleagues here have shown many patients may actually present with arthritis in anti-synthetic syndrome later on discovered to have muscle and lung involvement. And also there's a problem of false positive antibody. Our antibodies are very important, but we also have a problem of measurement. We need better tools to measure them reliably and also quantifying them. Right now we do more qualitative testing. Hopefully quantitative testing would help in future.
Okay, so there is another question on anti-HMGCR antibodies,
So
relying on our case.
So there are many patients with positive anti-HMGCR antibody who are not taking atorvastatin and present only with pain without objective muscle weakness. This raises an important question. How should this antibody be interpreted and clinically assessed? So what would you do for a patient who is antibody positive, come with muscle pain, but no objective weakness?
Well, we would do an extensive neurological workup with EMG and looking if there is really only pain or if there is maybe a subtle involvement, just beginning of a weakness or something. And the last option would be to really do a muscle biopsy after MRI of the muscle, like you did in John Smith case. And we would really look for it. But if there is no objective of really having a myositis here, we would not treat him.
Excellent. So you look for subclinical evidence, and if there is subclinical evidence, you would believe that the patient would eventually develop a clinical disease, so it's better to treat early.
Yeah.
Okay. How can autoantibody testing be improved or done earlier for these patients to improve therapeutic decision? Tough question. So autoantibody testing, as I alluded, it's tough. Sometimes we get really good assays, high titer positive antibodies, we are sure. Sometimes we get borderline results, we're not sure and not helpful. I think we need to do better testing of autoantibody. There is actually a symposium today on autoantibody outcome measure and outcome measures in the evening, and there's a group who's really trying to figure out what do, how do we interpret these autoantibody, for which autoantibody, what method is the best, and so on. So I think this is an evolving landscape. We do need to have better testing for autoantibodies for sure.
Okay.
Oh, no.
I think the time has run out.
Oh, the time has run out.
So whenever you have more questions, just feel free to come up. But the session is closed now. Thank you so much for coming, hearing the story of John Smith and all the stuff around with the antibodies.
Yes.
And
just some key takeaway, as you very well know, that autoantibodies play a central role in pathogenesis. Thanks to a lot of researchers here in this room. Targeting FcRn maybe is an under investigation, but it could be a potential treatment approach to block FcRn-mediated immunoglobulin recycling, which eventually could turn into drugs like efgartigimod, which is engineered IgG1 antibody FC fragment with high affinity to FcRn, blocking the FcRn resulting in decrease in pathogenic autoantibody, eventually resulting in improvement of these patients. And the last question here is this is the question that came up in earlier. Which statement now best reflects your current view on the role of autoantibodies in pathogenesis of myositis? Do you believe that autoantibodies play some role in pathogenesis of myositis, or do you believe it plays a key driver, or they are not involved, or you're not sure? So now we got to about 50-50, or maybe. All right, interesting. All right, probably a little better. We were able to convince about 4% of patients, maybe 1%. All right, so about 50-50. Well, thank you very much for coming and listening, and we'll close the symposium. Your feedback is important. If you could scan and give us some feedback on how this symposium went, it would be really helpful. Thank you very much.
Hello, everyone. Hello, everyone. I hope you are enjoying our conference so far. We have now the pleasure of opening the session about the classification and epidemiology of myositis. We will start with the talk of Professor Hector Chinoy, who is a professor of rheumatology and neuromuscular disease at the University of Manchester, where he co-leads a program of myositis research and is honorary consultant rheumatologist at Salford Royal Hospital, where he leads a tertiary neuromuscular clinic and recruits patients to clinical trials. The floor is yours. Thank you.
Thank you, Eduardo. These are my disclosures. I'm going to start off with a slide I presented yesterday because I just thought this is really interesting to try and quantify the number of patients that we're actually dealing with in Europe and in the US. And you'll see here that the UK is officially separate from the EU here. But the estimate is that there's approximately 160,000 patients with myositis in the US and in Europe total. And if we break this down, we're talking roughly about 60,000 dermatomyositis patients in Europe, roughly about 10,000 antisynthetase patients, and roughly about 16,000 IMNM patients in Europe. And why is this important? Well, it's important for us to know how many patients are coming to see us according to our population, according to the population we serve in our clinics, and also what the spread is of the disease, which will then dictate the treatments that we're going to use, especially if the treatments prove to be expensive. So IIM myositis is very rare compared to other autoimmune diseases. And thank you for Thomas Kuh for providing the figure on the right. And if we look at the comparative incidence of IIM, we'll see how rare it is compared to its more common autoimmune neighbors, including scleroderma, lupus, etc. And I think we're coming into a rich time in myositis now where we're actually going to have some treatments available for this rare disease. Again, this is one of Thomas's figures, and incidence can differ globally according to the subtypes of myositis that we see. So in my practice, in contrast to what the experience is in Japan and in China, and we see comparatively more IBM patients compared to patients, what's seen in the Indian subcontinent, for example. But it's very difficult to find this sort of data in particular countries. And there's hypotheses as to why certain myositis subtypes could be more common, for example, proximity to fresh water. Okay, so let's just go through a few areas that can cause a bit of confusion. Lovely picture where we're now subdividing what was previously known as PM and DM into something that's much more meaningful now. So now we've got the subtypes of IBM, IMNM. We further subdivide the subtypes by bolting on the antibodies and also the manifestations. So really we want to know, we don't just want to know how common IIM is, we want to know how common these different subtypes are. And so we're moving from this PM-DM focused case approach to a more subtype-aware population epidemiology. This is something that Matt Parker published with us when he was in Manchester for a year. So Matt's a rheumatologist in Sydney now. And we took the previous classification, well, it was actually the up-to-date EULAR-ACR classification, and then we applied a more expert clinician subgroup analysis. And you can see how the diseases, what we call the diseases change according to whether you use a classification or whether what terminology are we actually using in clinical practice. This is a plot from Latika Gupta and Sarah Tansley's paper where concurrent line blot was performed in the local center in Lucknow and the same samples were subject to immunoprecipitation. So what you might call an MSA in using one sample becomes a very different result if you then apply a more research level assay. So this leads to further confusion as to your assumption of what your local lab has told you the antibody result actually becomes something quite different. Another area for confusion is statin-associated myotoxicity. And I think the audience here know how to differentiate this from an antibody-mediated HMGCR-positive IMNM. However, our compatriots in general medicine may not, and so these patients may end up getting coded as IMNM, who actually don't have an autoimmune-mediated process, but have just had a toxicity relating to statins, which is self-limiting upon cessation of the drug. And then we've got James Lilliker's chameleons. So I love this term, and this is actually IIM masquerading as non-IIM. And we can see this with IMNM, where you may not see any inflammation on a biopsy, and then the diagnosis only becomes as weakness, but with normal MR features or a lack of inflammation on biopsies. And of course, we know about extramuscular antisynthetase syndrome as well. So anyway, the topic of this talk is supposed to be, is the incidence of myositis increasing? And recent cohort studies suggest that indeed it could be. And is this due to a true growth in exposure-linked disease, or is it just we're better at identifying the patients or better at classifying, as I've already alluded to? Or could there be other explanations? Is there something in the ether that's causing a true increase in autoimmune-mediated disease? So the estimated overall incidence of IIM is 7.9 cases per million person years, with a prevalence of 14 per 100,000. But major outliers can be driven by pure ICD-coded studies. So the heat map here, I think the first thing to say is look at all the gray areas globally. And the gray areas are where there just simply hasn't been any incidence studies done. So I think as a global IIM collective, we've got to do better at working out how common myositis is in Asia or Africa or Canada, for example. And then, I'm not naming names, sorry. But then we look at the red, that is the US, and we've not chosen red for any reason for the US there, but other than the fact that the incidence studies suggest that IIM is perhaps 6 times more common compared to Australia. So is that really a thing, or is it due to the way that the cases are captured? So then if we drill down into specific disease subtypes, and we specifically chose DM and IBM to focus on in this review because we thought that it's easier to capture and identify and code for these cases than the other IIM subtypes. So again, if we do a drill down into the relative incidence and prevalence, on the top left is the incidence of DM. So it's 2.9 per million person years in Australia, 3.7 in Turkey, 2.5 in South Korea, and 15.2 in the US. The prevalence figures on the right-hand side are even more stark, that it's about 2 per 100,000 people in Australia and 21 in the US. If you look at the IBM figures, on the bottom left, Scandinavia and Australia actually correlate very well together, but US is another outlier. And as the effect is slightly less attenuated for Australia and the US for IBM. So Estimates of rare disease are method sensitive, and as we've mentioned, they're distorted by changing classification criteria, inconsistent case identification, and reliance on administrative coding, which we might not be applying as clinicians, but there's other people within the hospital administration system who are defining the coding system. So one example was a US study published in 2023, the Kronzer study, where the overall adjusted incidence was 1.1 per 100,000 person years, and the prevalence was 13 per 100,000. So this correlates quite well with what I've shown you before. And the comment was that the administrative diagnostic codes perform poorly. So there was poor predictive value for validated DM where there was only one or more codes, which is slightly better where there was two or more codes for the patients, using a manual, underscoring the requirement for manual validation. So there's a number of studies which have suggested an increasing incidence over time. So there was a South Australian study of Tan et al. Showed that the annual incidence rose to a peak of 1.72 per 100,000 person years, and this was accounted for by increasing IBM incidence in the 2000s. So the second study, Parker, we published this. There was an increase from 1.36 to 2.14. OTA was a Japanese cohort where there was a doubling incidence of Tanimoto-defined disease, and Benderwald in Olmsted County, the US, showed that there was an increase of DM, but then this included amyopathic disease. There was low absolute numbers in the historical data set. Okay, so let's talk about my hometown. And just to clarify where Manchester is, in case you're not clear. So what Matt Parker did was we took our population of Salford and Greater Manchester, and these are effectively twin cities. On the left is Salford, and on the right is Greater Manchester. And in case you're not very sure about the geography, this is where our hospital is, Salford Royal. And whenever you mention Manchester, everyone always talks about the football clubs. So I've shown you where Old Trafford and the Etihad Stadium is. So now you know your geography, okay? And so we showed this year by year, there was an increasing incidence. And I mean, was there actually an increasing incidence in the city of Salford? But what we felt was there was this thing called a catch-up phenomenon. Cases that would have been missed 10 years ago are now being better identified. We're getting better at diagnosing the disease with diagnostics, genetics to exclude neuromuscular disease, antibody, the advent of antibody testing as well. Less patients being diagnosed with so-called seronegative disease. But then there's also this survivorship bias where we're still probably missing patients who would have rapidly deteriorated before they would have had a chance to have been captured in our clinic, patients who died before they actually present, or patients with cancer or respiratory failure. So if we compare our locally sourced figures, which was 2.14 per 100,000 person years, with actually a population-based study which was published with Patrick Gordon's team, and this was they published this in EULAR in 2023. They estimated that using nearly 15,000 incident IIM cases with a huge denominator of you're talking about 30-odd million cases. The incidence rate was 1.72 per 100,000 years. So they're not far off the locally sourced figures with case verification and the population-based figure. So I did go off on a bit of a tangent at this point because I just wanted to make the talk a bit more interesting for you. So I thought I'd just tell you about the origins of survivorship bias. So this comes from Wall's memorandum in World War II, where the US Air Force wanted to work out what it was about their aircraft and did they need to reinforce. And they analyzed the pattern of the bullet holes, okay? So what they identified was there was all these areas where the planes were shot. So they thought, okay, this is where we need to reinforce the planes so they don't get shot down. However, Wald said, no, this is wrong. You're looking in the wrong place. You need to do exactly the opposite, and you need to look at the areas where the planes didn't get shot, because these are the planes that we never recovered. So we're only looking at the planes that were actually recovered, but the ones that were not recovered were the ones that were really badly damaged, and they were the ones that were shot around the engines. So this is the classic example of survivorship bias. And those who are really interested, there's a whole mathematical formula. There's a 43-page PDF you can download from 1943, and just, yeah, knock yourself out. So other noteworthy mentions, there's immune checkpoint inhibitor myositis, which does, this is a new exposure-based ICI-treated adults, and they found that the incidence of ICI myotoxicity was 0.3 to 0.6% in this population. And the incidence at 6 months varied between 0.7 and 0.9%, with up to 7.1% specifically in patients with thymic cancer. So the question is, how are these patients coded in our data? And then incidence versus prevalence. And having done a couple of incidence studies, they're hard enough to be able to. So some of the clinical impression of more myositis might reflect we're getting good at accumulating our patients in our clinic. It could also be improved survival and longer follow-up as well. So the perceived disease growth is not identical to a true incidence, but there is an interaction with incidence and prevalence. This was a very interesting study from my colleagues in Leeds. And so Leeds is kilometers east of Rose. But what Dennis McGonigal's team did was they doggedly recorded the MDA5 status, and they really went to town with MDA5 testing with all of their COVID patients. So you can see that in 2020 and 2021, the number of MDA5 requests almost doubled. So they picked up more MDA5 positive cases. But actually, the percentage of positive cases based on the number of tests went up from 1.2 up to 4.8% in 2021. So they described this phenomenon called MIPC, MDA5 autoimmunity and interstitial pneumonitis, contemporaneous with the COVID-19 pandemic, which then seemed to go back down to baseline in 2022, despite increasing testing. So Thomas also looked at our incidence figures of HMGCR because we had an informal observation that we had double the number of cases in 2022. And you can see that on the left-hand row, left-hand column, cases would be captured, and then we calculated the annual incidence. And there was a little outlier for Western Australia in 2021 as well. But overall, we had very consistent figures for HMGCR, which averaged out at roughly just under 3 per million person years. So what next? So future studies should report incidence by clinical history rather than having this umbrella IIM coding, which we've previously used. So having prospective multinational registries with harmonized definitions will be much more useful for us as an IIM collective. And as a minimum, we should really be separating out our antibody, our clinical subtypes, and also paying attention to ICI-related myositis. So just to conclude, measured IIM incidence has increased in several modern, up-to-date studies, but the magnitude of change evolving over, better at picking up cases now. We're better at pigeonholing them into what the patient actually has. And we've got these exposure-linked entities, statins, ICI, cancer. So we're moving away from IIM coding. We want more ethnogeographic exposure-linked incidence studies. And now we need to know which subtypes arise, where, and due to which exposures. Thank you.
Thank you very much. We would like to open the floor for questions. While you think of questions, I would like to ask Professor Hector Chinoy, how do you think we can incorporate the new classification systems and still be able to compare results of new studies with studies that are historical?
I think this is a real challenge unless you've got access to the raw data from the historical data sets to retrospectively reclassify them in specific units, then it's possible.
There are no questions. I have a question as well. How do you think that this rising incidence has to do with the greater availability of autoantibody testing? And I'm thinking in particular, we see a lot of patients with ILD who get a panel and they have ILD with the myositis antibody. Is this then part of the spectrum, or should we exclude these patients? How would you approach that?
So there was a cross-sectional study done in the UK called UK Build, where roughly 1,000 cases were selected with ILD, and they were subject to serological testing at Bath. And it was found that roughly about 11% of these patients had a defined MSA. So I think it's capturing those patients as well. And so that's definitely relevant. And I think what I find interesting is we're seeing MDA5 now, but 20 years ago, what umbrella did MDA5 come under? What did we used to define MD as IIM spectrum, but now they are?
Mm-hmm.
Any other question? Thank you very much. Oh, look, Professor Lorenzo Cavagna. Okay.
Not a question, it's only a comment, because I remember that 20 years ago, at the beginning of my career, I was asked for a consultation in intensive care unit, and we had a young girl with rapidly progressive interstitial lung disease that was presenting with a pattern of an SIP endopy, and she was anti-ROF52 positive, high degree, but we had not anti-MDI5. 15 years later, we had the possibility to test the serum because I collected it, and she was anti-MDI5 positive. Without any skin lesions, is very, very wide. It's not limited to muscle, but we should consider a lot of other features. Stop.
And thank you, Lorenzo. And another really nice example is HMGCR. And the lovely index study from Andy Mammon and Lisa Christopher Stein, where they had their historical data available for IMNM, and they took the seronegative cases, and they were able to identify the HMGCR antibody in this hitherto undefined cohort. So an undefined IIM then becomes defined IIM and increases our case ascertainment.
Any other question? Thank you very much. Wonderful discussion.
So it's my honor to introduce Professor Cavagna, who is an expert in inflammatory myopathies with a focus on antisynthetase syndrome and MDA5 disease, combining extensive clinical experience with leading research activities. He currently serves as the European PI of the class projects and leads international collaborations advancing classification, research, and care in myositis. And today he will speak to us on performance of the new EULAR-ACR antisynthetase classification criteria. So thank you.
Thanks a lot. It's an honor for me to be here and with this speech. First of all, one statement. I love Canada, and we love Canada. So we are friends. So these are my disclosure, but my main disclosure is this one with all the friends that worked with us, with me and Reut, building the class project database. I want to say thank first of all to Reut, obviously, to Giovanni and to you, Edu, because your work was really precious and wonderful. And I want to say thanks also to other investigators that collected patients from every center around. But let's start with antisynthetase syndrome. You know very well that we have the classic triad that has been defined a lot of years ago, myositis, arthritis, arthralgia, and interstitial lung disease, and we have accompanying findings. Then we have the primary biomarkers, the antisynthetase antibodies, for sure, but we have other biomarkers, the anti-Rho52 that are present even in other conditions, not limited to myositis, not limited to antisynthetase syndrome. Also to consider the positivity for antinuclear antibodies with cytoplasmic positivity. This is very important when we are assessing a patient with the suspect of myositis and in particular of antisynthetase syndrome. Then we know very well that the disease is changing. The clinical spectrum time course of the disease is heterogeneous, where patients that may have the onset with isolated myositis, then they can develop arthritis and interstitial lung disease during the disease course. So the prevalence of the full spectrum triad is limited at the onset and is very common at the end of the follow-up. Then we have another issue that the number of autoantibodies, of antisynthetase antibodies, is steadily growing. With respect to the past, now we have not only the anti-J1, and I expect that the number of these antibodies will raise in the future, because we have 20 amino acids and we have 20 possible targets. As a minimum, we could expect at least 20 anti-aminosyl tRNA synthetase antibodies, but we have not the possibility to test for everyone, first of all, because we should define it and identify it. But however, this is very tricky for our clinical knowledge about the disease. The other point that is very important is how we are defining antisynthetase syndrome, because we have different classification criteria performed in the past, but however, if you are looking for clinical papers that have been published until a few years ago, we have different type of definitions. So the world is quite confused about the definition of antisynthetase syndrome, and it's not easy to compare clinical papers because we have different definition of this syndrome. And this is the reason why we perform the classification criteria of antisynthetase syndrome. But now, please, take your mobile phone. I'm asking it for you because we should play together. We have a lot of questions for you because I think that the performance of classification criteria will start directly from you and from your experience. So take your mobile phone and let's start. So we have one patient with interstitial lung disease presenting with a spectrum of NSIP that is anti-PL7 positive confirmed, not by immunoprecipitation. So what is your answer? It's allowed to perform multiple answers because classification criteria of antisynthetase syndrome, if you are classifying one patient with antisynthetase syndrome, it's not forbidden to classify this patient in another way. This is very important to remember. This is a key point. Okay? What a success. A lot of answers. Good. Okay, it's a probable antisynthetase syndrome for the majority of people, of colleagues. It's a definite antisynthetase syndrome, but it's also an IPAF. It may work because it satisfies classification criteria for IPAF. That's correct. But however, I have not the answer for now. You will see the answer at the end. Now I have another question. Now you have a patient with a pattern of usual interstitial pneumonia that is antigen 1 positive. How do you classify this patient? Multiple answers are allowed. Remember, and don't forget that we have also idiopathic pulmonary fibrosis, please. I'm introducing a bias in your answers. I beg your pardon. Okay, definite antisynthetase syndrome, but the majority of you, for the majority of you, the answer is probable antisynthetase syndrome. Some patients sometimes some of you classified as IPAF, and only 7 brave people diagnosed idiopathic pulmonary fibrosis. Next step, now the same patient with mechanic hands. Eduardo, you cannot answer. Mary, you too. Okay, definite antisynthetase syndrome. The majority of colleagues answered in this way, and only 1 brave with idiopathic pulmonary fibrosis. Another question. So NSIP, endop, a mixed pattern of interstitial lung disease, mechanic hands, inflammatory arthralgias, anti-Rho52, anacytoplasmic positivity, and all myostatin-specific antibodies are negative, tested a lot of time. 2, 3, 4, always negative. Okay, in this case, the winner is probable antisynthetase syndrome. Obviously, all answers could be correct, for sure. We have not the wrong answer. We have a possibility to define if this patient may have a definite or probable antisynthetase syndrome, maybe with other diagnosis. And again, clinical evidence of myositis, Gcom papules, anti-Me2 positive, anti-OJ borderline, confirmed in several testing, but not by EP. What's the diagnosis for you? I don't know why. Sorry. Okay. I think that in this case, the winner is dermatomyositis for sure. Thanks a lot for your collaboration. And again, I move. Okay. And now let's start with the topic I was asked for. So how did we organize the new antisynthetase syndrome classification criteria? We performed a clinical domain that involved the triad, the classic triad, arthritis, myositis, and interstitial lung disease. We performed another subsetting, including clinical features, Raynaud phenomenon, and so on. And then we drafted a new serological domain. The serological domain was split between anti-Jo1 positive and other antisynthetase antibodies positive. We included anti-Rho52 and anti-SSA, and also cytoplasmic positivity of ANA test. Of note, the positivity for antisynthetase antibodies is not entry criteria. We started for our daily life from the clinical aspect, from the clinical presentation. Then remember that borderline results or indeterminate results are not considered positive. This is a key point, because remember, with classification criteria, we are willing to draft the clinical trials. So in this case, it's important that borderline results should not be considered positive because we need to have a strong evidence for the correct inclusion with the right terminology of patients. If you have a negativity for anti-synthetase antibodies, it's important, and also if the clinical picture is consistent with the clinical presentation of the patient, you should not apply these criteria. For example, if you have one patient with anti-Me2 positive antibodies, anti-synthetase negative with dermatomyositis skin rash, obviously you don't need to apply these criteria because it's only a dermatomyositis. It is not necessary to apply these criteria. And these are the criteria that has been approved by the EULAR, and we are waiting for the final answer from the ICR that we are expecting in a few days. So we have the clinical domain with joint involvement, only one dimension, 1 point for inflammatory arthralgia or arthritis. We have muscle involvement that is divided in 3 different subsets: subclinical evidence of myositis, clinical evidence of myositis, and biopsy-proven myositis with different weight, as you can see. And then we have interstitial lung disease. Interstitial lung disease is split into dimensions, UIP, and other patterns, because it's not easy for us, for non-pulmonologists, non-radiologists, to define, to identify correctly the pattern, because sometimes the interpretation of the pattern is quite misleading. And if you have the certainty to have an SIP and or OP, we have to IGES score, because you know very well that an SIP and OP is the most common pattern of interstitial lung disease in anti-synthetase syndrome. Then we have clinic accompanying findings, and we added also inflammatory rashes, because the 30% of people with anti-synthetase syndrome may have also skin rashes, such as in dermatomyositis. And then please observe the serological domain that has been split in different items. Anti-Jo1, if positive, trust to this positivity. The weight is very, very important. On the other hand, we should be very, very careful when non-anti-Jo1 are not performed by immunoprecipitation. That is not easily available. And these are our scores. Definite total score higher than 5.5 with at least one clinical domain plus the antisynthetase antibodies. Positivity is mandatory. But we can define a probable antisynthetase syndrome if we have one clinical domain among the triad findings, and if we have not the antisynthetase antibodies, and other antibodies are obviously negative. So remember, again, borderline under indeterminate positivity for antisynthetase antibodies should not be considered as positive. If we have a multiple positivity for myositis-specific autoantibodies, trust only if you have a strong positivity for antisynthetase antibodies, or if you have a positivity that is confirmed in the 2 different testing. So it's important to remember that, because double positivity is not so rare as is expecting. In our daily practice, we see this problem a lot of times, and even confirmed in multiple testing. And then this is another bullet point, and to resume is that according to this wise man, it is better to define antisynthetase syndrome when anti-MDA5 and anti-PM-SCL antibodies has been ruled out, because this patient might present features that are very, very similar to the one of antisynthetase syndrome. But they are not antisynthetase syndrome, they are another disease. And this is what we can classify the previous patient. Well, so as you can see, it's a definite antisynthetase syndrome according to our criteria, the positivity for antisynthetase antibodies, in this case PL7 with an SIP. If you have UIP, even with anti-Jo1, is a probable antisynthetase syndrome, because UIP is less common. We have a probable antisynthetase syndrome in this case, you can see, because we have antisynthetase antibodies negative, despite the weight of points is very, very high. And then, when in the last case, clinical evidence of myositis plus Gottron Pappus plus anti-OJ, it's a probable antisynthetase syndrome. But we performed the validation of our criteria. We evaluated the performance evaluation cohort, but I'm focusing more on the independent validation cohort and on sensitivity analysis cohort. Sensitivity analysis cohort raised from patients from both performance and independent validation, and we performed central testing by immunoprecipitation to confirm the positivity of anti-synthetase antibodies. So it's a cohort of patients really positive for these autoantibody. And these are the performance. In the independent validation cohort, sensitivity 86.8%, specificity 99.2%. In the sensitivity analysis cohort, the weight rise a lot, and we have a sensitivity of 92.8 and a specificity of 99.3. I think that these results are very, very important. This is the graph reporting how the performance changed according to the possible cutoff, and we identified this cutoff after evaluating the risk of overdiagnosis and underdiagnosis. This is for definite. And this is for definite again, but on the sensitivity analysis score to patients that were positive by immunoprecipitation. Regarding to probable, 92.7 and 88.3 in the first cohort, and 96.7 and 88.6 in the second cohort. These are the graphs, please check, in the first cohort and in the second cohort. But we have also included the possible definition of anti-synthetase syndrome. The cutoff is 4. We need at least one clinical domain that may be referring to both classic triad or accompanying findings, and anti-synthetase antibodies is not mandatory, also in this case. And the performance was good, 96.4% sensitivity, 75.3% for specificity, 98% and 80.5% in the cohort that was confirmed positive by immunoprecipitation. These are the graphs that I'm showing to you again. Quite boring, this part, I beg your pardon. Graphs, it's better to see clinical data, in my opinion. But however, this is interesting from my point of view because you may have the combination that may rise to the definition of anti-synthetase syndrome starting to the definition of possible anti-synthetase syndrome. For example, if you have one patient presenting with NSIP and OP, if you have an inflammatory arthropathy, you have 3.5. Check the color. If you have anti-Rho positivity, you will reach the cutoff for a possible anti-synthetase syndrome. And I think that is what we are thinking and what we are doing every day in our clinical practice. But now, the last question, that will be for sure the first question after the end of the presentation. Do you think that the definition of possible anti-synthetase syndrome could be useful? Stop. It was for a joke. Okay, it's interesting because the majority said yes, and someone said, a lot of people say also maybe. Only a few people answered no. Someone, no idea. It's possible, it's allowed even to have no idea, but I think that I'm very happy about these results. Now, this is the end of our paper. It's very, very long. Obviously, it's not my intention to read all these conclusions, but I think that we could go directly to our slide, that is this one. Hector, we have not Old Trafford, we have not a good soccer team, football team, because we are very, very bad. But I think that Pavia could have something of good that you could observe if you are willing to visit my wonderful time and my old university. Thanks a lot for this, for your support and for your presence.
So this presentation is open for questions. And so if I may, and I think I've asked this question before, and the reason why I'm asking it again is I'm not sure I agree.
Don't hear very well. It's not easy to hear here, sorry.
Why include probable and possible? Because I would argue that you would do that if you improved sensitivity. But your sensitivity is perfect, and all you do is you lose specificity.
We discussed a lot during our steering committee. That's correct. However, you should consider that with respect to the past, having probable, it's allowed the inclusion of people that could have antisynthetase syndrome but have not antisynthetase antibodies because, for example, we have not all the antisynthetase antibodies available in our routine practice, in our daily practice. So it's important for me to open the window and include also patients that could have an antisynthetase syndrome, but they are not presenting to typical biomarker. Our intention was to move from the classic definition starting from an autoantibody because we are clinicians, we see patients from every day, and in every minute of my life, I'm first thinking about the clinical presentation and then about antibodies. Mm-hmm. I'm not starting from autoantibodies, I'm starting from my patient. Mm-hmm. And then, if the suspect is raising, I could ask for, but where I think that someone has something, I'm going straight to the continuous follow-up to define this patient. And this will allow the inclusion of some probable antisynthetase syndrome. Mm-hmm. Regarding possible, in my opinion, and in the opinion of Freud and of the steering committee, and you agree with us, is captatio benevolentia in the old Latin. So why it's important possible? Because as we show in the past, antisynthetase syndrome is an heterogeneous disease. The clinical spectrum time course of the manifestation is heterogeneous along the time. So it may change a lot. And, but having the definition of possible, we may start a collection of data of several patients that have the flavor of antisynthetase syndrome, but we are not able to define if they will progress. For example, the previous question in the previous seminar was mine, and because we recently described a cohort of 165 people with established rheumatoid arthritis, psoriatic arthritis, and undifferentiated polyarthritis, prospective followed for at least 6 years. They have no evidence of renal phenomenon, mechanic ends, anti-lung involvement, skin involvement. They were completely rheumatoid arthritis, undifferentiated polyarthritis, and psoriatic arthritis. We found 15% of positivity for myositis-specific antibodies, not limited to antisynthetase, but including also anti-SRP. And the positivity was confirmed by multiple testing. So, first of all, remember, don't start from autoantibodies. Start always from the clinic. If you don't need a result, don't ask for this testing. This is very important. This is a key point of our daily practice. It's enough?
Yeah, I also have a question, Lorenzo. So how do you see us using both these criteria and the IAM criteria? So can we have a patient that fulfills both the myositis criteria and antisynthetase?
Yes, because it's important to remember that we are talking about a condition that is an overlap syndrome. So why we could have not an overlap between dermatomyositis and antisynthetase syndrome? It's possible. So to limit the spectrum of our diseases in a single field is limiting, because I have a lot of people with antisynthetase syndrome that is fulfilling also criteria for rheumatoid arthritis. So for me, they have both. It's important to avoid the risk of perform only one classification when we can have a very complicated patient with a lot of possible conditions. And this is the future and what rheumatologists and not only rheumatology should work on, because we have a very wide panorama of diseases, and that they are very frequently overlapping.
Yes, there's a question here.
Vladimir Liarsky from University of Pittsburgh. Thank you very much for your talk. Just my personal opinion, but this seems like we're creating too many buckets based on this criteria, and we're going against some of the other diseases. Like, for instance, for rheumatoid arthritis, we went from a very defined criteria requiring erosions to a much more liberal criteria. For IBM, for instance, we went from, again, all these subcategories to one that encompasses all patients, including those with atypical presentations. So at least in my opinion, it seems to make more sense to have a larger bucket that we can then subset, in studies, but by including more patients, we would have more trials and more participation and more research down the line.
Yes, this is the target, but you should consider that the future of our job is to better define the patients in terms of the underlying conditions that might be overlapping in a lot of things, as I told before. Regarding rheumatoid arthritis, we've heard described it about 12 years ago, that the prevalence of a rheumatoid arthritis-like pattern was very common, even particularly in anti-G1 and even to a lesser extent in unknown anti-G1. We have a huge prevalence of rheumatoid factor and of anti-CCP. I think that the use of different classification criteria could be very useful to define the possibility to draft clinical trial. I think that our proposal is in line with this possibility. We don't need to enlarge the spectrum of classification. For example, if you think, when I was young, when I was born, ankylosing spondylitis in early 70s was together with rheumatoid arthritis and psoriatic arthritis. So ankylosing spondylitis was a subset of rheumatoid arthritis. Now isn't no more. It's different. We have different classification criteria. We have different treatments. So why should we talk about one single set of classification criteria when the future is to go straight to the personalized medicine? This work is in line with this perspective, in my opinion, but we have a lot of work to do again. Thanks a lot for your comment.
Yeah, I would also point out that the fact that there are pathophysiological differences between the different myositis subtypes may actually open the door for different treatments for the different subtypes. So there's that usefulness of separating the patients as well. And we have another question.
Yeah. So thanks for the wonderful talk. So my question is regarding you chose to exclude the patients with MDA5. But as we understand that there are anecdotal reports of dual positivity of anti-synthesis antibodies, like PL7 with MDA5 positivity. So what is your take on that? Where exactly to keep these patients?
So anti-MDA5 syndrome is my second love after anti-synthetase syndrome. So in our experience is that mechanic ends are very, very common in anti-MDA5 patients. So sometimes the difference is not, from the clinical point of view, is not so little. We have a lot of problems that may lead to the definition of one patient that is very close to anti-synthetase syndrome but is anti-MDA5 positive. You know that, for example, anti-PL12 and PL7 are at increased risk of rapidly progressive interstitial lung disease. So we have a risk of an overlap. But I think that from the general point of view, and I have some preliminary data, the pathogenesis of anti-MDA5 syndrome is not the same of anti-synthetase antibodies. Yes, okay, I was right. I didn't mention twice anti-synthetase antibodies. Because anti-MDA5 syndrome is more interferon type 1 related, and the action of the antibodies of anti-MDA5 is stronger than the one of anti-synthetase antibodies in the pathogenic path. For sure, I have preliminary data, I cannot show it to you, but anti-MDA5 antibodies are for sure pathogenic because they are directly activating fibroblasts, they are directly activating fibrotic process, they are leading to damage of alveolar pneumocyte, and I hope to present it in short time with the full data.
So if there are no other questions, we have time.
Hi, Ana Campar from Portugal. Just checking, did you include in your variables previous immunosuppressive treatment? My point being, could the anti-synthetase antibodies be negative because of previous treatments?
So, it's possible, it's one possibility. I think that the negativity of the antibody testing is more common in anti-MDR5 patients with respect to anti-synthetase antibodies. If patients with anti-MDR5 syndrome become negative, it's because treatment is well working. We have less data about anti-synthetase antibodies. The truth is in line with my expertise, is that in general, if we have a negative anti-synthetase antibody, it's because we have an underlying anti-synthetase antibodies that has not been tested, or we don't know why. Please consider that the number of 20 is very limiting, because you know that anti-synthetase, aminoacyl tRNA synthetase is a macro complex. It's very big, it's very huge. We have different aminoacyl tRNA synthetases that are together with other appendix that work performing different actions. So we may have an overlap between targets, between antigens, that is macro complex, and so maybe that we could have one part of the antibody test is leading to one antisynthetase, to one aminoacyl tRNA synthetase, and another to another. So I think that the world is very, very big, and we will identify a lot of new antibodies in a near future.
Following on that, how do you value when you have double or triple positivity for specific antisynthetase?
So we are performing a study, and our conclusion is that if you have an antisynthetase positivity that is strong, antisynthetase antibodies rule to clinical presentation, always. We may have some additional features that may be related to anti-Me2, for example, but however, if you have one strong positivity of an antisynthetase antibodies, it rules, always.
So we've run out of time, but we'll have one short question and a short answer.
It's a short question. Based in criteria of vasculitis, you don't think about to adding negative ratings, like negative ratings in the criteria? Based in vasculitis criteria, you don't think to adding negative ratings in the criteria?
No.
I'm sorry.
No, the reason is because we have the possibility to have antisynthetase antibodies that are not deco-identified. So it was not useful, in my opinion, to include that, and not only my opinion.
Thank you.
Thank you.
Anyone?
So we have heard about the performance of the new criteria. Now we will hear a bit more about how this work was done. So I invite Giovanni Zanframundo from Università di Pavia to present. The floor is yours.
Good morning, everyone. So we've heard a lot already about the EULAR-ACR classification criteria of antisynthetase syndrome, and I'm going to give you just a little bit more insight of the definition criteria. So trees enrolled more than 4,000 among cases and controls, and into the classification criteria, and we talked about the development of data and candidate a year and a half, where the steering committee basically proposed several modifications of performance evaluations of simulation that you may already have seen in the previous presentation, and this is how decisions and under classifications, and propose some solution to this, like, or some preliminary criteria, all possible solutions that could help us to avoid over or under classification. So we finally get to the in this way, we get to the model that you saw. And just to remind you, the model has some preliminary criteria which were developed just to mitigate the misclassification of these patients. And these preliminary criteria said that you should not apply the classification criteria when you have a positivity for an MSAs that is not anti-synthetase antibodies or anti-Rho52, and you have negativity for all anti-synthetase antibody, and the clinical presentation is consistent with the serological profile of the patients. And this is the example that you already have seen. So a patient with anti-Me2 and dermatomyositis clinical picture doesn't need to be, passed through the classification criteria for anti-synthetase syndrome. These are, you've already seen them, so we have three principal domains: the clinical domain, the serological domain, and the other clinical features. And inside this domain, we have subdomains that myositis. You just need to pick this variable here with the highest score. This is for the purpose of the final score calculation, as well as for anti-RS antibody. These are, in theory, they are mutually exclusive, so the problem here is not so relevant as in the muscle domain, as well as in interstitial lung disease. And these were the scores. So, positivity of anti-synthetase antibody. Probable anti-synthetase syndrome is defined with a total score of at least 5 and at least one clinical domain. So we have no need for anti-synthetase antibodies anymore. The possible anti-synthetase syndrome is a total score of at least 4 with one of clinical domain or one of the other clinical features without the need of anti-synthetase antibodies. So if you want to dig a little more deeply into the reason why we picked these variables, we have a couple of patients. Arthropathy was present in roughly 60% of anti-synthetase of patients with anti-synthetase syndrome. And if you look at this graph here, the prevalence of joint involvement is way more high than we can find in any other form of inflammatory myopathies, and it's roughly comparable to the one of SLE, more or less. Same thing for interstitial lung disease. So why do we pick NSIP endop pattern to have a higher score compared to UIP? And this is what we found in our data set. So NSIP was, the legend is missing. Orange is anti-synthetase patients, and blue are controls. NSIP is roughly the same, a little more prevalent in anti-synthetase compared to control. But OP, so organizing pneumonia, is way more common in in patients with anti-synthetase syndrome compared to controls. And the opposite can be said for UIP, which is more common in controls rather than in anti-synthetase syndrome. And we are planning to do some idiopathic inflammatory myopathies. So if you are willing to participate to this project, do not hesitate to contact me or Dr. Laure Gallet, that we are in charge of this project. So we talked about the initial recommendation, the variables and the relative scores, and we also have additional recommendations. The first one is that it is highly recommended to test all the patients also for anti-MDA5 and anti-PMSCL, because as we said before, there are many clinical features overlapping between these two syndromes and anti-synthetase syndrome. And it also should be remembered that patients that meet ACEs classification can also meet other classification criteria. And this is what the way that we intend to manage the results, the serological results, when borderline or indeterminate anti-RS should not be considered positive to the purpose of applying the classification criteria. Weakly positive results should be retested at least 2 times to consider them as positive. And in case of multiple positive results, you consider anti-arrest positive in case of strong positivity, or in case of at least 2 determination with the same result. And there is another poster upstairs that also tells us why it is important to rule out anti-MDA5 syndrome and anti-PMSCL syndrome, because we performed a cluster analysis on our data set, and we found that when we consider both cases and controls, 3 clusters could be identified, and in cluster one, that includes the fact that these clinical syndromes are overlapping is also confirmed by the data of our data set. So in conclusion, the final classification criteria consists of 3 domains: the clinical domain, serological domain, and the secondary clinical features, including mechanic hands and Eicher's feet, inflammatory rashes, Raynaud phenomenon, and unexplained fever. The classification criteria is intended to provide a more nuanced classification for pain. Definite is the highest scored variable, underlining how important is lung disease in antisynthetase syndrome. And of course, this is a dynamic field of research, and much more knowledge will be achieved in this field. And so we are totally open to modify our classification criteria according to what we discover in the future. Thank you.
Giovanni, please come forward for the questions. I will start with a question. So if you have an undeterminate pattern, let's say that you don't have an expert radiologist, he doesn't know if it's UIP and SIP. In this setting, how should you consider a report that only says ILD?
Well, let's say that my honest opinion is that a rheumatologist, then you should apply the lowest score. So if you're not sure you're talking about an SIP or OP pattern, you just score the patient as having an SIP or undetermined ILD pattern.
I have a quick question as well. What was the rationale to divide the 3 main clinical features from the skin and consider skin as secondary clinical?
Just dividing the main triad clinical manifestation from all the other manifestations. In terms of scores, the scores rule.
And the score is the same, but to have a definite, we would need one of the 3 main.
Yeah, so it does make a difference.
Yeah, it does make us that small.
Yeah, that's right. The small difference is that you cannot have definite antisynthetase syndrome without having at least 1 clinical features from the clinical triad.
Fair enough.
We have a question.
Yes, thank you very much for your presentation. I have a question regarding those patients who are negative. So according to the classification criteria, you don't have to have the positivity to be classified as an antisynthetase patient, right? So once the patient is tested negative or borderline, and if the clinical phenotype suggests a lot that the patient has an antisynthetase syndrome, so would you advise to repeat?
Good question, and this is also the reason why we decide to maintain the possible definition. So without antibodies, you can classify patient as probable or possible, and we definitely think that patients that are negative for antisynthetase syndrome, for antisynthetase antibodies, but have a very have a clinical picture that is very consistent with antisynthetase syndrome should be retested at some point after 6 months, 1 year, whatever. And the possible classification may help clinicians just to decide when to retest the patients or when to test the patients in the first place, maybe sending the sample to a 3rd level center, or when to addressing the patients to a more refined serology in this way. So yeah, definitely repeating the test, the line blot, which is the most widely spread test, is definitely something that we advise in case of first negativity and a consistent clinical picture, but also consider when to or test the patients in the first place when maybe you don't have line blot in your own center, or addressing the patients to a more...
Thank you.
Thank you.
So we will move to the last presentation of this session by Maria Rosa Pellico, who will be talking on understanding relapse in inflammatory myopathies, insight from a multicentric international cohort.
Hi, good morning, everyone, and thank you to the scientific committee for giving us the chance to present our work today. It's difficult interest. As Better said before, inflammatory myopathies are a group of very heterogeneous diseases, each with different degrees of myopathy and systemic involvement. These are also rare diseases with an incidence of 1 to 10 per million a year, but this incidence varies a lot across regions and subtypes. Due to this rarity and heterogeneity, we still face some gaps on some crucial aspects of the disease. Above all, on the complex topic of relapse, which is still under-characterized and inconsistently defined across studies. To address some of those gaps, the aims of our study were to describe relapse in myositis in the first 2 years of the disease, to identify baseline features that were associated with relapse, and to assess the impact of treatment strategies on the relapse risk. To do so, we defined relapse as a physician-documented clinical deterioration that required an escalation of immunosuppressive treatment or glucocorticoids. This was with at least 2 years of follow-up. We excluded patients with IBM or cancer-associated myositis. All the data were collected from the participating centers in Italy, UK, India, and Japan. And after initial screening, we selected 239 patients. These patients were then divided into 2 groups, the relapsers and the non-relapser group, based on the presence of at least 1 relapse event in the first 2 years after diagnosis. Statistical analysis comprehended group comparison between the relapsers and the non-relapsers, an unsupervised K-prototype cluster analysis, and a binary logistic regression model that were used to identify predictors of a relapsing course. So, as said, we finally analyzed data from 239 patients with a median age at diagnosis of 46 years. These patients were mostly female with prevalent diagnosis of dermatomyositis and antisynthetase syndrome. 57% experienced at least 1 relapse in the first 2 years of the disease, with minor differences across all the myositis subgroups. We analyzed data from baseline, and we observed how there were no statistically significant differences in terms of demographics between the relapser and the non-relapser group. But relapser patients presented with higher activity at baseline, as highlighted by the higher physician global assessment and patient global assessment scores. We then analyzed organ involvement at baseline, and we observed how there were no differences in terms of systemic, skin, lung, and articular involvement at baseline between the 2 groups. But relapser patients tend to present more frequently with dysphagia and myositis. And when presented with myositis, their biochemical activity seemed to be higher than the non-relapser group, as highlighted by the higher CK and aldolase that they presented at disease presentation. Then we analyzed data from the treatment strategies that both of the group adopted. So non-relapser patients tend to be treated more frequently with higher dosage of steroids, so more than 1 milligram per kilo a day of prednisone equivalent, and they were treated earlier than the non-relapsers with the steroid treatment. On the other hand, relapsers were treated more frequently with IVIG. No statistical difference were observed in terms of immunosuppressive treatment or steroid pulses. In the whole cohort, in the first 2 years of the disease, 161 relapse events were detected, with muscle being the predominant organ that was involved in all the cohorts. But in more than 40% of cases, multiple organs were involved at the time of disease recurrence. This percentage was highest in the dermatomyositis subtype and, of course, lowest in the polymyositis and immunomediated necrotizing myopathy subtype. Interestingly, also, relapses occurred across all steroid doses and duration, reflecting a persistent immune activity that was independent of treatment intensity. So almost 40% relapsed off steroid, but most others were under low to moderate doses. These trends tend to be different across all the subgroups, with CTD and polymyositis and immunomediated necrotizing myopathy relapsing on high steroid treatment, so more than 10 milligrams per day, whereas the dermatomyositis and the antisynthetase syndrome subtype more frequently were off or under a low steroid treatment at the time of relapse. We then conducted an unsupervised cluster analysis that was able to identify two principal autoantibody phenotype signatures. The first, a dermatomyositis dominant type, and the second, an antisynthetase-enriched extramuscular type. These two phenotypes were repetitive both in the relapser and then in the non-relapser group. So let's first look at the dermatomyositis dominant archetype. This is a strongly muscular type with low extramuscular burden score. We intended with this score the number of extramuscular organs that were involved at disease presentation. But the main difference between the two groups in the same phenotype is, again, the treatment that they received. Let's then look at the antisynthetase syndrome archetype. This is a strongly extramuscular type with high extramuscular burden score that was highest in the relapser group. In this group, we can also find the MDA5 positive dermatomyositis, and this group has also a higher prevalence of Rho52 positivity. But again, the main difference between the two groups is the treatment that they received. We finally conducted a binary logistic regression model that was able to confirm what we saw in the previous analysis. So higher CK or higher extramuscular burden score at baseline seemed to be predictive of a relapsing course, while a higher dosage of steroid at induction seemed to be protective of an early relapse, or at least in the first years of the disease. So in conclusion, this is the largest multicentric study to date that investigates relapse in myositis across a different ethnic group. As we saw, higher severity of disease at baseline pose patients at risk of early relapse. Also, we've seen how relapse could have occurred despite high dose or maintenance therapy, so it's not merely an under-treatment expression, but it may reflect a smoldering subclinical inflammation that occurs differently in the two pathogenetic settings. With this in mind, and with our data, we can support what we can call a hit-hard and early approach, in which a higher dose at induction may reduce the relapse risk. And avoiding under-treatment at diagnosis may reduce the overall cumulative steroid burden. So in this optic, early steroid-sparing therapy should be seen as a complement, but not a replacement of adequate induction. With that, I would like to thank the mentor of the study, Dr. Gupta, for her guidance and her patience during these years we've been working together, my professor, Professor Caporali, and all of my team at Gaetano Pini Hospitals, all the collaborators that contributed to this study, and Mira Foundation for giving me the chance to be here today.
Thank you. Please come to the microphone if you have any questions.
Thank you. Very nice study about a heterogeneous patient group. How do we know that all these patients are in remission? Are they really in remission, or do they have some continuing activity? I mean, I know that you recorded increased activity in the whole group of patients, but is their activity really zero, means remission, and then relapse? Or this is just an increase in ongoing activity because of, insufficient treatment? We are not perfect in the clinical records. It could be not recorded,
Yeah, thank you for the question. So actually, since there's no standardized definition for remission, we used an operative definition meant as low or no disease activity. But as we observed, patients who already relapsed were under even high dosage of steroids. So, I mean, they were under low disease activity, but with treatment. So the increase of disease activity was, collected, but from a low or a stable disease point. But some patients never actually, went into remission.
I have two questions. First of all, how was long to stop of corticosteroid in patients who relapsed? And the second one, if you are not willing to analyze, for example, the rate of flares in people that started treatment with methotrexate as a tioprine, so using even the starting treatment as a future outcome measure of the relapse risk. Thanks a lot.
So regarding the first questions, patients who were under no steroid treatment were at least 6 months steroid-free at time of relapse. While pertaining the second questions, we analyze data from the immunosuppressive treatment point of view. We analyze binary data, so starting or not starting the immunosuppressive treatment and when. And we also stratified patients based on the treatment that they've received. But since the cohort is so diverse and heterogeneous and the number is not so big, we couldn't find any significant data to present.
All right, so if there are no further questions, thank you very much.
Thank you. Microphone? It's working? Okay, thank you. Yeah. Can you go back?
Is there a pointer?
No. Is there a pointer? It is just a mouse. Oh, is that the back button? Yeah. So you have two slides. So you have this one, and then the video, and then that one. Okay. No, it's just a mouse. Okay.
Matran? Maybe they can just turn it up, or is it loud enough now? Is it loud enough? Do you find? Yeah, so it's fine. Do you want me to check the other one? You want them to use this?
Just go next slide, yeah, that's all.
Don't touch that. Okay. All right. I guess you can still, does this work?
Well, maybe no, here. You select here.
Yeah, that works. Yeah. But we're recording, so if you have that on there while you're recording, they won't be so nice.
No, what I told them is not to use them. Not to use the point.
Yeah, because otherwise, yeah. Should we just start with the music and then start from the very beginning? So we have the first slide and then the music starts, right? Okay, so I'm going to start. Okay. Don't start. Okay, bridging science and clinical practice and yeah, okay, I'll just keep going. Can I go faster? Just the QR code. Matran, do you want to test the QR code at the beginning? Okay. Okay. Oh, we also need the timer. Almost ready? Oh, we're waiting. I was going to wait for the timer. Yeah, So, oh, we're starting from the beginning, okay. Matron, do you want to test your QR code? Is it fine? Okay. It's good? Okay. Can you set it for 15 minutes? Yeah. Okay, good. So it works. It's good. Okay, next presentation. So we can reset it again for 15 minutes. No, we're just testing. Okay. Could you change the lectern so that it shows the name? Does that mean keep going? Is the name changed? Okay. Keep going. Okay, then we need to start the timer as well. Could you start the timer? Yeah, we need the name here and the timer. Can you start the timer? Thanks. Okay. Okay, so we're at the end of the second presentation. We're at the Q&A. Can you restart the timer? For 10 minutes. Thank you. Blah, 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 blah. And now we have the closing remarks. So we need the timer for 3 minutes. Okay. Yeah, so we just need 3 minutes on the timer for the closing remarks. Okay. Hey, Matran, do you want to test your Q&A? Okay. And now the last one. Do you want to test that one? Okay.
to arrange it? Would you like me to keep full glasses? Would you like me to remove some? Okay, ma'am. Okay, ma'am. I think you'll be fine. You're welcome. You're welcome. That was a pleasure. There's not many Olgas. Thank you. I'm Olga as well. Yes. There's not many Olgas. I am indeed, yeah. Yes. I am Portuguese, and I'm the third generation in my family named Olga. So it was from Swedish. I thought it's from Russia. I thought because most of people ask me if I'm from Russia. Interesting. We are not many Olgas in the world. It was a pleasure to meet you, Olga. Thank you very much. You're welcome.
a haver menos gente, as pessoas vão passear. Isto aqui nesta zona é mesmo, é só sair, não é? Está-se mesmo no centro Sim, sim. E para eu depois começar também a apresentar, como eu apresento logo a primeira, se calhar é preferível.
Acho que está na hora, vamos começar. Olá, boa tarde. Ok, obrigada. Acho que está tudo ok. So, good afternoon, dear colleagues. Let's go on with this very nice meeting. I am Margarida Gonzalo. I am a dermatologist from Coimbra, dealing with some cases of dermatomyositis mostly. And it's a pleasure to co-share this session with Dr. António Moraes, pulmonologist from Porto. So with this, I give the word to Professor António Moraes.
Thank you. Good afternoon to all. It's very nice to be here. We have a section, a clinic perspective from presentation to management, and we will focus on the lung involvement and skin involvement. We will begin with lung involvement, and to start, we'll have a patient that will deliver some experiences of the myositis with lung involvement. Olga Daprolova is from Czech Republic. Please, Olga.
My speech will be recorded, yeah? That means you will listen and then I will answer questions if you will have any. At a plenary session, as a patient with myositis. Let me introduce myself. My name is Olga Drapova. I come from the Czech Republic. I am currently retired. In terms of my professional background, I work as a secondary school teacher. Later, I worked as a regional inspector and ended my professional career as the inspector of the secondary cycle of the European schools. I was responsible for the European Baccalaureate in the Czech language and geography. After ending my professional career, in 2019, I founded a patient organization. I am a chair of the Czech Myositis Working Group. I am ER and Reconnect EPEC advocate, and I was involved in several international projects. Next, please. The first symptoms appeared in the fall of 2013. With the arrival of color autumn weather, I felt painless muscle weakness, extreme fatigue, and joint pain. The small joints on both hands swelled up, and the skin on my fingers hardened and began to crack. I visited my general practitioner, who then referred me to a local rheumatologist. He attributed my health problems to my age, which hurts me deeply. Unfortunately, he was unable to diagnose me or prescribe effective treatment. My health continued to worsen, limiting my mobility. I couldn't get out of the car, climb out of the bathroom, dry my hair, and even the slightest number of stairs or a small hill caused me enormous breathing problems. Gradually, I became dependent on the help of others. It was the most complicated period of my life. I was eventually hospitalized to a specialized center at the Rheumatology Institute in Prague. After several tests, including blood tests and muscle biopsy, the rheumatologist diagnosed me with a rare disease, polymyositis, antisynthesis syndrome, and interstitial lung disease. A CT scan showed that 20% of my both lungs were non-functional and that the changes were irreversible. And my respiratory function is at half that of healthy lungs. My illness affects my daily life, and pain is my daily friend. I have to plan my daily activities, which include housework, cooking, shopping, exercising, and walking. I listen to my body, and I know that, for example, the maximum number of steps per day is 10,000, and I try to keep to that. Over the course of 12 years, I have 2 cases of disease progression in my lungs, and each time my rheumatologist increased my medication dose. I always caused this myself because I overworked and didn't listen to my body signals. Last year, I met the criteria and received fibrotic treatment. I think the new treatment is beneficial in all respects. Next, please. I've got 2 messages. The first one to healthcare providers, and the second one is message to patients. I would like to share a part of my patient's story. I remember it as if it were yesterday. I was lying in a hospital bed in a specialized center. Almost for the first time in my life, I encountered such a cultivated behavior, empathy, and humanity on the part of a doctor. One gloomy morning, the door suddenly opened, and a man in white entered the hospital room. His appearance immediately caught my attention, and his behavior was somewhat unusual and unexpected to me. He shook my hand, introduced himself, and officially told my diagnosis. Then he described my treatment options. He told me that I would have to visit his clinic regularly in the future. I also had the opportunity to ask questions. At the moment, however, none came to my mind. Miraculously, almost unbelievably, every visit encourages me and gives me new energy. Whenever my myositis reminds me that it exists and that I have to deal with it, I find help from my rheumatologist. I had and still have my rheumatologist constantly on my mind. He has become part of my life and accompanies me on all my journeys. He taught me to live with a rare disease, to listen to my body signals, and most importantly, he brought me back to life. In general, not only a professional, but also a human approach by a doctor to patient is beneficial in all respects and has therapeutic potential. It is necessary to build mutual trust between patient and healthcare providers. My case is proof of this. And message to patients, be optimistic, take care of your physical condition, and get involved in a patient association. Next, please. CT, this is CT scan of my lungs, and I spoke about it, that 20% is unfunctional. Next, please. I have been a very active person all my life. I was cycling, skiing, loved hiking, and traveling. This photo from 2005 illustrated. Next one. It's a picture 20 years later, just before my 70th birthday in 2025, my son and his girlfriend gave me a gift in the form of a 9-day trip to the Arctic Circle. We flew from Stockholm, because they live in Sweden, to Kiruna, and from there we traveled via Narvik to the Lofoten Islands in Norway. My initial concern melted away, and I was able to participate in all the activities without any major problems. The whole family respected my needs. We spent 8 wonderful days together above the Arctic Circle. Next one. Thank you very much for your attention. It's time for questions and answers. What's on your mind?
Thank you, Olga, to share your experience. We have 2-3 minutes for questions for the sake of time. If there is no questions from the audience, I would like to know, because we have some problems here, we don't have a strong association, patient associations as we should. For you in the Czech Republic, you have a strong association, you can reach to the authorities, you have impact on them, for instance, to the treatments.
Yes, thank you very much for this question. Thank you very much for this question. Yes, I have founded my patient organization, Gcom Myositis Working Group, in 2019. And yeah, because it was a huge challenge for me to start it, because maybe I didn't know how to cope with it, but our patient small groups was integrated in the patient organization with a long tradition. That means Czech Leagues Against the Rheumatism. And it was a beneficial step because the team helped me a lot. And my patient organization or association is worked well.
And your organization is all rheumatologist patients, or is a large patient
organization? Czech League Against the Rheumatism, or integrated patient with rheumatology diseases, and we've got groups with lupus, scleroderma, and myositis.
Very well. And you have access to therapeutics for innovative therapeutics for it? Do you have easy access to innovative therapeutics?
Yes, I think that.
Yes, it's easy for you, and you have impact on that,
yes,
on the authorities?
Exactly.
Right. Thank you. Questions? Well, thank you very much, Olga.
Thank you very much.
Then we move forward for lung involvement by Robert Olwell. Robert Olwell is from Massachusetts University. Unfortunately, he will not be with us. So the presentation is previously recorded. I don't know if we will have him for questions, but I will see. I don't have that information, but we hope that it will be possible. I will ask for Roberto Olwell presentation, please.
Good afternoon. My name is Robert Hallowell from the Massachusetts General Hospital. I hope you're having a wonderful conference in Lisbon. I'd also like to thank the committee for inviting me to speak today. I had every intention of being here in person, but fate had other plans for me. These are my disclosures. As you can see, I've served on several advisory boards and I've received authorship fees and consultation fees from the companies listed here. I've also served on several, or as the PI on several clinical trials. The learning objective for the next 25 minutes or so is to talk about the clinical manifestations and radiographic patterns in patients with interstitial lung disease, and then focus primarily on the treatment approach in these patients. I understand that I'm speaking to a room of experts, and that much of the data I'm going to show you is probably generated by people in this room. So I'm not going to lecture at you. This is more a chance to commiserate a little bit on the lack of data that we have, and hopefully inspire us all collectively to go forth, come up with new clinical trials, and advance the field for our patients to spark a discussion. As I think we all know, ILD is very common in patients with myositis. The reported prevalence can range pretty widely depending on the series we look at and whether or not certain antibodies are prevalent. We also know that ILD can precede the myositis diagnosis in up to a third of patients, and depending on the antibody positivity. ILD is the leading cause of morbidity and mortality in myositis patients. These patients die of lung disease primarily, and so it's important to recognize, diagnose ILD early on in these patients, and typically treat it aggressively. We know that certain antibodies are associated with bad outcomes in myositis patients, and MDA5 has earned itself a particularly bad reputation, although there is probably some reporting bias with this antibody. This is work from our group at MGH, where we found that anti-Rho52 antibody, like MDA5, and perhaps even more so than anti-MDA5, is associated with worse ILD progression, worse ILD survival, hospitalization, and need for transplant, whether other synthetase antibodies, whether other myositis-specific antibodies were present or not. We often hear people talking about certain myositis radiographic patterns and radiographic patterns that are pathognomonic for myositis. In reality, the full spectrum of radiographic patterns can be seen in myositis patients. Yes, NSIP and organized pneumonia are the most common, but you can see pretty much any pattern in these patients. Likewise, surgical lung biopsies are rare in myositis patients. We tend not to get them because of the risk of flare, and it typically does not change our management strategy. That being said, NSIP is the most common pattern, but again, like we see with radiographic patterns, the full spectrum is possible, with UIP actually being the second most common pattern, followed by organizing pneumonia and other mixed patterns. I'm going to show a few cases here just to highlight a few clinical pearls that I think will resonate with your own clinical experiences. The first is that of a 34-year-old woman who came to my clinic with anti-PL7 positive dermatomyositis. Her extrapulmonary symptoms included joint pains, fevers, and a significant rash that readily improved with immunosuppression. And you can see her therapy here. She was on full-dose mycophenolate and a prednisone taper starting at a mg per kg that was eventually brought down to her target dose of just 5 milligrams daily. And we were all feeling pretty good about her case because of how well she was feeling. But after just 4 months on this regimen, she developed a worsening dry cough and pretty significant dyspnea. And you can see her CT imaging here, old one on the left, and then repeat imaging on the right, with pretty significant worsening of her radiographic findings. She had worsening oxygenation, and as you might imagine, her DLCO had also gone down. And so I showed this case just to highlight the fact that the different body compartments can march to the beat of their own drum. Essentially, even though patients may feel better globally, and the skin or the joints or the muscles may be improving significantly, the lungs can be worsening behind the scenes. And we may not know it right away because if the muscles are getting better and the joints are getting better, et cetera, patients may initially feel better even though the lungs are getting worse. Conversely, here's the case of a 68-year-old woman with anti-Jo1 positive dermatomyositis who also had some progressive dyspnea after several months. She had a decrease in her forced vital capacity, was unable to perform a DLCO due to coughing. And unlike the previous case, repeat CT imaging was actually rather unremarkable in terms of progression. You can see both CT scans look rather similar here. We got some MIPS and MEPS, so these look at inspiratory and expiratory forces as a measure of respiratory muscle strength, and you can see that they're pretty significantly decreased, so the respiratory muscles are weakened. And this patient, who always had a moderately elevated CK, now has a pretty profound CK elevation. And so here we see respiratory muscle involvement, and this is probably the main cause of this patient's dyspnea. I'm going to pivot a little bit to treatment. I showed this study here, which was a really nice review and guideline looking at the treatment of anti-MDA5 positive dermatomyositis, RP-ILD. And my purpose of showing this is to show the challenge we face right now when it comes to treatment and guidelines, because we really have limited data. And what you see here is that this was a very thoughtful paper by leaders in the field, and what they were stuck using to come up with this guideline. And essentially all the studies available were retrospective, and you see the size of the studies ranging from 20, 10, 28, et cetera, patients. And so this really just sort of highlights how much work we have to do and how hard it is to do studies in this type of patient. Likewise, the most recent and highly cited American College of Rheumatology guidelines for the treatment of interstitial lung disease painstakingly went through the data, and I'm sure many people here worked on this, and yet it was impossible to really come up with a true algorithm in the treatment of the connective tissue diseases, including myositis in patients with interstitial lung disease. We sort of had to lump all the treatments together because there really isn't data to support the use of one agent over another. And so it's sort of like choosing your favorite football player, either male or female. And you can argue for any of these players. They're all phenomenal. And depending on the country you're from and which team you support, you could say that one agent, is better than another, one player is better than another, but it really just comes down to familiarity and preference. We know that myositis ILD can be stabilized by a variety of agents. There are many studies like this. This one, I think, just highlights it simply, that whether you're using cyclophosphamide or azathioprine or mycophenolate, granted, this is a small study, but they're all small studies. They all have a similar steroid-sparing effect and a small, probably negligible increase in forced vital capacity and DLCO. There are studies looking at the use of calcineurin inhibitors in patients with myositis ILD. Some of them show that the early use of these agents may be beneficial in our myositis patients, or that the use of calcineurin inhibitors may be beneficial in patients who have refractory disease, or that these agents maybe are preferential in patients with myositis. The problem is none of these studies are true head-to-head comparisons against other steroid-sparing agents, or patients who are on other agents either concurrently or beforehand. And so there's maybe a signal here, but we really need more data to suggest that calcineurin inhibitors really are superior. I always look for any excuse not to use cyclophosphamide in my patients because I think it's more toxic and not necessarily more potent. Really all we can say is that there are probably other agents that are non-inferior to cyclophosphamide in connective tissue disease ILD and certainly myositis. I use this as one example. This is the recital trial, which was a randomized controlled trial. And you can see here evenly split 48 patients in the cyclophosphamide group, 49 in the rituximab group. Of those patients, a little less than half had myositis. There was no difference in change in FVC or infection. So essentially, this is a non-inferior trial. So given a choice, I'd rather be on rituximab than cyclophosphamide. But again, we don't have proof that any agent is superior in our myositis patients. What about the JAK inhibitors? So there's been increasing talk slowly over the past few years for agents such as tofacitinib. Some data in our sickest patients, most of all those with MDA5 ILD. This is a retrospective study comparing those treated with tacrolimus versus tofacitinib. And you can see here there was actually a survival benefit in the tofacitinib group. Other data here, also retrospective, looking at the use of JAK inhibitors to treat antisynthetase-associated ILD. You can see extensive previous treatment in these patients, and so the data is a little bit messy. The JAK inhibitors are associated with reduction in inflammatory scores, inflammatory markers, and HRCT scores. There had been concern about these agents because of black box warnings in terms of cardiovascular events. Certainly our rheumatology colleagues are much more familiar with the use of JAK inhibitors than our pulmonary colleagues here. But I think you're going to start seeing increasing use of these agents for the treatment of our sicker myositis patients, and hopefully we'll be generating more data in this arena. What about IVIG? Certainly it's enticing because there's less of an infection risk with this agent. But again, the data is scant, in part because there's a lot of noise with the data because this is typically used as a second or third line agent. And most patients receiving IVIG are also receiving other steroid-sparing agents, making it difficult to tease out the IVIG effect when it comes to the outcomes. That being said, certainly anecdotally and in terms of retrospective data, there's perhaps a signal that the addition of IVIG can be beneficial in our patients with refractory ILD. Well, how aggressively should we treat these patients? We've all been faced with patients dying in our ICUs with MDA5 positive, anti-Rho52 positive, antisynthetase positive ILD, and certainly the temptation when we see these sick, dying patients is to sort of throw the kitchen sink at them, as we say, to throw as much immunosuppression at them as we can, because certainly if they have inflammatory disease and they're dying, maybe more is better. And we've had some patients with good outcomes who get through the inflammatory phase and they survive and they walk out of the hospital. But perhaps more is not better. We've also had patients who die of infections. And so, some of these studies do suggest that more is not necessarily better. We're perhaps doing harm in some of our patients by using more aggressive therapy. And I think we just don't know which patients benefit from a more aggressive approach and which patients are being harmed by that approach. I think part of the issue is that whenever you do any study in the ICU, as I think you know, there's so much noise drowning out the signal that it can be very hard to tell which cohorts benefit from which approaches. So a lot more work needs to be done here. What about more advanced therapies such as plasma exchange? There certainly is some data to suggest that plasma exchange may be beneficial in patients who have autoimmune diseases and autoimmune-associated interstitial lung disease, myositis notwithstanding. And I show you an example here. There are just as many examples showing no benefit from the use of plasma exchange. And so I think we really just need larger studies, prospective studies, looking at this technology in this patient population. The third case I raise here is that of a 62-year-old woman with anti-Jo1 associated dermatomyositis. Despite being on immunosuppression and presumed control of the inflammatory component of her disease, she had a slow but real progression of the fibrotic component of her disease, as you can see here. Over the course of several years, worsening reticulation, worsening traction bronchiectasis. And so the question is there a role for antifibrotic therapy in these patients? So here's a slide I think many of us have seen over and over again. This is from the InBuild trial, looking at the use of nintedanib, antifibrotic agent, in patients with non-IPF progressive pulmonary fibrosis. And as you can see, patients who receive nintedanib have a slowing of their FVC decline. Not a reversal, not a complete halting, but a relatively slowing by about 50%. However, when you look at this study, although roughly 25% of the patients did have an autoimmune interstitial lung disease, including patients with rheumatoid arthritis, and there were similar studies looking at the use of this agent in patients with scleroderma. That's the census trial. Myositis was not really represented in this population or in this trial as a whole, in part because the use of the type of immunosuppression that we generally use in our myositis patients was an exclusion. So none of these patients could be on calcineurin inhibitors or mycophenolate or rituximab, et cetera. And so you're not going to see myositis patients represented here. And so this data, this slowing in FVC decline in patients with myositis, we really have to extrapolate this data to our myositis population because we just don't know specifically how it would act. Likewise, the newest kit on the block, nerandomilast, by the same makers as nintedanib, also shows a slowing of decline in FVC in patients with non-IPF progressive pulmonary fibrosis. But again, when you look at the breakdown of patients here, myositis is not represented. So as always, we sort of have to extrapolate this data to our myositis patients. They're always sort of left out. Well, what about CAR T therapy? Certainly this is something that will be talked about here at the conference for the treatment of myositis and the extrapulmonary manifestations of myositis. Its use for the lung disease is certainly less well described. There are case reports and small case series, but in general, patients with significant lung disease have been excluded from these trials. And so we really don't have a sense of how effective this approach is for treating myositis ILD. We can guess that perhaps it's effective, but we really just don't know. And so I think we'll have to wait and see as trials come out how we can do this safely to figure out whether this is an effective approach. So in summary, interstitial lung disease is the primary driver of morbidity and mortality in our myositis patients. We still lack convincing data to guide our immunosuppressive approach. A lot of it is based on familiarity and comfort and the institution. There's perhaps a role for the use of antifibrotics in these patients, but again, that data is extrapolated from other trials. And I think this is an exciting time for the field. There's novel therapies, novel technologies. Those are all likely to transform our field and help our patients, but we still have a lot of work to do. I thank you for your time. I wish you all a safe and happy conference and safe travels home. Thank you.
We have 10 minutes for discussion, but unfortunately, Robert will be, he cannot be with us, so we move on for the skin involvement.
So we change from the lung to the skin, and it's my great pleasure to ask Aisha Hall, that is a colleague of us. She's an occupational physician, but she also has dermatomyositis. So let's hear her experience. She has a pre-recorded talk, and then she'll be available for questions so that we really know the impact of dermatomyositis in her life. Please, the floor is yours.
Is it on? Oh. Hello, everyone. My name is Dr. Aisha Hall, and as she stated, I have a pre-recorded video. Thank you. Hello, my name is Dr. Aisha Hall. I'm a wife, a mother, and an occupational therapist serving New York City public school students in Bed-Stuy, Brooklyn. Today, I come before you as both provider and patient. Fortunately, my journey to diagnosis was not long, but it was extremely painful. On January 16, 2022, I lost my maternal grandmother. I was overwhelmed with grief. About 2 weeks after her funeral, I began experiencing what I now recognize as the onset of my symptoms: tingling in my fingertips, inflammation around my cuticles, and slight swelling above my right eye. On February 17th, I saw my primary care physician, Dr. Amir Hamidin. He listened, ordered blood work, and took my concerns seriously. That was the last time I saw him in person before my diagnosis, but it wasn't the last time we communicated. As my symptoms progressed, he remained in constant contact through my chart. On February 22nd, after I updated him about my worsening condition, he referred me to my rheumatologist, Dr. Latoya Freeman Beeman. Within days, I struggled with basic tasks like lifting my arms and opening toothpaste. On March 1st, I went to Methodist Hospital in Brooklyn and was discharged with 600 milligrams of ibuprofen 3 times a day for pain. That treatment did not address the underlying cause, and I later developed acute kidney complications. Less than 2 weeks later, my symptoms escalated dramatically. On March 14th, I woke up unable to swallow without pain and unable to walk. If you looked at me, you wouldn't have believed that I could even see you. I returned to the hospital, and this time, I encountered a physician who changed the trajectory of my care. He said, "I want to admit you, but not here. Go to Mount Sinai Beth Israel in Manhattan, where your doctor is affiliated." That referral was advocacy, prioritizing my outcome over convenience. I left that afternoon and was admitted to Mount Sinai Beth Israel. The very next day, on March 14th, at the age of 32, after imaging and extensive labs, I received my diagnosis, dermatomyositis with interstitial lung disease. I remember thinking, what are the odds? My mother-in-law had polymyositis, so the word myositis was not new to me, but this time, it was mine. I was immediately started on 1 gram of prednisone via the IV. 4 days later, I was discharged on 60 milligrams of oral prednisone. Over the course of my treatment, I was managed with azathioprine, but it was discontinued due to thrombocytopenia, followed by CellCept, IVIG, and ultimately Rituxan. Dermatomyositis impacted nearly every domain of my life. I went from working out 3 days a week to struggling to walk a block without severe pain. I developed visual rashes across my face, chest, arms, and legs. My joints were so inflamed that even opening doors became difficult, and I had to take medical leave from work. But the most significant impact was this. I couldn't pick up, hold, or even feed my 1-year-old daughter. That loss of function wasn't just physical, it was emotional. Mentally, it was heavy. I remember saying to my husband, what if my purpose in life was just to care for my grandmother and bring our daughter into the world? I was grieving, newly diagnosed, and afraid. A few days after my diagnosis, I found Holly Jones, who was living with polymyositis and ILD on social media. She connected me to the Myositis Association and the Women of Color Affinity Group, a space where I saw myself reflected and supported. That community changed the trajectory of my healing. What I've learned is this: remission begins long before medication. It begins with listening. Early in my diagnosis, I spiraled. I was overwhelmed with test results and afraid of my future. Dr. Hamidan made time to walk me through every lab and answer every question. I left feeling lighter. That conversation stabilized me more than any medication. I have what I consider the dream team. My PCP, Dr. Amir Hamidan, listened early, stayed in communication, and made space for my fears. My rheumatologist, Dr. Latoya Freeman Beeman, ensures every question I have is answered and never makes me feel like my symptoms are exaggerated or in my head. My pulmonologist, Dr. Nicole Ng, walks me through my pulmonary function test results in detail, and she communicates directly with my rheumatologist to ensure coordinated care. That level of communication and collaboration is why I am stable today and actively discussing growing my family. Dr. Freeman and Dr. Ng have developed a coordinated plan to ensure my body is ready for pregnancy. I am currently maintained on tacrolimus alone and have remained stable on it for the past 9 months. Family planning in younger women with dermatomyositis deserves thoughtful, coordinated care. As a Black woman living with dermatomyositis, my key message is simple. Listening is diagnostic. You may have all of the textbook knowledge, but I live in this body every day. Partnership doesn't just improve clinical outcomes, it determines whether a patient believes remission is possible. And because I was listened to, I am here, I am stable, and I am hopeful about my future. Thank you.
Thank you, Aisha, for your testimony. Is there any question? As far as I understood, it took some time for the diagnosis. Sometimes most people from outside this group, of course, they do not recognize the skin signs of dermatomyositis, so it can be sometimes difficult to get to the final diagnosis.
Yes.
What's your experience in that? You took some time.
Okay, so actually mine started, it didn't start immediately with the skin, it started with swelling above my right eye. But it was very slight. But because I'm very familiar with my body, obviously, and I pay attention, I was like, that doesn't seem right. And so because of that, I was then referred to, actually, he sent me to an eye doctor, and she gave me, what did she give me? She gave me prednisone. And so once the swelling went down, she said, uh-oh, that's not a good thing. And so she basically wanted to make sure that there wasn't any eye issues with me. And so once she saw that, she knew that I needed to be seen by a rheumatologist.
Okay. You were lucky because you're also a doctor, so you recognize the skin signs and the severity of symptoms. Maybe other people that are not doctors will not have the diagnosis so quick.
Yeah, my diagnosis was pretty quickly in terms of me starting out with symptoms and then going to get checked and my doctor telling me to go to the emergency room. I actually got diagnosed pretty quickly, thankfully.
And in your experience at the patient association, what is for skin lesions are visible, so are often visible and people can see them. So how is the impact, how do you feel the impact of these lesions on the relation with other people?
So I actually went into hiding. Because as you saw, my appearance changed. You couldn't really notice you didn't recognize me. And so I didn't want to see anybody. I didn't want to speak to anybody. I took time off of work, and it was pain, and it was also me not recognizing who I saw in the mirror. And so because of that, I actually got connected with TMA, the Myositis Association, and the Women of Color Affinity Group. And once I found my community there, they encouraged me to share my story. And so ever since then, I've been who I am today.
Okay. Any other question? I think no.
Okay.
So thank you for sharing your story
Thank
with
you.
us. It's now my great pleasure to ask Victoria Worth, who is a professor of dermatology and rheumatology at the University of Pennsylvania and also a doctor in Philadelphia. She has a very large experience with a huge cohort on dermatomyositis. She has published a lot on dermatomyositis, and so it will be a pleasure to hear you again on this topic.
Thank you so much. It's great
Thank
to
you
be
very
at this
much.
very interesting meeting. And I want to also say that I met Aisha at a TMA meeting not so long ago, and also can say that it's really important to have that kind of advocacy. So I'm going to talk about myositis presentations in the skin. I do have conflicts. We're trying to get drugs. We have no drugs approved for the skin part of dermatomyositis. And I'm going to talk about, first, the impact of skin disease, which we heard about already in dermato, classification and diagnosis as it relates to skin, and skin findings in various skin types in dermato, as well as outcomes in the skin. So if one looks here at the degree of erythema, and this is a Shaw sign, V-neck sign, excuse me, these patients really have a hard time with this condition. And we've done some qualitative interviews, and one of the major complaints is itchiness, followed by pain and uncomfortableness, the color of the rash, because it's so notable, hair loss, the burning hot skin, flakiness, and so on. But this is a disease that has huge impact on patients. You can look at it a different way, where we looked at the Skindex, which is a measure, has 3 subscales: symptoms, emotions, and functioning. And the red dermato has a high score relative to many other skin conditions, particularly with emotions and in symptoms. So what about the classification and diagnosis? So one of the things that I will say, and we already heard about, is that there's a huge problem in getting a diagnosis. Often these patients are diagnosed with systemic lupus, and you can see why. Malar rash, photosensitivity, ANA, oral ulcers, inflammatory arthritis, and maybe not the typical muscle findings that we find in dermato. A skin biopsy is indistinguishable between lupus and dermatomyositis, and the older criteria did not allow identification of patients who had the skin version of dermatomyositis, amyopathic dermato. So one of the things is that with lupus, there's sparing of the nasolabial fold. In typical dermato, there can be involvement of the nasolabial fold, typically a more violaceous color to the rash, as you can see in the middle, in the man in the middle. But I want to emphasize the erythema that you can see in the person on the right with darker skin color. There's a heliotrope with erythema. There's malar eruption on the face. There's dyspigmentation on the forehead. And all of these are very troubling and very concerning for patients and for their physicians. So a few years ago, we tried to look at our patients with dermatomyositis. And at that time, there were 232 that we were able to identify. And about 44% of them were diagnosed with dermatomyositis when they came in the door. The others, we felt, had dermato, but what did other people think they had prior to referral? Well, 37% were called lupus, 29.5% undifferentiated connective tissue disease, and then the rest were either undiagnosed or other, with other being things like psoriasis, eczema. Some of these patients had gone 10 years without a diagnosis, had been put in light boxes, had gotten all the psoriasis meds you could hope for, and still had their disease. I just want to talk about a case actually from last week, a patient who had a history of SLE for 30 years. You can see the manifestations there. Had been on hydroxychloroquine, had ulcerative colitis, got many meds. New onset very recently of dry eyes, dry mouth, dyspnea, dry cough, proximal muscle myalgia, tightness in the muscles, and dysphagia. And she'd been diagnosed in our own clinic by one of the residents as rosacea. She did have some livido on her legs, new alopecia, no muscle strength issues. She had erythema on her scalp, face, involving the nasolabial fold, via the neck, elbows, over her joints, and along extensor tendons. And she had proximal nail fold changes with some cuticular overgrowth and some dilated vessel looping. Here you can see the erythema over her knee. She has a heliotrope. She has erythema involving the nasolabial fold on her face and on her forehead and her chin. She has mild erythema extensor arms and via the neck. And it is really difficult for patients like this to get properly diagnosed. And basically, we will talk a little bit more about that, but this is the kind of patient that we see quite frequently. So one of the things this has led me to is to look at the skin manifestations in patients who have clinically amyopathic DM relative to classic DM in terms of their frequency. And what I'm showing you here that you can't see is just that every single manifestation, whether it be erythema over the joints or malar area, are identical in terms of the frequency that we see in patients who have classic DM versus clinically amyopathic DM. I do want to highlight at the bottom there mechanics hands, which we see in about 50% of patients who have classic DM and 60% who have clinically amyopathic DM. So this is not a specific finding for a subset in terms of antisynthetase versus non-antisynthetase. We see this very, very frequently in dermatomyositis. So luckily, we now have criteria that at least allow including these patients if the diagnosis or identifying patients as having dermatomyositis by this classification criteria that was done in 2017 under the leadership of Ingrid Lundberg. And you can see that there were 3 criteria that were identified in the skin: heliotrope, Gauthrin's papule, and Gauthrin's sign. And with these criteria, if you have 2 of these, then you can be determined to have dermatomyositis. And this is a huge advance because these patients are quite frequent. They're half of my practice and at least 20%, and I suspect more, of the patients who have dermatomyositis. In our database, we found that about 73%, 74% of patients could be identified with these 3 criteria if they had 2 out of 3 of them. It still leaves a little bit of a gap. And we've done some work and have some proposed criteria for dermato skin findings that has been completed. And now we've been able to incorporate the variables that we've identified into the next version that's being worked on now of the dermatomyositis classification criteria, including more skin variables. Hopefully these will be identified. I will mention, in retrospective capture of skin data can be difficult because detection of skin variables ideally should be done prospectively to be accurately assessed, and many skin variables are not included in routine EMR records. And so as opposed to, for instance, looking at EMGs, or looking at muscle biopsies or blood tests, this is really quite different and quite important. So what are the findings that we're looking for? I have a list of some of them here, and I think you all are pretty familiar with these. I just wanted to go through some of the morphologies and perhaps also emphasizing the variation that we can see. So we saw the Shaw sign, another variation of a Shaw sign going up into the neck, into the scalp. This is so pruritic that patients cannot sleep, and they're very, very miserable. So here's another presentation, and this is not exactly what you and I think of as a Shaw sign, but this patient had the erythema over her joints, she had abnormal nail folds, and she had this morphology on her back, which on biopsy showed interface dermatitis, and she does have dermatomyositis. But again, I think one of the problems is this can look so many different ways. We saw the V-neck here on the left, again, very common characteristic that we've seen. And then erythema over the joints, which is now in two of the three classification criteria, either sign or papules. But you can get them also over the elbows, you can get them over the knees. And in case you didn't think you could get papules on the elbows or knees, here you go, or Gotrin's papules on those locations. Typically, it's more just erythema, but again, emphasizing how variable this condition can be. Now the nail folds, anybody who comes to my clinic, I'm carrying a dermatoscope and I'm looking at nail folds. And what you can see here is the kind of, on B for instance, dilated blood vessels. You can get cuticular overgrowth. There's dropout of vessels. On C, you can see hemorrhage. And there's so many different morphologies, but when you see this in a patient that has the kinds of skin findings that I've been showing you, you've got to think about dermatomyositis. You can see these findings in scleroderma, but that's not from a clinical perspective what we're usually looking at in these kinds of clinical presentations in the skin. And lupus typically does not look like this. So I would encourage you, it's very easy, it takes just a couple of seconds to look at the nail fold, and it's been very helpful for us. You can get this kind of extensor erythema over the arms. Certainly the Holster sign is worth looking for and is not uncommon at all. You can see erythema here. MDA5 has its own special look. Here you can see papules on the palms, which is a typical location. You can see ulcers over MCPs on the hands. You can see the arthritis that you can see in MDA5 along with the changes on the hands. And again, many different colors of skin that can be that we see with this condition, and it's really important to recognize. Here you can see a heliotrope. You can see it's erythema and scale on the left, very bright erythema. On the right, harder to see. Darker skin, it's harder to see. But if you look in some of the lighter areas, there is erythema. If you look at the medial canthus areas, there's erythema. And this often results in the kind of dyspigmentation that we're seeing on the forehead and on the cheeks. And this is also a huge issue that is one of the reasons why we need to be able to treat these patients effectively, to try to minimize this kind of result. And here you can see, again, heliotrope. On the left, you can see there's dyspigmentation, there's some scale, but you can also see erythema, especially on the right eye laterally, and that's what one has to look for to determine if there's still activity or not. Admitting that there are some patients who may get so pigmented early on that it's hard to see erythema. Often those patients will be itchy, and you'll see scale, and we'll talk a little bit about what happens over time with this pigmentation after treatment. And then on the right, you can see erythema on the lid margin, also on the malar area with some scale. But you can also appreciate dyspigmentation, and these things go completely together. And if you can get rid of the erythema, one can prevent progression of dyspigmentation. And one of the ways this was shown was in the IVIG study, which led to the approval of IVIG for dermatomyositis. And what this is looking at now here is the skin, and you can see that there was not much improvement, very slight placebo effect in the red line there on the left in A. But you can see that the efficacy of IVIG is pretty clear. And what's really interesting is that the damage on the right in B, the CDASI damage, improved also, which we did not see in the patients who got placebo. So I think a lot of times we think that damage doesn't get better. And one of the things about skin is we can actually see it. I think joints and muscle, much harder to see, much harder to evaluate activity versus damage. And I think damage in some patients can actually get much better over time. And this is a good example of that, and potentially something we want to think about for, as we include or are more inclusive in our trials. So what about other findings? So anti-TIF1 gamma has more extensive skin involvement. You can get palmar hyperkeratotic papules. The lesions can look like psoriasis, and I'm convinced that's why so many patients get called psoriasis. And again, where a biopsy could be helpful. Hypopigmented red on white telangiectatic patches can also occur. There's less calcinosis, and often these patients have other findings that are fairly mild, although we worry about the malignancy association. So here you can see the psoriasiform changes. Again, biopsy is going to show likely interface dermatitis or lichenoid dermatitis. And on the right, you can see the hyperkeratotic lesions over joints, which is characteristic of TIF1 gamma. But also on the far right, you can see the kind of keratotic lesions that can occur, again, emphasizing the really big differences that one can see in patients who have dermatomyositis, somewhat atypical keratotic minute papules. This is red on white on the left. You can see hyperkeratotic palmar papules on the right. Again, TIF1 gamma. If you see these, it's certainly a good clinical correlate. You're still going to want to get the antibody test. So what about Wong-type dermato? This one looks really different also. You get erythematous and hyperkeratotic follicular papules. You can see that here on the chest on the right. But often, these patients will have a typical dermatomyositis rash like heliotrope eruption or Gotrin's papules. And again, I want to emphasize on the left that you can appreciate that there's been hyperpigmentation, for instance, on the forehead, on the chin, but you can see erythema over the eyelids, and that this patient, and also malar area, that this patient still has activity. So what about poikiloderma? We consider more the damage side of things. We see telangiectasias, dilated blood vessels, and dyspigmentation, hypo or hyperpigmentation. And that's all part of what we consider to be poikiloderma. So in darker skin, you can see certainly hyperpigmentation, and also you can see the kinds of changes that you can see both on the left and on the right. But if you look beyond the follicular hyperpigmented papules, you can see erythema between them on the left. And this patient still has ongoing activity, and she has signs of having had a biopsy, which was also showed an active interface dermatitis. And so although we get pigmentation, I think it's very important to very carefully look at the skin, again, with the caveat that some patients, it may be very difficult. Calcinosis is another part of what we see, and it can be either subcuticular on the left or it can be exophytic as it is on the right. We heard a lot today about antisynthetase syndrome, and it was really interesting about the discussion in terms of, lumping or splitting, and it reminds me a little bit of CLE versus SLE, and I think certainly patients with an antisynthetase antibody, high titer, lung disease, they clearly have antisynthetase. But I will also point out that many of the other clinical findings here are typical of our DM cases, and I know they're exclusionary from being labeled antisynthetase, but the inflammatory rashes, mechanics hands we see in 50%, and then arthralgias and muscle involvement, ILD, are pretty common. So I think we are dealing with the lumping, splitting kind of situation. We've had that discussion among our own community at different times. And so I think the probable and possibles are going to end up being part of a continuum, including patients who often would meet criteria for dermatomyositis. And one of the ways you can look at that is we looked at patients who had antisynthetase antibodies and had been called antisynthetase syndrome, but had some of those inflammatory skin eruptions. And we did biopsies from patients who either in the middle are the DM patients or those who were labeled as antisynthetase. And what we wanted to do was sustain for, in green, interferon beta, which you can see at the top, which was really the same between the dermato and antisynthetase patients. And you can see the mix A at the bottom, again, staining for a type 1 interferon upregulated protein, is present in both of them, as opposed to the healthy control, where you can't see that. So I think it's another example where we don't want to not be able to give our patients who we might label antisynthetase drugs that might work for DM. In the case here, the interferons seem to be a bit of a driver. And so it is going to be, I think, individualized medicine, but we're going to have to really think about how we categorize our patients. Mechanics hands are here. Symmetric, non-pruritic, hyperkeratotic, scaly, fissured patches, linear papules or plaques on the lateral aspects of digits, most prominently on the ulnar thumb and radial index, and it can extend to the palmar surface and distal fingertips. Again, we're seeing this in about 50% of our DM patients, so it's not a specific finding for one subset or another. I do advocate histologic diagnosis when it's not clear, and I think in general it's really helpful, especially in amyopathics, to do that, and look for vacuolar interface dermatitis, which is present in about 70% of patients. There's dermal mucin in about 71%. And in some patients, there's a superficial perivascular inflammation, which might be the only manifestation. So a little bit like antibodies, which can be negative in dermato, the biopsy is not always helpful, and I warned the patients about that. And it's more if you see these changes that are typical of an immune disease, autoimmune disease, whether lupus or dermato, like the vacuolar interface or interface dermatitis, that one, I think you can start to feel much more comfortable with the diagnosis. So these are some of the histologies that you can see. On the left, a subtle interface dermatitis. In the middle, a lichenoid dermatitis. And then on the right, a perivascular inflammation. That biopsy is very nonspecific. It's not going to be that helpful, but the others can be quite helpful. I also want to make the point that in the skin, the cells that are dendritic cells tend to be myeloid dendritic cells. And you have to look pretty hard to find CD123 plasmacytoid dendritic cells. And this is really different than lupus. And it may speak a little bit to the differences in terms of the interferons that we see as our drivers between lupus and dermato. But what you can see on the right is it's basically the CD11C cells are quite prominent relative to CD123. At the bottom there. And so this is a fundamental difference between between DM and lupus. Now, pink versus red, again, very different in different skin types. On the left is pink, on the right is red. And at the top, you can see kind of lighter skin, and it's easier to see the difference between pink and red. In the middle, it's darker skin, but there's hypopigmented areas, and you can see some erythema in the lighter areas, and you can see erythema on the cheek, in the red cheek there on the right. And at the bottom, very much darker skin, but clearly can see the heliotrope in the red and the erythema on the face. And so, not easy, but I think it's a feature of what we have to deal with as we try to evaluate our patients. We did look at this a little more carefully by looking at the C-DASI erythema mean score, and what you can see here is there's no difference between classic and amyopathic DM in terms of the degree of erythema. And we also used our CDM IGA that we published back in 2023. And what you can see is that the white and black skin is somewhat different, but not that different. They both are predominantly pink. And you can see the white is about 1.29 is the average erythema score, so close, a little bit above the pink will be 1, 2 is red. So it's a little bit higher, but not dramatically higher. And this is looking at the percentage of people who have pink versus red, and you can see again that people with black skin are more likely to have pink, 82% versus 66% of those with white skin. So we really have to examine our patients carefully to evaluate their degree of erythema. So what about outcomes in the skin? Well, we know that, as I mentioned, half my population of patients have classic dermato, the other half are clinically amyopathic. And about 40% of the classic DM patients become post-myopathic after a median of 3.8 years. So skin disease frequently persists after muscle disease gets better. And 5% and the other flip side of this is that 5% of patients with clinically amyopathic DM, if they go the 2 years and haven't gone on to get muscle, it's pretty rare to develop muscle disease. So we do have, between the post-myopathic and the CADM patients, we have a lot of patients that we need to be able to treat. So the CDASI is a score for looking at activity in the skin and damage. We know it's mild and moderate. We know it's responsive. We know it correlates with quality of life and biomarkers. And it's been used in many trials, as we've heard about during this meeting, and it's working in separating treatment from non-treatment. This is an example where it's correlating, the CDASI score as it goes up is correlating with the CXCL10. And you can see interferon beta is also correlating nicely. So if you look down at C, you can see that as the CDASI activity score increases, so does the interferon beta score in the blood. So it's correlating with biomarkers. This is the TIS, and it's been used as the primary efficacy measurement in current dermatomyositis trials. And it's from a regulatory perspective that is happening, but unfortunately it lacks a skin-specific measure. And the skin is, as we've discussed, a defining feature of dermato and disease characterization. But because TIS is largely a muscle measure, it has led to inclusion criteria that don't allow us to include our patients with clinically amyopathic dermato or post-myopathic dermato. This actually can translate into not being able to get drugs for patients when they're approved for dermato, when the trial has only been done in muscle patients. Even with a label, the insurance companies don't necessarily pay for these drugs. So I'd like to advocate for including different types of patients in trials so that we can use these new drugs that are coming along, and it's miraculous for all of our patients. We have a score called DMOMS, which gives equal weighting to MMT and the CDASI. And what that would allow is including both muscle patients and skin patients in trials using the same outcome measure, but stratifying on what is the predominant feature of the disease. And this has worked well or better than TIS for muscle responders in several trials. And this is largely because so many of our patients with muscle disease have skin disease. And it may allow inclusion, again, as I mentioned, of skin-predominant DM patients in trials. We can get these drugs for our patients. And with DMOMS, we could stratify, as I said, and have inclusion criteria that would allow deciding on enough severity for muscle or enough severity for skin to include patients in the same trial and get quicker enrollment in trials and get approvals. So in conclusion, the skin has a dramatic impact on patients with dermatomyositis. The myriad skin findings make diagnosis difficult at times. Skin biopsy helps rule out other diagnoses. Erythema in skin of darker skin patients can be more difficult to detect. Hyperpigmentation can improve with removal of inflammation after treatment. And validated outcome measures for skin are working in clinical trials, which is very exciting. I would like to acknowledge the work of many, many fellows over quite a number of years. My statistician, coordinators, and Sarah June, who's a student who's here at the meeting and had a poster yesterday, as well as my funding sources that you can see here. And I want to thank you very much.
Thank you very much for this very comprehensive overview of all the manifestations of skin in myositis. I think we have a question from the audience.
Yes, thank you. Galen Folk, also from the United States. Hi, Dr. Wirth. I'm wondering if nail fold capillary changes, do they need more prominence in classification schema for dermatomyositis? Not for their specificity, but for their sensitivity. I feel like even in my very small number of dermatopathic DM patients, I'm still able to identify nail fold capillary changes there. It's become really the first place I look when I see them.
Yeah, no, they're very helpful for diagnosis, no question about it. I think they don't respond so quickly, so in the setting of a more limited time scan of a trial, they may not improve enough, but very important, and dermoscopy works really well, and I agree with you.
Yeah, I think more for classification than following in like clinical trials.
Yeah.
Thank you.
Hi, Vicky. Thank you so much for your lecture. I have a question for those patients who have their skin disease pretty well controlled, but there is persistent nail bed erythema, some goitrons, but no other signs of disease activity elsewhere. So how do we interpret the disease activity in these patients? Do you still consider them having low disease activity, or are these nail bed changes or even just erythema some signs of chronicity only?
Yeah, so if you look, for instance, at the CDASI, it has a high score. The hands go trends if they're dark red, and a papular, that's a count of 6 right there, and you have other changes in the skin. So I think they're very important. They're very refractory to treatment. They're very bothersome to patients. I think that there are 2 issues about severity. One is what's the total score, which takes into account other areas, but also how much it impacts the patient. And so we've tried to rate the areas, give higher ratings to things that really bother the patients the most. So you bring up a really important point, but also why we need better treatments, because they're so refractory to most of our treatments.
Any other question? I think it's important also to raise the importance of itch in dermatomyositis, because different from lupus, it's really very itchy and it can disturb sleep and...
Yeah, totally, yes.
Yeah.
And quality of life measures in studies is really important because of those kinds of things, looking at itch and pain and looking at other impacts.
Yeah, there's another question.
Hi, thank you. Thank you for your wonderful talk. I wanted to ask, if I understood correctly, we would more commonly identify pink skin instead of red in people of color. Does this mean that we may be underscoring their disease activity and maybe undertreating as well?
Sure, I think there's certainly that possibility. And so being aware of that and trying to recalibrate, I think, is part of it. But the differences weren't that great, but they're clearly there. And so I think it is important. It's sort of training the eye to look at different skin types. Those are my values, so I take full credit for that. Yeah.
So any other question? So I think we want to thank you
Thank you.
for your presentation. And really, to show how dermatology can be important to diagnose initially the lesions and recognize dermatomyositis, which is really important. So you should frequently ask for the help of a dermatologist. So with this, we go to the next presentation.
Well, now we will move on for the selected oral presentations, section 3. We are 10 minutes ahead of time, so I don't know if the speakers are already in the room. Maybe I will call the first one, Dr. Lucia Wernerova from the Czech Republic.
She's there.
Okay. Dr. Lucia Wernerova will present the oral communication, circulating and muscle FCTL3 in the idiopathic inflammatory myopathies, associations with disease activity, inflammation, and functional status. Thank you.
So first of all, thank you very much for the opportunity to contribute to all the wonderful talks during this meeting. I'm a biologist. I'm a postdoctoral fellow at the Rheumatology Institute in Prague. And today I will share with you some of our recent data involving also follistatin-like 3 protein and its association with clinical and functional outcomes. I have no disclosures. During the past 10 years, let's say, we've been interested in a negative regulation of muscle mass growth, as we think that this is an important non-immune mechanism that could contribute to a persistent muscle weakness even after suppression of inflammation. And mostly we've been interested into myostatin as a dominant negative regulator of muscle mass, and myostatin does not act alone. There are other factors or proteins related to its function, and part of them are negative regulators of myostatin. They inhibit its binding to the activin type 2 receptor on the muscle cells, and among those negative regulators is follistatin and follistatin-like 3 protein. And when the binding is successful, the signaling cascade leads to gene expression of factors that are involved in muscle atrophy, and also the signaling inhibits the muscle cell differentiation, and myostatin also has a negative Previously, there were around 10 years ago, there were several attempts to inhibit myostatin in clinical trials, and the aim was to increase the muscle mass in patients with muscle wasting diseases, but these trials were with limited efficacy. And in a study by Marriott in 2017, they proposed the reason why there was the limited effect of these studies, and they showed in patients with neuromuscular diseases, and they also involved patients with IBM, that the myostatin was lower in sera and also in muscle tissue. It was the gene expression compared to healthy controls, and also in IBM patients it was lower. So actually, when the levels were already decreased, that might be the reason why the myostatin blocking therapies did not work well. And by that time, we also measured myostatin in our myositis patients. We measured in sera, and we also performed the gene expression analysis in muscle biopsies, and we also found that the myostatin was lower in myositis patients compared to healthy controls, and also the gene expression correlation network was visibly different in patients compared to controls, and in terms of particular components of the signaling pathway, they were also attenuated in myositis patients. But what was more important than the levels of myostatin in sera correlated with disease activity, and there was a negative correlation, so lower levels of myostatin were related to higher disease activity, to higher CRP levels, and to lower muscle strength expressed by MMT8, which is actually contrary to an original expectation, because as a negative regulator of muscle mass, it would be understandable to expect increased levels in muscle wasting diseases. And a few years later, the same observation was published by a French group led by Professor Allenbach, and they showed on the bigger cohort of myositis patients the same, that the myostatin was decreased, and also they showed the attenuation of myostatin signaling components, gene expression in muscle tissue. But both of these studies were performed on patients with established disease, in chronic patients. So there are mechanisms that could contribute to these findings. It's the muscle damage caused by the long-term auto-inflammatory process, and it's also the long-term therapy that can have an effect, a significant effect. So in our recent project, we decided to monitor all these parameters in newly diagnosed patients to see the situation at the onset of disease. So we have done, again, the analysis of serum concentrations of myostatin, follistatin, and also follistatin-like 3 protein, and we found that the alterations are even more profound in patients with newly diagnosed disease. So the myostatin was even lower than in chronic patients, and follistatin was higher, and also was follistatin-like 3 protein higher in myositis patients in general compared to healthy controls, and highest in the group of newly diagnosed patients. We followed these patients for 6 months. We actually are following them today, but I'm showing the data after 6 months, where most of the proteins did not change significantly, but myostatin increased during the 6 months of standard therapy. We also performed the gene expression analysis on the signaling components, and in the newly diagnosed patients, they surprisingly were upregulated compared to chronic cohort, and this is visible in many of the components of the signaling. And when we looked at the gene expression of all the genes involved, and the pattern of gene expression on the heat map, we see that they have a different pattern compared to healthy controls and chronic patients, which was also supported by the principal component analysis that showed clear separation of this newly diagnosed group compared to chronic patients and healthy controls. We also looked at the protein in the muscle, which has not been done before, and it was the same situation when the myostatin itself and the components of its signaling were increased in newly diagnosed patients compared to chronic patients and healthy controls. And interestingly, the myostatin protein decreased after 6 months of standard therapy. And now I come back to the FSTL3 protein, which we initially did not aim to study any further, but it showed, it was like a part of the whole story as a negative regulator, but it showed interesting association with clinical and functional parameters. So how FSTL3 could be involved in the mechanisms that are important for myositis pathophysiology. It could be involved in muscle mass regulation as it antagonizes TGF-beta family members, and among them also myostatin. It could be involved in immune modulation as it also antagonizes activin A, which is involved in inflammatory cytokine production, and it also could be involved in fibrosis pathways activation. So it seems relevant for many important processes. And in addition to the analysis involving the whole patient groups, we also looked at the myositis subgroups, and we saw that the FSTL3 levels were highest in patients with anti-synthetase syndrome. We also stratified the gene expression analysis for myositis subgroups, but there was no clear pattern. But when we look at FSTL3 itself, then we see that it's different than in SERA, that here the highest gene expression was found in IMNM patients. And in another step or further step, we performed association analysis with plenty of clinical data. We decided for linear mixed effects model, which enables the controlling for confounding factors. We decided for factors such as age, glucocorticoids, daily dose, body cell mass, and serum creatinine, as we think that these could contribute, and especially in myostatin biology, these are relevant factors. And this table shows the associations that were significant even after adjustment for these factors. And we see that FSTL3 was significantly associated with CRP, MyoAct, and mental and physical component score of SF36 questionnaire. And this figure shows the result of the analysis stratified even more to stratified by sex, so separately data shown in women and men. And it's interesting that the association remains significant only in female patients. So, and we see that higher levels of FSTL3 were associated with higher CRP, with higher MyoAct, and with lower physical and mental score of SF36. And these highlighted p-values represent the change in the whole group, even when the time change was involved. So it's observation from baseline and after 6 months. And we also stratified this analysis for myositis subgroups. This is quite a complicated figure, but what I wanted to show is that after this stratification, the associations remain significant in patients with anti-synthetase syndrome, which could suggest there might be some processes that are specific for particular myositis subgroups that could be relevant for the FSTL3 contribution to these results. And to conclude, our recent data show that early myositis is characterized by marked dissociation between reduced myostatin serum levels and enhanced myostatin signaling in skeletal muscle, which could possibly reflect a catabolic state driven by acute inflammation and cellular stress at disease onset. Circulating FSTL3 emerges as a potential marker of systemic inflammation burden, inflammatory burden or inflammation and patient-reported disease impact. And I'm sorry, I forgot to mention that those analyses I showed you were adjusted for body cell mass, as we think that it's a parameter that is affected by the disease mechanisms itself and also by the muscle disuse due to reduced physical activity. So therefore, we can conclude from the previous data that observed associations of FSTL3 with clinical and functional outcomes were independent of variation in metabolically active tissue mass. And I would like to thank my colleagues from our group led by Professor Vencovsky, and thank you for your attention.
Thank you very much, Dr. Lucia, for the excellent presentation that is open to discussion. I will make you a question. I am a lung physician, so the question is about lung. Do you have data about the inflammation on fibrosis on lung and this glycoprotein?
Yes, we have the data, but I think those were not involved because we only, so far, we've still collect the data. And so far, we only have the information about the presence or absence of ILD. So, which is...
So all the patients doesn't have, it's an exclusion criteria to have ILD, is that so? The patients that you studied doesn't have ILD.
I'm sorry, and you asked if we involved this information in the analysis.
Mm-hmm.
Not particularly, like we haven't looked at the association of ILD with these proteins.
Okay.
Like, I mean, among the parameters involved in the analysis.
Very well. And do you feel that this glycoprotein could be a marker of progression, but do you feel that it's preclude the evolution, for instance, in the other parameters?
I'm sorry,
you have some markers that tells you that disease is progress. Mm-hmm. Do you feel that this glycoprotein anticipates that data or no? It's one more.
I think these are first preliminary analysis, so it would need more deeper approach in terms of even the statistical approach, because these were association analysis. I think for the prediction we would need to use different statistical method, and maybe it would be better to have more of the longitudinal data, which we still collect. So hopefully later we will see if it's possible for FSTL3 to work as a predictor of a progression.
Okay.
There's one question from the audience, please.
Yeah, Pedro Machado, University College London. So there's an inverse relationship between follistatin-like 3 and myostatin, right? My question is there any added value of measuring follistatin-like 3 compared to myostatin, or do you see the same relationships, although on a different direction if you measure myostatin? So is there any added value of measuring follistatin-like 3 as opposed to myostatin?
I'm sorry, I'm not sure if I understand the question.
So you're proposing that this could be a biomarker, a monitoring biomarker, for example, because there is a relationship with disease activity, right? And the higher the disease activity, the higher the level of follistatin like 3, correct?
Yes.
Yeah. But with myostatin, you also see that, but the relationship is the inverse relationship.
Yeah.
My question is, are you not just observing the same that you had already observed with myostatin? Is there any added value of looking at this marker as compared to myostatin?
Yeah, I see. Yeah, it is possible. Well, we need to think about it, how to approach it as a negative regulator. Yeah, that's a very good point. Thank you.
Is there any other question? I think not for the moment, so thank you for...
Thank you very much.
Now we move to the next oral communication by our American colleague, Agvar Rowit. Are you there? Oh, yeah. We will be listening about safety and early efficacy of new autologous CAR T cell with a very strange name. I do not dare pronounce it, in severe refractory idiopathic inflammatory myopathies. Sorry for the...
Thanks for inviting to present this data. This is the first time we are declaring this data. This is the safety and efficacy of, again, I have the same problem, rapcabtagene, but it's called RAPCell, so I'll use the word RAPCell more commonly during the presentation. It's an autologous CD19-directed CAR T therapy in severe refractory idiopathic inflammatory myopathies. So here are our disclosures of all the authors that are involved. So first, I think this audience doesn't need this introduction slide, but we know that idiopathic inflammatory myopathies is rare, systemic, autoimmune disease with primary target of muscle and/or skin and multiple other organs, including lung. Despite multiple immune suppressive drugs and steroids that we use and some new targeted therapy now being tested, many patients remain refractory and continue to require a lifelong immune suppression, including significant doses of steroid. We have seen the promise of CAR T targeted, CD19 targeted CAR T therapy, which has a potential to induce rapid and complete B-cell depletion, almost leading to an immune reset, and that can be a path for a sustained remission, hopefully a drug-free or minimal drug remission in patients with severe refractory autoimmune disease, including IAM. RAPCell is a rapidly manufactured, it's manufactured on T-Charge platform, autologous CD19 CAR T therapy, which is currently being investigated in multiple autoimmune disease as well as neurological disease and hematological malignancy. Today, I will present you the results of safety and early efficacy from cohort 1, which was a safety cohort of n = 6 for phase 2 autograph IAM study, which evaluated RAPCell in patients with severe refractory IAM. So first, what's RAPCell is? Basically, it's generated using the T-Charge platform. Now, what's the difference between the T-Charge platform RAPCell versus traditional CAR T manufacturing? There are 3 things. One is the time to infusion is way shorter because the manufacturing time is less than 2 days. Now, when you have a low manufacturing time, you're really requiring low dose of CAR T to be given to the patient because most of the expansion of CAR T is happening in vivo. And that also, because you're so quickly preserving the T cells, it preserves the T cell stemness, leading to increased proliferative ability and increased therapeutic potential in the patient itself. As you know, in any CAR T trial, you have to have apheresis followed by T cell enrichment, followed by activation and lentivirus-based transduction, followed by lymphodepletion, and then CAR T infusion. All of this time can be shortened with the manufacturing process, which could be less than 2 days. And this figure shows you the difference between the traditional manufacturing where the expansion has to happen ex vivo, and that's why you have to give the whole dose of CAR T to the patient several weeks later, whereas in this platform, the expansion is happening mostly in vivo. So what's Autograph IAM? It's a multi-part, 5-year, randomized, open-label, but accessor-blinded, active control phase 2 study. So what I'm going to be presenting is a cohort 1, which is a safety study, which all patients underwent lymphodepletion chemotherapy with fludarabine and cyclophosphamide, followed by single infusion of Rapcel. Now, if you see, the inclusion criteria was classic inclusion criteria that we see in all clinical trials in myositis, which has in cellular therapies, you have to meet classification criteria, ACR and EULAR classification criteria. You have to have evidence of active disease. You have to have severe refractory disease and fail multiple immune suppressive agents to get in the trial. What I will be presenting safety and efficacy result of the first cohort, which is n is equal to 6. But what I'm showing on the slide here is the cohort 2 design, which is already active. In this cohort 2, which is currently ongoing, we are giving 2:1 randomization, 2:1 for Rapcel, 2:1 chances to get Rapcel, and 1 chance to get an active comparator, which could be cyclophosphamide, rituximab, mycophenolate, and a couple of other drugs. And these patients will be followed for a primary endpoint at week 52 for TIS of more than 40, which is a moderate to major improvement. Now, if the patient who is on active comparator does not improve by week 24, worsens, that patient can be transferred to Rapcel. So that's a safeguard for the patient who may get an alternative treatment but may not improve and have full progression that can go to Rapcel. So what were the baseline characteristics of the cohort 1? So if you see here, we had 6 patients, 3 antisynthetase, 2 dermatomyositis, and 1 IMNM. All patients were autoantibody positive by design. 3 patients had ILD, and 2 patients with dermatomyositis had very high skin score by CDASI of a median of around 28. Prior treatment failure was around 3 to 5, median of 3.5, which shows that these patients have failed 3 or more treatment. But also corticosteroid dose was ranging between 5 to 20 milligram and a median dose of 10 milligram. If you look at the overall severity, these patients had a median MMT-8 score of 129, physician global of 6.85. So when you get to 7 out of 10, that is considered severe myositis. So these patients had a median score of 6.5. So we're getting into high, moderate to more severe patients in the trial. And also HAQ-DI was 1.5, which shows how disabled these patients were to get in the trial. So what we see is Rapcel demonstrated robust CAR-T expansion in vivo, with a median expansion was around 11 days. And all the patient expanded beautifully, robustly, and then the CAR-T went down, as would be expected in any CAR-T, CD19 CAR-T. And when you look at the B-cell data, what you can clearly see rapid and deep B-cell depletion following by rapid B-cell recovery in about 60 to 90 days. But what's more important that is shown on the right hand of the slide is what type of B-cells that are coming back. That's key message here. We see that mostly naive B-cells that are coming back, whereas memory or switched memory and other plasmablasts are not coming back. So the good thing is almost nearly 100% recovery of B-cell was in naive section. What about the safety? Because when we talk about cellular therapy, CD19 CAR-T, we have to be really be clear about the safety. We have to make sure we counsel our patient about the safety. There are 2 or 3 major issues. One is CRS, then is ICANS, then the risk of infection, and then prolonged neutropenia. Those are the 4 key points that we want to look at. They're called adverse event of special interest. So if you look at the CRS 1 and 2 is always given. You want to have some CRS, otherwise you may think that patient may not be even, drug may not be even working. You really want to pay attention to CRS 3 and 4. In this case, we had 1 grade 3 CRS, which is the patient who deteriorated, required pressors transiently, got onto tocilizumab, and got better. In the median time to recovery on all CRS was around 11 days, and the median time of onset for CRS was 7 days. So even though one patient developed CRS3, recovered very easily with standard treatment. Now, no ICANS, which is great. In terms of infection, one patient developed a UTI and was hospitalized, and that's why that led to a grade 3 infection. And amongst the neutropenia, the 2 patients had grade 4 neutropenia, but they recovered after subsequent days. What about the efficacy? This is again very early results, small number, but let's pay attention to it, what type of magnitude of improvement we are talking about. If you look at 4 out of 6 got major improvement. As we have discussed in past, major improvement is tough to get. And major improvement to get being off immune suppression, and I will show that how many patients, every patient got off immune suppression, and about 2 patients were even off steroid, and out of 5 out of 6 patients were on 5 or less of steroid. So off all non-steroid immune suppression, 2 patients was even off steroid, and 5 of the 6 patients who were on steroid were on 5 or less milligrams of steroid. With that type of concomitant treatment, you're now going to week 16 and 20. So you would think that if the patient was not truly recovering, then that they would start to flare, but it's not in this case. If you see 4 of the 6 had major response, and IMNM, which is the most difficult subset to get better, look at the robustness of response in this IMNM patient. So this kind of really oppose the notion that some people talk about IMNM patient may not recover from CAR T. If you have an appropriate IMNM patient, that patient could have really robust response with CAR T. Now, the other 2 patients I want to talk about is one of them, which you see that is dwindling down to minimal improvement, actually lacks the patient global. There was a missing data, so they're lacking 10 points. And if this patient had 10 points, they would be even higher in terms of improvement. And then the last patient, one of the patients was in the moderate category. Now, what about the MMT8? As you know, MMT8, those who do MMT8 is tough to improve. We talk about if you have 5-point improvement in FMT8 is great. If you have 10-point improvement, it's beautiful. Here you have a median of 13.5-point improvement in MMT8 by week 12 and a median of 20-point improvement in week 20, which is really dramatic MMT8 improvement, except one patient who did not improve in muscle. This is the patient who improved in skin. So sometimes the skin and muscle can be dissociated. Specifically, it could be that the skin was active, but the muscle was not active, had a lot of damage in many patients, so may not improve the muscle. But this patient actually improved the TIS primarily because of the skin and extramuscular component improved. What about physician global? Patients clearly improved. All of the 6 patients improved. Even the one who did not improve in muscle improved because their skin improved. So the overall disease improved. One patient did not improve their HAQ-DI. That's the patient who did not improve the muscle or MMT8, but all other patients improved their HAQ-DI. And if you look at the CK trend, almost all patients who had higher CK plummeted their CK. So in conclusion, what you can see from cohort 1, n is equal to 6, the phase 2 autograph IM demonstrate manageable safety profile and early, clinically meaningful, in fact dramatic, to major improvement in 4 out of 6 patients of RAP cell in these severe refractory IAM patients. Now, we see that there's a rapid and deep B-cell depletion and robust in vivo CAR T expansion. There's also these adverse events were very manageable, and even though grade 3 and 4 happened a couple of times, they were all recovered in a span of a week or 2. Overall, you see 5 out of 6 patients achieve major to moderate improvement, 4 major and 1 moderate. All patients discontinued all immune suppressive drug, and 5 of the 6 patients only was on 5 milligram or less of steroid. Overall improvement in MMT8, physician global, and HAQ-DI were robust. And this study is now recruiting for a randomized cohort 2, which is ongoing now. And would like to invite investigators to contact us if they're willing or wanting to go on to this autograph phase 2 study. Thank you.
Thank you very much on this wonderful data on this new therapy. I think there's a question from the audience. Please.
Hi, Pedro Machado, UCL London. I don't think you mentioned any data about LICATs, because the German group, I think that data is a bit surprising. They published data with around 75% episodes of LICATs, which is not our experience, I have to say. Did you observe any LICATs in this cohort?
Very, very good question, Pedro. No, there was no LICATs in this cohort. You know that LICATs can be confused with disease flare or worsening in many cases, but fortunately, we haven't seen any LICATs. But again, Pedro, it's 6 patients. We need to have more data.
Any other question? So with this new technology, oh, sorry, I didn't.
I'll be really brief. Just given what you've seen so far, do you think this is an intervention that has the potential to actually kind of reset, in a sense, kind of the immune system for these patients, or it's more of something that'll require ongoing control?
That's a great question. The promise here is a long-term immune reset. What is that long-term? Is that 6 months, 12 months, 24 months? Is yet to be decided. But we are really trying to achieve at least 1 year immune reset here. And again, we need to see how the data pans out. But we have seen patients now going into year 2, 3 in multiple autoimmune diseases without requiring any immune suppressive therapy in many of our autoimmune diseases like lupus. So we are hoping it's a long-term immune reset at least, if not lifelong.
Any other question? I was wondering, did you also follow, so you are targeting only B cells, not plasma cells, and you see that then they come back, and you see they come back as naive B cells. Have you followed also the level of autoantibodies, if they really change with the...
That's a great question. That's the next step. We haven't looked at the autoantibody results so far, but that's a really excellent question. What we want to look at is when autoantibody decreases, is that consistent with the improvement that we are seeing? And the patient who's not improving, is their autoantibody not decreasing? And that's a really valid question. We don't have the data yet. This is the first time we have declared these results.
And as far as I understood, there is some difference between the muscle and the skin. I couldn't understand if the skin also improved with this.
Okay, yeah, so that one patient, muscle clearly did not improve. This patient had significant long-term damage, and muscle did not improve, but also had very active skin and extramuscular component that improved. So when you have so much of dramatic extramuscular component improve, what happens is physician global improves, patient global improve. All of that combined leads to TIS improvement. So even though TIS improved, you saw the muscle was flat.
Yeah, we usually, even with other therapies, sometimes we see the skin improving and the muscle not, or most of the times the opposite. Muscle improves and the skin still keeps affecting our patients.
Absolutely.
So, is there any other question? If not, I think I have to thank you for bringing this data to us and sharing with us. Thank you very much.
Now we will go for the third presentation. It's oral communication 204, risk stratification and immunosuppressant use in reducing respiratory progression among anti-MDA5 patients, Japanese and Taiwan study. Ting-Yun Lan. I hope that I spelled well.
Yeah, that's correct. It's Ting-Yuan. Yeah, it's very hard to pronounce. Good afternoon, everyone. I'm Ting-Yuan Lan. I'm from Taiwan, and it's actually my first time in Gcom, and I'm very grateful to be here to share our clinical study results regarding anti-MDA5. I have no disclosure. And while the ACRS guideline recommend dual immunosuppressive agents for patients with anti-MDA5, we all know that the necessity of universal intensive combination therapy remains controversial. That's because the disease progression is actually highly variable, and there's significant infection risk of strong combination treatment, and also actually the treatment effectiveness is inconsistent. And many risk factors and prediction models has been proposed and identified. However, patients may present at a different stage of ILD. And we all know that the severity of ILD is actually the most important prognostic factor. So it challenges the model prediction. And also, most risk models lack external validation. So in this study, we aim to stratify the risk of respiratory progression specifically in patients without respiratory failure. And we aim to develop risk model in Asian cohort and validate existing models from literature. And we will also want to explore treatment effects in our cohort. And this is a collaborative retrospective study between Taiwan and Japan, including patients from 2008 to 2025. In Taiwan, we use live blood assay for screening and followed by ELISA confirmation for anti-NDA5 antibody. While in Japan, ELISA was used as primary testing method. Importantly, we also include patients with isolated lung involvement who were tested for anti-NDA5 due to unexplained RP-ILD. And then we classify ILD into 3 stages based on our clinical experience when patients present to us. The first stage is no or subclinical ILD, defined by minimal respiratory symptoms in HRCT parenchymal involvement less than 10%. And second stage is clinical ILD, which means symptoms, there are respiratory symptoms, but there's no or just mild oxygen demand, and HRCT parenchymal involvement is more than 10%. And final stage is the respiratory failure, defined by more than 10 liters per minute oxygen use or using positive mechanical ventilation. And here, we include 99 patients, half from Taiwan and half from Japan. And most patients present with subclinical or clinical ILD stage, but 20% patients already had respiratory failure at diagnosis. And notably, some of the patients with respiratory failure had isolated lung involvement without skin, without muscle, without joint symptoms. So that's highlighting the diagnosis and treatment challenge. And in this patient, in patient with respiratory failure, they had significantly higher CRP, ferritin, LDH, and neutrophil to lymphocyte ratios. And not surprisingly, patients present without respiratory failure have much, much better prognosis. In contrast, 3-month survival was only 20% in those with respiratory failure. So I think these 2 patients should be treated and managed quite differently. So a lot of previous literatures analyze all the anti-NDA5 as a whole cohort and will make some of the conclusion or the models quite difficult to explain. But if we focus just the patient present with non-respiratory failure, which means they present to us with clinical or subclinical ILD stage, there are still 20 to 30 patients will progress within 6 months. They progress to respiratory failure. So we focus on these groups, and then we want to develop a risk model. But due to a limited number of events, we use loss regression first to identify variables and select 3 key factors based on our clinical experience and determine the cutoff for these variables. So the final model, we call it AAC model. First one is the age, the cutoff is 50. And the second one is acute onset, which means the symptom duration less than 6 weeks upon diagnosis, and CRP with a cutoff of 1 milligram per deciliter. And each factor score 1, so the A score can be ranged from 0 to 3. And for easier clinical use, we group the score 0 to 1 to low risk and score 2 to 3 to high risk. And then also, we want to validate the existing flow model. And this model is developed from Hong Kong myocyte cohort, and it's quite very useful clinically. And then from the table, we can see that the respiratory failure rate in our cohort based on the flow score is actually quite similar to the RP-ILD rate in the original Hong Kong cohort. Again, we simplify the score to low and high risk. And next, we test the accuracy of the model prediction for respiratory failure. And then we can see that both models perform quite well. The AUC of both models at different time points, more immunosuppressive use, no matter use mono, dual, triple, it actually did not prevent respiratory progression. Yeah, so it's quite surprising to us. But if we further categorize the treatment regimen to CNI-based, JAK inhibitor-based on other combinations, and we can see there seems to be a trend that JAK inhibitor-based treatment reduce progression in high-risk patients, consistent with recent reports from other groups. So there are some limitation of this study is retrospective design and missing data, and one of the risk factor, symptom duration from our model, is actually affected by recall bias. And one of the famous poor prognostic factor, anti-Rho52, was missing in some of the patients, so couldn't be analyzed and validated in this cohort. And there are variable treatment protocol and treatment strategy changed over time. And so to summarize, risk stratification and for respiratory progression seem to be feasible. And low-risk patients considering show non-progressive features, and treatment outcome may depend on regimen type, not just the number of the immunosuppressant used. And JAK inhibitor-based regimen may benefit high-risk patients. And importantly, future prospective study need to confirm this finding, and hopefully we will have a risk-based treatment strategy in the future. Thank you.
Thank you very much for excellent presentation, please.
About the high-resolution CT patterns in your study. I have the idea that at least there are two major high-resolution CT patterns in these patients. One, organized pneumonia, very cellular non-specific interstitial pneumonia. The other one are patients with non-specific interstitial pneumonia, but with a fibrotic phenotype. Do you have that data? Do you have analyzed it? I think it's a very relevant variable for your risk prognostic factor.
Yeah, the problem it's because we have two different cohorts from Japan and Taiwan, and then we don't have a central radiologist review for both of the cohorts. So we only have the description. So we categorize the pattern for OP and like an NSIP and then UIP and NSIP and OP and undetermined. And then and we put this pattern to the model, but it doesn't show any say statistically difference. I think that's because most of our patients are actually present with OP and or NSIP. So in two of our cohorts, I think 80% of patients actually have predominantly organized pneumonia patterns. So that's why I think it's a more inflammatory rather than fibrotic.
You also mentioned something really relevant, that time matters in this clinical condition. Could you tell us more?
Okay.
What's your idea of that?
Yeah, because first, I think a lot of NDA5 patients actually delay diagnosis because they lack of the skin and muscle and joint involvement. So we encounter them like maybe 6 months or maybe 9 months after their first symptom onset. But we find that patients, if they present very slowly and maybe have a very long duration, actually they don't progress anymore. I mean, for respiratory progression. So we came to a conclusion that patients with very acute onset suggesting a fulminant course of the lung progression. So we put that into the model and shows that the 6 weeks is a cutoff for what we call acute onset. If patient present to diagnose at that time, and it should be very carefully monitored and maybe treated very aggressively.
Thank you.
More questions? I have a question that is in the risk parameters that you studied, didn't you consider any functional parameter or imaging parameter, for instance, because it's frequent?
Yeah. There are lots of reports suggesting that poor baseline lung function predicts poor long-term outcome. But for this fulminant NDA5 courses, I think like most of the patients did not have time for the lung function. So I think lung function may be important in patients that present that not that acute. Yeah, but for patient present quite acutely, I think the other biomarkers predict better than the functional parameters, actually.
Mm-hmm. And the imaging, didn't you consider it?
Yeah, imaging, again, I think there are, as we discover, the more inflammatory patterns have more impact in prognosis. So like the organizing one and also the NSIP, I think. Yeah, but I think that, again, the interpretation of the CT pattern is very hard. So making the conclusion very hard to draw.
Okay.
Can I have a question? Thank you for bringing this data. You spoke about JAK inhibitors that really prevented or reduced the risk of progression. Which JAK inhibitors did you use? And were they as effective in those that had a very acute onset or those, and in the skin also? Sorry for asking so many questions in the same.
Yeah, that's a very interesting question. I think we, as Asians, China, us, and Japan, we have a lot of discussion about the choice of the JAK inhibitors. Initially, everyone used the tofacitinib, but we also find that the dose matters. So usually the 10 milligrams doesn't help a lot. Sometimes you need to use 20. And so later, we start to try to more JAK1 specific. So we start to use baricitinib, and then finally we use upadacitinib. And I think what we discover is similar to the group from China, Renji. So they use upadacitinib, the more JAK1 selective one, and I think that the efficacy is actually better than the non-selective one. So now we all use upadacitinib, 15 to 30 milligrams, depends on the disease severity. Yeah.
Thank you.
Okay. Another question. It's a curiosity. All of these patients that progress were medicated previously, I think.
I'm sorry?
All of those patients that progress to respiratory insufficiency were medicated previously.
You mean all the patients progress?
Yes.
No. If they present to us with a subclinical or clinical ILD stage, only 20 to 30% progress, not everyone.
Yes, but those who progress were medicated previously or no?
Were medicated?
Yes.
Oh yeah, everyone received the medication.
Yes, and I saw that some of them were with one drug, some of them with more than one drug. Is related with different protocols, or those patients were more serious, or what was the...
I mean the treatment protocol. Yeah, I think the problem for this retrospective study is that the treatment protocol varies. So, but I think upon diagnosis, everyone received treatments. So sometimes they receive only one immunosuppressant, sometimes two, sometimes three immunosuppressants at the same time. So what we discovered is just that more immunosuppressant use doesn't reduce the progression, but what you use is important. For example, if you use JAK inhibitor in high-risk patient, if you contain the JAK in the regimen, and then it actually reduces the progression risk.
Okay. So if there is no question.
We have still 5 minutes for questions if you want.
Well, thank you very much.
Oh, there's a question coming.
Sorry.
No, I just wanted to ask what I mean, I always use a JAK in my regime, but I always use cyclophosphamide for the rapidly progressive ones and occasionally add in something else. Are you using cyclo? What in a rapidly progressive, are you just using JAK in some patients?
I think, sorry, because the echo, I cannot hear you
so
clearly.
From what you're saying, it's a JAK inhibitor that matters and not whether you use other drugs. So are you just using JAK for a rapidly progressive ILD, or are you also using cyclophosphamide or another agent?
Yeah, that's a very good question. For now, if we, with JAK inhibitor, we mostly use rituximab or cyclophosphamide. So now we are using a dual regimen, JAK inhibitor with either cyclophosphamide or rituximab. That's what we use in Taiwan. But in Japan, they still use triple therapy mostly.
Yeah, okay, thank you.
More questions? I think now it's okay. Thank you. So we will close the section. It was a very good section about lung involvement and skin involvement. Thank you for your presence. Thank you.
You might not have that problem.
So we should start on time because Brian is long, so we should really. Brian is long? Yeah, so we should switch over at 6 p.m. Okay. Yeah.
One more minute.
Oh, on another time, we have to discuss more about revising the TIS. It's a little bit more to it because we have to also revise the online calculator. I think we should go back to ACRU or to be sure they're going to approve of the revision.
Well, first we need to have a plan.
Yeah.
Then go to them.
Yeah,
If you just
yeah,
go to
yeah.
them,
No, I agree.
yeah.
I agree. But it takes more discussion.
Yeah.
Because we also have to revise the online calculator and the program. So, yeah. Okay. All right, we're due to start.
You got to start? Okay.
Yeah, you start.
You start,
Yeah,
okay.
yeah.
We're gonna, I don't think they have.
Oh, did you press your button?
No, there's no button.
Oh.
I think they're.
Okay, should I go back there?
I can go.
I'll go back to Rohi if you're going to introduce.
Is it good?
Yeah, he said it's really.
Welcome to the clinical trial session. So we have Dr. Barbara Wilkins, a neurologist and assistant professor at Antwerp University, Belgium, who will be talking about peculiarities of cell therapy-based clinical trials. Welcome, Doctor.
Okay, hello, good evening, everyone. Thank you very much for the kind invitation to speak to you about cell therapy-based trials. I feel a bit a stranger in the room since I'm mainly an MS expert and expertise in central nervous system, neuroimmune diseases. Nevertheless, I hope to in the next half hour, teach you something about cell therapy trials and specifically very hot topic, CAR T cells. These are my disclosures. So the agenda, I will talk about some basics of cell therapy. Then we will discuss ongoing clinical trials and specificities about those trials. And finally, I will end with some future prospects and some key challenges for the field. So, cell therapy is actually just very simple, using cells to cure disease. And these cells can be used to regenerate tissue, to replace tissues, or for immune modulation. Frequently used cell types are stem cells like hematopoietic stem cells, mesenchymal stem cells, but also immune cells, of course, and the T cells, but also differentiated adult cells are used. For autoimmune diseases in general, it's preferred to use autologous procedures, meaning that you use the cells from the patient, bring them to the lab, and then give them back to the patient. Allogeneic treatments are, of course, coming from the donor, and they can offer an off-the-shelf approach, which can really help to win time. EMA has made some guidance on cell therapies, and these cell therapies are actually called ATMP, or Advanced Therapy Medicinal Products. And this is the definition. I'm not going to read it to you, but you can read it yourself. That EMA says that they offer groundbreaking new opportunities for the treatment of disease and injury, I think is really true. And we will discuss that later. Of course, these cell therapies are heavily regulated. And recently, in July 2025, there has been a guideline on the quality and non-clinical and clinical requirements for investigational advanced therapy medicinal products of use in clinical trials. And if you're interested, you can, of course, read that document, which is lengthy, on the EMA website. ATMPs are classified into various categories. There are the somatic cell therapy medicines, for instance, mesenchymal stem cells. Then there are the tissue-engineered medicines, for instance, chondrocytes that can be given in patients who have arthrosis. Then there is the category of gene therapy medicines, where cells are manipulated with genes, with DNA, RNA, and this is, for instance, CAR T cells. And finally, you have a category of combined ATMPs, meaning that cell therapy is combined with an injection device or a scaffold. Now, because CAR Ts are the cell therapies most in use in clinical trials nowadays, I would like to go over the basic structure of CAR T cells with you and also discuss a bit how they are produced in the lab. So a CAR T cell consists of the T cell that is either transduced or electroporated with mRNA or lipofected with a small particle to get DNA or RNA in the cell that can then be expressed on the surface and intracellular as the CAR or the chimeric antigen receptor. This receptor consists of an external domain, the antigen recognition domain, and an internal domain which has the function to give signals and to make sure that the immune response starts when the CAR T cell encounters its antigen on the target cell. There are various generations of those CARs, and each generation of CARs has something in addition that it can do better than the previous generation. Most of the approved CAR T-cell therapies for hematological indications are second-generation CARs, meaning that they have an additional co-stimulatory domain to ensure sufficient interleukin secretion and damage to the cells. Third, fourth, and fifth generations include either also an intracellular domain that helps to produce interleukins, or the fifth generations even include some on and off switch domains where you can use small molecules to guide this CAR and say it must go off after a certain time that it's been in the body of the patient. So most target antigens that we use are derived from B-cell mediated diseases because CAR T-cell therapies have really transformed the field of hematological malignancies. And there, of course, B-cells are mostly the problematic cell type. But also in autoimmune diseases, these B-cells are very important. And targets are, for instance, the frequently used target is CD19. Less frequently used target is BCMA, and then there are also various combinations of those targets that can be used to make CAR T cells. So what happens when you give CAR T cells to a patient? First of all, the patient receives a lymphodepleting therapy to allow the CAR T cells to expand in the body. When those CAR T cells are infused, you can see that they expand in the body, so they increase and then they go down over time. And that is also what you see with the B cells. So the B cells go down over time, and after here approximately 100 days, you can see that naive B cells are reoccurring. And this also tells us something about the effect of the CAR T cells, because we see often in case reports that antibodies also decrease over time, and that sometimes you cannot even measure the autoantibodies anymore. So now what is then the advantage of CAR T cell therapy over monoclonal antibodies? When you compare it to monoclonal antibodies, CAR T cell therapies give a much more rapid reduction in B cells. They can also penetrate a lot better in the tissues than monoclonal antibodies. And as you know, monoclonal antibodies require repeated administration, while in general, CAR T cells are a single infusion. And thereafter, the patient is chronically followed up. So this gives the potential for a long-term and a durable remission, although this still needs to remain proven in longer-term clinical trials. So now, clinical trials. What is actually the need, and why is this of interest in idiopathic inflammatory myopathies or myositis? So when preparing this presentation, I also had, again, a very good update for myself about the whole landscape of autoantibodies. And of course, when you see that there are so many antibodies associated with idiopathic inflammatory myopathies, you can appreciate that, of course, B-cell depleting therapies could be beneficial. The current treatment algorithm is a bit dependent on the disease, but the mainstay is, of course, steroids and several older immunosuppressants. And not much trials have been done in the past because all those diseases are relatively rare. But despite all those treatments, there are still big unmet needs in the treatments. Many patients have chronic disease activity and significant disabilities. When you have insufficient disease control, and this is something that you see across several autoimmune diseases, it can result in significant and irreversible damage, and in this case, damage to the muscle or extra muscle, or other organs that are involved in those diseases. You all know the long-term effects of steroids. It's difficult to do large-scale clinical trials. And therefore, we do really need new targeted and preferably mechanism-based treatments to improve the efficacy and the tolerability for the patients. So based on the immune pathogenesis, there are various crucial pathways involved in IIM. And here I will mainly focus on the B cells, since that is the target pathway that you can target with CAR T cell therapies. A little bit also, of course, you can target regeneration with regenerative therapies, but there's not so much in the pipeline for that at the moment. So I did a search on clinicaltrials.gov, and you can see here a nice map of cell therapy trials in IIM and myositis, with almost double a number of trials ongoing in Asia, mainly China. About a quarter of the trials ongoing in Europe, and about half of the trials of China ongoing in North America, and only very limited in South America and Oceania, Australia mainly then. I found 2 trials that are completed, or at least reported as completed in clinicaltrials.gov. That was one phase 1 study in inclusion body myositis, where they used adipose-derived regenerative cells, type of mesenchymal stem cells. I didn't find yet any published results of that trial. And one phase 1 study of mesenchymal stromal cells in patients with polymyositis and dermatomyositis. And there I did find abstracts that have been published that this approach was safe and well tolerated, and there were some improvements in the patients. And a phase 2 study has been designed and is probably on its way. Now, something that the clinical trials with cell therapies have in common these days is that they all use a basket trial design, or at least many of them use a basket trial design. And this is a type of design where various diseases are used, are pulled together because they share pathological mechanisms and are treated then with the same therapy, while a classical trial groups patients with a single disease and then treats them and uses a placebo or an active comparator, or only the new treatment in an open label study. So what do we know about ongoing trials in myositis? I first want to focus a little bit on the industry-driven phase 2 trials. There are 2 phase 2 trials reported in clinicaltrials.gov, one being performed with a CAR T cell that's already been approved in hematological indications by Novartis, another one by Cabaletta Bio, which is named Reset Myositis. And those 2 trials are still ongoing and pending results. I expect that a lot of results will be coming up in the coming 2 to 3 years, between 2027, 28, and 2030. Many of these trials will have their readouts. Then there are also several basket trials. The previous 2 trials are really focused only on IIM, so you will have a very clean population of patients with myositis. In the other trials, there are patients included who have SLE, who have systemic sclerosis, or sometimes also rheumatoid arthritis. It depends a little bit on the trial and the trial design. Most of the CARs used are CD19, but also there are combinations of CD19, BCMA being used. And there is one little bit more specific type of CAR T which used mRNA rather than a classical vector, viral vector to induce a CAR. When you use messenger mRNA to make CAR Ts, in general, they last less long in the body and they have less durable effects than CAR T cells that have been manufactured with a viral vector. And they require then often also repeated administration. The main advantage of this way of using the CAR is that you don't have any risk of long-term integration in the patient's genome. Of course, those classical autologous CAR T-cell therapy approaches have some limitations. There are the timelines to do the apheresis. You need specific treatment centers who can do the treatment. Sometimes those T-cell products, they are not always similar. It costs a lot of money. And there's a huge logistics and manufacturing capacity needed. So that's why there are also other approaches being looked at. So instead of using the classical ex vivo autologous CAR T-cell therapy approaches, one could also go for ex vivo allogeneic CAR T-cell therapies. The risks of those allogeneic CAR T-cell therapies can be modulated by using CRISPR-Cas techniques to knock out TCR, to knock out HLA, and thereby limiting the host reaction to the allogeneic CAR T cell. And a recently more developed approach is in vivo CAR T cell therapy, where there are various ways to use the patient's body actually as a bioreactor, and then you can inject, for instance, a lipid nanoparticle into the patient, which targets the T cells, and then the RNA in that lipid nanoparticle will be encoded in that T cell, and the T cell will become a CAR T cell in the body of the patient rather than being produced outside of the patient. So there have been some phase 1 trials ongoing using allogeneic CAR T cells, and there has been even also one publication from a trial that was ongoing in China with CAR T cells. They published a total of 3 patients, of which 2 of them had myositis. But then on clinicaltrials.gov, this same trial is now stating that it is only accepting patients on invitation and was projected to have 15 patients. And that is already, the last update was somewhere in 2024. So I don't know what happened to this trial. So that's also indeed a worry, what happens to some of these trials. The interesting thing also about the allogeneic CAR T cells is that approaches are being looked at to use prior lymphodepletion, yes or no. And could be, of course, very interesting to have an off-the-shelf CAR T cell therapy. You don't need prior lymphodepletion, and you can treat the patient with an allogeneic CAR. And various companies are again looking into basket trials to look into mainly the safety aspects, but also some preliminary efficacy aspects. Finally, also not only T cells are used, but also NK cells are being looked at, again in allogeneic fashion, because this could be the easiest off-the-shelf approach in the future. I found here 3 trials, also basket trials, ranging from very low number of patients to quite high number of patients to be included. So I'm also curious what will be the results of these trials in a couple of years. I found one industry-driven trial of in vivo CAR T by a Chinese company also, aiming to recruit 12 patients with autoimmune diseases. So again, refractory B-cell related autoimmune diseases, but there are so many different autoimmune diseases included that you may have only 1 or 2 patients with each disease in such a small trial. So it's mainly going to tell us something about the safety, about pharmacokinetics, about is it feasible to make these CARs in vivo in patients with autoimmune disease. Finally, there are not only industry-driven trials, but also investigator-initiated or academic trials. Many different types of CAR Ts, I listed them here, many small trials ranging from between 5 and 50 participants. Lots of the trials are also ongoing in China, some in the USA, and limited in Europe. And then there are also, of course, lessons to be drawn from terminated or withdrawn trials. I found one trial that was done by Richard Burt in Northwestern University in the USA. He tried classical autologous hematopoietic stem cell transplantation, but this trial was halted because of a high relapse rate. I didn't find a final publication. And then 4 trials were terminated because of business decisions or R&D adjustments. So that can also, of course, be a relevant reason to stop. Now, towards the future, some key points we need to address. I do believe that CAR T therapy is a highly promising treatment for B-cell mediated diseases, including myositis. But we do need better definitions of durable remissions, because what is a durable remission, and could you declare somebody cured eventually from a disease? The patient population needs to be defined, responders need to be defined and identified. We need a lot more data on safety and efficacy, because everything we have so far mainly comes from some single case reports and case series, but many of those trials that are ongoing now will inform us about this. Patients will need to be followed up for long term to also indeed define how long does it work. And there have been patients who had a remission for several months, very therapy refractory patients, but who did relapse after some time. So it's also not the solution for every patient. Which target antigen we will choose, which cellular source we will use, if it's going to be autologous or maybe in the future allogeneic approaches, it still needs to be defined. And there are also approaches being done about optimizing all the logistics and the manufacturing for the autologous CAR T-cell approaches. And finally, a big challenge is also phase 3 design in those small populations with rare diseases, where choices will have to be made about which approach the field is going to take forward. And this can only be done by a multi-stakeholder approach, in my opinion, where you have academia, researchers working together with patient representatives, regulators, industry, and also government and payers, because in the end, they are the ones who are going to need to pay for these expensive treatments. And with that, I would like to thank all my colleagues in Antwerp, in Belgium, and funders of our research, and I'd be happy to take any questions if you have.
Thank you, and this talk is now open for questions. Dr. Lundberg.
Thank you for an excellent overview. Of curiosity, did you find any trials with antigen-specific T cells?
There are ongoing trials with CAR, so AA T cells. There are some ongoing in other diseases. I didn't find it for myositis, but maybe I didn't look well enough.
Thank you. We hope for that.
Yeah.
Thank you.
Thank you for the great overview. I was wondering, you said that the allogenic CARs don't need lymphodepletion in front of. Why is that?
Could you repeat the question?
Why do the allogenic CAR Ts don't need lymphodepletion in contrast to the autologous
Why you don't
CAR
need
Ts?
lymphodepletion? Yeah. Very good question, because they also need to expand, of course, in the body. Probably that could be because those allogeneic T cells have been manufactured in such a way that they don't, that they are not attacked anymore by the body's own T cells, because that's one of the reasons why in autologous CAR T cell therapy, the lymphodepletion is also being done to prevent that the patient's immune system will attack the CAR. And with the allogeneic CAR T cells, there are such modifications that they are not so well recognizable anymore to the patient's own immune system. And that's why probably you could leave out the lymphodepletion.
Thank you very much, Barbara. It's really nice to see so many trials coming. Is there any coordination between, I know your experience is in neuroimmunology, like in MS and some of these other diseases, but is there any coordination? Because patients are going to get really confused. Now we've got 60 trials or so, different types, and most patients would hear only CAR T, and we're starting to learn about the other CARs. Is there any coordination with associations or scientific societies such as the EBMT, I don't know, some other people, ASGCT in the US, so that we could start to already think of how to develop guidelines, for advising physicians as well as patients on which type in the future would be good for what kind of disease?
Yeah, it's an excellent question, and I don't know, but I think it's absolutely needed, because if you see how many trials are ongoing, there is some guidance needed from expert societies. It's the multi-stakeholder framework I put forward that is absolutely needed. Yeah.
Wonderful. Thank you very much for this excellent talk. And
our next speaker in this session is Professor Brian Feldman, a pediatric rheumatologist practicing at the Hospital for Sick Children in Toronto, Canada. He's going to talk about the particularities of juvenile trials in myositis.
Thank you very much, and thanks for bringing the slides up. And thank you all for inviting me here to come and talk about this, the particularities of juvenile trials in myositis. I don't really know what that means. I was given that title. So I'm interpreting as meaning if we want to include children in the development programs for new medications or new treatments of any sort, what are the considerations we must have? These are my disclosure statements. The only one that's probably really relevant or important is that I made the graphics for just about all of these slides using AI, and some of them are kind of weird, so you let me know. Now, just a show of hands here, how many folks look after adults primarily? And how many look after children primarily? And both? Anybody look after both? And patients? Any patients here? Okay, not too many patients, all right. So in pediatrics, we commonly say something like children are not small adults, or not just small adults. And certainly when it comes to clinical trials, there's differences we need to keep in mind, and so proceed with caution. And somehow or other, there's a garden inside this lab. Don't ask me how that worked out. So this is a map of what I'd like to talk about over the next few minutes. I'm going to start by making the point that although there are many similarities, there are also some differences in the diseases that the pediatricians look after when compared to the adults. In children, myositis is very rare. And being very rare, there are special issues we need to consider. There's details that we need to consider in terms of medication formulation, especially when we're talking about medications, pharmacology that differ between children and adults and must be considered when we're thinking about clinical trials. Even the outcome measures we choose have to be considered. There are ethical concerns when studying children. Any of you who have children will probably appreciate this. There are regulatory frameworks around the world that we need to consider. And all of these lead to different decisions that we can make about trial architecture to favor the study in children, which might otherwise be hard. And I'm going to start first off by talking about the differences that we see in our conditions. First of all, in children, it is almost always the dermatomyositis phenotype. What I'm showing you here in the left side of the slide, that pie chart, is a study from about 260 adult patients from the French Myositis Network. And you can see there that 30% of them have inclusion body myositis. We don't see that in children. 35% have immune-mediated necrotizing myositis, much more than what we see in children. Contrast that to what you see on the other side of the slide, which is about 200 patients from my hospital in Toronto from sick kids, where 95% of the patients we see have a dermatomyositis phenotype. So right there's a big difference that we need to consider when we're thinking about trials. Now, I asked AI, just for fun, to review all the series that have been published in adults and pediatrics and come up with the differences between childhood myositis and adult myositis. I wouldn't normally include a table like this in a talk, but it was so good It did such a good job, I thought I had to include it. But basically, as I showed you, there's differences in the primary diagnosis, and as such, differences in the pattern of muscle weakness that we see. Children have much more, because it's all dermatomyositis, much more skin vasculopathy and more calcinosis as a result. Lipodystrophy, changes in growth and metabolism, are things we see in childhood myositis that are rarely seen in adults. In contrast, interstitial lung disease is seen much more often in adult patients than we do in children. There is no cancer association. I'm going a little too far. There's almost never a cancer association with dermatomyositis in children, so we don't have to worry about that. The frequency of the different myositis-specific autoantibodies differs. We never see inclusion body myositis, and the overall prognosis is much better in children than it is in adults. These are all things we have to consider if we're trying to come up with a development program that includes children. And it's rare. It's super rare. Childhood myositis is a very rare condition. I asked AI to picture what would it look like if there was one fan for AC Milan and all the rest, and 1 million people, were for Inter Milan. Or, you know, one fan for Liverpool and all the rest were Everton fans. And this is what it came up with. And you can see the one person there in red, but this is really what we're talking about when we're talking about childhood myositis. The incidence is about 1 to 4 per million children per year. And of course, when you have a very rare disease, it makes accrual very difficult. If the patients aren't there, we have to do extra special things if we want to accrue them into clinical trials. And we need to consider medication formulation. Just a show of hands, anybody here have their own children? Probably more than that. Nobody wants to admit it. But, you know, I have children. I have 7 grandchildren. You know from your own children, they may not be able to take a pill. They may refuse injections. We have to think about these things. For example, I cannot get tofacitinib in Canada in a liquid formulation. And so I can't use it for many of my patients. So these are things we have to think about in development programs. And the pharmacology is very different as well. This is a great review, one of many, that outlines all the difference in pharmacodynamics and pharmacokinetics between growing children and adults. And especially as children are younger, we see big differences in medication absorption, a much higher body water content, so differences in distribution of medications. Many of the enzymes, especially pre-adolescents, are not fully formed. Many of the enzymes that process medication, so metabolic changes lead to differences in pharmacokinetics. And even excretion in the very young children, renal excretion, GFR, are different. All things that need to be considered. And just by way of example, this is just a very small number of children and young adults from Hannah Kim's first publication in baricitinib. And you can see, just looking at age and weight changes, there are very big differences in T1/2 and area under the curve, and these are really important things that we need to consider when we're developing medications for children. And we need to consider the outcome measures we use as well. So all of us share the IMAX core set, the total improvement score. But when you actually look at what's been done in clinical trials in children and compare that to what's actually been done in clinical trials in adults, even in non-medication trials like exercise trials and supplement trials, we see that there's a big difference with a high preference for functional tests in children and things like histology and even mortality in adult trials. So just by way of example, this is a crossover trial looking at water-based versus land-based exercise done by colleagues in the Middle East, in Cairo, with some help from Saudi Arabia, and which demonstrated that water-based exercises, by the way, are better. They work better in this crossover trial. But all the outcomes in this study were patient-reported outcomes like fatigue or functional outcomes. And contrast that with Ingrid Lundberg's group, a very important exercise trial where 2 of the important papers that were produced were about paired muscle biopsies showing improvement in mitochondrial health and improvement in microRNA expression showing better mitochondrial function. We can't do paired muscle biopsies in studies of children. No parents will let us do that. And there are ethical considerations as well. I'm sure all of you have heard about the principle of equipoise. The principle of equipoise says that it's ethical to do a randomized trial, for example, a comparative trial, if there's really nothing at all to choose from between the two different arms. Now, of course, that's never the case by the time a medication comes to a clinical development program. We already know that there are perceived advantages. That's why we're testing it. So nowadays, it's generally recognized that uncertainty, the principle of uncertainty, is enough. If we're not certain that the new medication is better than control or placebo, then it's ethical to study. But that just doesn't hold water for most families. In broader society, and certainly parents, are much more risk-averse about children than they are about themselves. And almost never will accept a placebo in a clinical trial. And this was demonstrated very well. I mean, it's been published so many times. This is a study of over 200 patients with neuromuscular diseases like muscular dystrophies, not myositis, but muscular dystrophies, in which parents were interviewed and given questionnaires to look at what were the barriers to participation in clinical trials. And number one was that my child could receive a placebo. And this is why they would not enter their children into clinical trials. And this is a systematic review of many similar studies like that across pediatric medicine, showing a general lack of trust when it comes to their children in the whole research system. And certainly real problems with randomization. 18 of 18 publications listed that as a big problem. So these are all things we need to consider and put that in the context of current regulatory frameworks. Now, a number of years ago, I was very delighted and lucky to be invited to sit on an Institute of Medicine panel in the United States, sponsored by the Federal Drug Administration, the FDA, looking at safe and effective medicines for children. And shortly after that, our version of the national academies, the Council of Canadian Academies, did a similar thing with Health Canada. And through this process, I got to meet a number of decision makers at the FDA, at EMA, at Japanese regulatory agencies, and in Health Canada. And as best as I can tell, in 2026, this is the regulatory framework that we need to consider when we're looking at clinical trials. The rows there are different regions of the world. The USA, the European Union, Health Canada, that's Canada, the Japanese PMDA, and the Chinese regulatory agency. And in the columns is the strength of the mandate for pediatric studies, some different things about the plan and the timing, the incentives that are involved, and key features of waivers. Now, you might notice in Canada, our pediatric study plans are very weak. There's basically no mandate, whereas in the US and the EU, it's very strong. And that both the US and the EU provide strong incentives to companies and sponsors who want to develop medicines that include pediatric plans, whereas in Canada, there's nothing, in my country. But the word I have outlined there in red, which is most explicitly stated in the US guidelines, is extrapolation. Now, what extrapolation refers to here is the degree to which we can take data from adult studies and apply them to children. And that's really has to do with how similar are the diseases in question. And although it's a continuum, and all the health agencies recognize it's a continuum, it basically boils down to if there's complete similarity between the disorders, you can have full extrapolation, you don't hardly need to study anything for children. If they're completely dissimilar, they just have the same name, and you have none, then you need to do a full pediatric development plan if you want to get approval for a medication. And for us, in myositis, we fall somewhere in the middle. We're partial. So we need some evidence in children, but we don't need the same level of rigor as is needed to establish an indication for the adult patients. So where does this leave us? Well, none of us are the same as we were when we were children. So there's a difference between adults and children. We can't assume full extrapolation, so we need some evidence. But we are allowed to use evidence from adult studies, so we need less rigor. The diseases are rare. Patients won't accept many clinical trial designs, so there's difficult accrual. So what we're stuck with is thinking about trial architectures that are more permissive and that limit the use of placebo. And so just to orient you, this is what a regular parallel groups randomized controlled trial would look like. In the yellow is the patient population, potential subjects. We sample from them. They're then randomized, hopefully using a process of hidden allocation to reduce allocation bias, into an experimental treatment and a control treatment, then followed over time, and then outcomes are measured, hopefully blindly, to reduce measurement bias. And you can see along the horizontal axis is time. And this is what the large printout 3-arm trial comparing prednisone alone to prednisone plus methotrexate to prednisone plus cyclosporin was. This is the design that that trial used. And it was a very successful and important trial, but it took years to accrue patients and enroll patients. It took them forever because of how difficult it was to get families involved. So what we need to do is increase that accrual and increase that accrual. This is apparently what AI thinks I look like. Increase accrual. I almost wore that shirt, by the way. Make trials more acceptable and limit the amount of placebo that we use for our children. One way that we can do this is a crossover trial. Now, crossover trial works like this. In yellow, again, we have the population, the potential subjects. They're then sampled and randomized to either start experimental treatment or the control treatment. They go on for a period of time, outcomes are measured, and then the patients switch. That means every patient at least get some exposure to the active therapy, and they're not on placebo for the whole trial. It also means that it's a much more efficient design. Fewer people can be studied because everybody's compared to themselves. And so it's statistically more powerful. And the study I showed you already, the Egyptian study looking at different types of exercise, was an example just like that, with only 14 patients in each group, yet a very successful trial. What we haven't done in myositis, but was widely done in children with arthritis, is something called the withdrawal trial. The way a withdrawal trial works is that we take our sample and everybody goes on the active therapy. So for example, let's say we're studying a new JAK inhibitor. Everybody would go on that treatment. And if they responded, they would stay in the study. If they didn't respond, they would drop out. Now, because only the people who respond stay in the study, this is what's called an enrichment design. We can't get a real understanding of the true treatment effect, but because we have extrapolation allowed, we don't really need that. We can have less rigor. Patients who respond are then randomized to stay on the experimental therapy or withdraw from that therapy and see which group flares more frequently or sooner. An advantage to the families is that if the patients flare, when they come off therapy, they get to go back on therapy. So again, time on placebo or control therapy is limited. No studies so far have done this for myositis. What has been done in myositis is a staggered start design. In this, sometimes called the randomized placebo phase design, we take our subjects, we sample them, and then randomize them to either start experimental treatment at the beginning or to go on a blinded placebo for a period of time and then blindly switch over to experimental treatment later. The idea being that if you start treatment sooner, you should respond sooner on average than if you start it later. And so, for example, the rituximab in myositis, or the RIM trial, was a staggered start design. And you can see, I've pointed out in the graph of the juvenile dermatomyositis patients, this is a Kaplan-Meier curve. So everybody starts with active disease. Time is along the horizontal axis over 48 weeks. Every time there's a step, it means one or more patient had a response. And the group in gray, that is the ones who are randomized 9 weeks sooner to get rituximab, responded 9 weeks sooner than the ones in black. And so we were able to show that this, in our sample, was effective. However, when we designed this study, it was thought that rituximab worked very quickly, like anti-TNFs in RA. And of course, we now know rituximab takes a long time to work. So this study, although in the sample was successful, it was underpowered to show that we could generalize this. But if you look at another therapy, this is rilonacept in children with arthritis, the systemic form of arthritis. They were randomized to either start rilonacept right up front or to wait 4 weeks and go on placebo for 4 weeks and start it 4 weeks later. So only 4 weeks of placebo in this entire clinical trial. Parents were willing to do this. There were 35 patients in each group, and there were striking results. This is the same thing, Kaplan-Meier curve, only here we're showing everybody not yet responded. And every time there's a step up, it means one or more patient responds, and there's a highly statistically significantly in favor of rilonacept, with only 35 patients per group. Now, that's really just the tip of the iceberg. Our creatine study that was published recently, and the one that's in review right now, a supplement study in children with myositis, used something called the multiple baseline design. A highly efficient design, much less rigorous than a 2-arm randomized trial, but probably enough to get a drug registered in children because of extrapolation. I haven't talked at all about adaptive trial designs or Bayesian trial designs. The British study looking at baricitinib right now in children is in a Bayesian study design. But my Canadian colleagues have published a really good systematic review if anybody wants to see. It's in 2 parts. Part 1 is listed up there. Part 2 is soon to come out, they tell me, and it focuses just on pediatric trials. And they talk all about the entire literature about adaptive clinical trials. I think for us in pediatrics, one of the ways forward is to take drugs that are currently in use and not even do clinical trials, but use the really sophisticated causal methodology that we now have to get results from our electronic medical records or our registries to get levels of evidence that are almost as good as randomized trial. And we did that as a proof of concept using the CARA data and the consensus treatment plans looking at methotrexate alone with prednisone versus pulse methotrexate versus pulse methylprednisolone, methotrexate, and IVIG. And we're now in the process of just starting to analyze the full CARA data set to see if our earlier results hold true. So I was asked to talk about the particularities of clinical trials in pediatrics. And the way I thought about this was, what would we need to do? What we need to think about if we're going to carry on developmental programs of the new medications, CAR T cells, things like that, into childhood. And I think we have to consider the differences in the disease, the fact that myositis in children is very rare, so we need special strategies to accrue patients. We need to consider formulation and pharmacokinetics, pharmacodynamics, which differ in children. We have to make sure that our outcome measures are acceptable, that they're not biopsies, and they're not things that children find very difficult, like electromyograms and things like that. Be aware of the ethical principles that make it much more difficult to study children than adults. Consider the regulatory framework that allow for less rigid and less rigorous trials in children, and really use advanced thinking about the trial architecture. Anyways, thank you very much. I'm happy to take questions if you have any.
Okay, welcome questions. Please step up to the podium.
First of all, Lucy, thanks for asking a question, because I really didn't think anybody would ask a question about a pediatric clinical trial talk.
Okay. Hi, Lucy Wedderburn from London. Beautiful talk. Thank you. I totally agree with you about using real-world evidence, and some such real-world evidence has got into clinical guidelines that national organizations write. But what is your sense that the regulators are going to accept that as a high enough level of evidence in situations where we're not able to do, or we're not wishing to do randomized controlled trials, which I agree with you.
I mean, the thing that I took away from my time with the EMA and FDA officials is that it's all a conversation. And especially when we're talking about pediatric plans. They might have very rigid definitions of what needs to be done for adult studies, but if we're talking about conditions that are like dermatomyositis compared to dermatomyositis, not dermatomyositis compared to inclusion body myositis, but if we're doing stuff like that, it's a conversation, and I think there's some very forward-thinking people that I met that would probably say, this is fine. Like, think about everything you can do to generate evidence for us so we feel comfortable approving a new medication.
I'm short. It was a great talk, Brian. I have a question. You touched upon adaptive, trial designs and, platform trials potentially. I think, that got a lot of momentum in ALS and got a lot of drugs FDA approved. I feel like the myositis space is also potentially ready for that, especially in IBM. Is that happening in the juvenile dermatomyositis realm as well? And given your expertise, do you think that it can potentially launch in the myositis space for adults as well?
Julie, sorry, there's a big echo.
Oh.
It's really hard to hear clearly.
Okay.
What is the actual question? Because that's the part I couldn't hear.
The actual question, I'll distill it down, is what do you think about platform trials? Are we ready for it yet in myositis, basically?
I think especially for pediatrics, platform trials are probably a great idea.
Yeah.
So for example, some of these CAR T-cell studies now are looking at platform trials with a variety of pediatric indications and with much more rigorous designs for the adult disease, adult lupus, for example, whereas the platform trial might have single-arm lupus, dermatomyositis, scleroderma, things like that. And because we can get away with that because of extrapolation, I think any evidence that allows us to get approval for medications that we can use in children is perfect. As a purist, as a trialist, we could argue on paper that they're not going to be as rigorous and as good, but I don't think that's the key here. I think the key for us as pediatricians is getting medications approved.
Ardalan from Duke University. We go way back, Brian. Nice talk, as always. My question for you, so at one point you characterized in the talk the incentives for pediatric trials in the US in particular as being really robust. And it was interesting to hear that because I facilitated a conversation with many different representatives from industry at the CARA Corporate Advisory Council last year. And during that conversation, a number of, not everybody, but a number of the attendees representing industry were pretty clear that pediatric trials more or less are an afterthought, essentially a regulatory requirement, but not something desirable for them to do, just something they have to do. What can we do to bring ourselves forward as thought leaders to industry and bring industry to us as partners early in the trial design process so that we're not treated as a footnote, and moreover, so that the trial designs from the get-go in the adult studies are appropriately set up to enable extrapolation for children?
Yeah, so that's a bit of a double-barreled question there, Kaveh. In terms of incentives, you're probably right in the sense that if you have a blockbuster drug, a 6-month patent extension is perhaps worth $1 billion. That's probably makes it very well worthwhile doing a small pediatric trial. But if you're talking about a rare indication that's for a rare disease, it's going to be like a 6-month extension on patent may not be enough. So I think it really depends on where you're coming from in this. What can we do? Well, I think the very fact that I got invited to talk here means that we're thinking, the MCTC and the global myositis community is thinking about this right at the beginning. And industry is engaging with us. And so as long as we bring pediatrics to the table and we have strong representatives in the charities as well, like CureJM, I think that's the key. Is to, as you say, get right in there at the beginning. It's not going to be us yelling and screaming. I really think it is the rest of our larger group bringing us along and supporting us.
Just as one minor follow-up for anybody from industry in the room, in the CARA, in the Childhood Arthritis and Rheumatology Research Alliance, one of the things that we can and do offer is early consultation on clinical trial design across not just myositis, but lupus, juvenile arthritis, and more. And so I think there is thought leadership represented in CARA and other organizations in the myositis space that can be tapped to enable better trial designs from the get-go. So come to us early so we can help you at the start. Thanks.
Thanks, Kathy.
Last question, very short.
Yeah, very short question. Peter Korsten from Germany. Thank you for mentioning a couple of trial designs. Do you think N of 1 trial design could work in children?
So the term N of 1 trial design has been used in different ways over the years. It originally meant a randomized trial with multiple crossovers within a single individual. Now it's often used, especially in oncology, as an early phase 1B experiment in a single person who's going to die anyway, so you might as well try this drug. With the original use, we've published, for example, Adam Huber, who was in the audience over there, published a Bayesian meta-analysis of N of 1 trials to give quite robust population for the kind of drugs you can that do wash out well, that you can turn on and off, is probably a phenomenal strategy, and one that I've been a big supporter of. But it's that multiple crossover.
To understand? Yeah. All the doors are still open. Maybe Peter, you can close some doors? Yeah. Okay. Well, I hope that will become better this time. Yeah, thank you. Well, the International Myositis Organization, the aim is to provide a global infrastructure to harmonize standards of care, to develop diagnostic criteria and classification systems and implementation thereof. And we want to strengthen collaboration amongst the myositis community, including patient organizations, increase international awareness of myositis, and education of myositis specialists, including the hosting of the Gcom is also a very important subject. And that's why we're here during the Global Conference on Myositis. Well, I like all the people present to welcome them very much to the meeting. An agenda has been sent, and I don't know if anybody else wants to add something to the agenda that has been sent. The agenda is here, but well, when you have things later on, that's also possible, of course. So then we'll just stick to the agenda that has been made. The minutes of the General Assembly of the 19th of November from last year have been sent, and I don't know if anybody has anything to say about that, or that we can just accept them. And then we thank Peter for making them. Thank you very much. And there are several things that I would like to inform you about from the chair point of view. We have grown in the number of members. There are over 250 now, and they come from all regions, well, almost all regions of the world, because South of Africa is at this point missing. So if someone knows someone from Africa, I think it would be really nice to have additional members from there as well. But the society is growing, and I think that's good. There are several reasons to become a member. You get access to exclusive member content. You're entitled to vote during this meeting about, for instance, the Board of Society, including the chairs. People that are member are able to have reduced registration fee for the Gcom, which is held every 2 years. And of course, we would really like you to participate in one of our many subcommittees. And there's also collaboration with the Clinical and Experimental Rheumatology, the official journal of IMyos, and well, you can present papers there. Well, the board, changed in November. I'll come back to that later. And, well, I already showed you the board members, and we have several associate board members: Olivier Boyer, Karen Cheng, Margarita Gianni, Midrul Johari, Peter Korsten, come back to that later, Tiran Liuluk, and James Lilleker. And, well, we really would like to include board members from additional regions of the world, such as, for instance, South America, Africa, and Asia. And we are already thinking about people that might contribute to the board. But, well, when you or someone else knows a special person that could contribute to the board, we would really like to hear that. I'll show the email address later, because just an informal mail would be appreciated. So then we can become a real global society. An overview of the society: it's a non-profit charity organization. We don't have to pay tax. It was founded in 2019 by Jens Smit, together with all the other people. The legal office and tax home is in Germany. There are bylaws. You can read all the information about that. And so far, there is a membership fee of 50 euros per year. Additional members can apply. And, well, for the time being, we'll just stick to this amount of membership fee. And we just decided that there is a reduced membership fee for low-income countries, so that the number of members can grow. And as said before, the current number of members is 251 now. This looks like the same, is it true? Doesn't go, yeah. Well, we have a lot of cooperations already, and we put them all here. I'm not going to go through all of them, but you can see there are a lot of things going on in the myositis organization, and a lot of different organizations working on myositis. And we have a lot of connections with all of them. And the thing that has just been published in the Clinical Experimental Rheumatology from this year, that there is a governance system where several organizational frameworks have been included. And the governance meeting is just after this meeting, and there will be more details about all the different organizations that are contributing to it. Well, we recently established collaborations, developments with FOCIS, WMS, EAN, and ENMC. And for instance, on the EAN, there will be a scientific theater session this year in June. There's a special symposium organized together with FOCIS in San Francisco. WMS are collaborations established. And unfortunately, well, the application that has been done for an ENMC workshop on myositis terminology, that has not been accepted, unfortunately. But we decided that we are going to take up the project ourselves, and Jens is one of the leads in that. I don't know if you want to add something about it. At this point, we'll come back to that during a later stage with more details of how we're going to do that. Well, this is what Olivier already showed yesterday. It's the FOCIS meeting in San Francisco. I just wanted to pay attention to it again. A special myositis session during that meeting. And then I would like to give the word to Silke, who's going to... Yeah, of course, yeah, go ahead.
If you just go ahead.
Yeah, if you have a question at this point.
one question and one comment. Question is a reduced fee for low-income countries. Did you also consider to include low-middle income countries?
Yes, we did. Yeah.
Okay.
Yeah. I just mentioned the low income, but we did. Yes.
And the second one is within the World Federation of Neurology, there are specialty groups. And there is one specialty group, the neuromuscular specialty group, which organizes the
ICNMD?
Yeah.
Yeah.
Meetings. And would it be worthwhile trying to get a collaboration with them as well?
Yeah. We do. Sorry, I did forgot to mention it, so it's good that you come back to it. The ICNMD meeting is in Florence in July, and I've been in contact with the organization, and we're going to have a special symposium on myositis or a special session on myositis there as well.
No, that's great. Congratulations. But maybe, I mean, the chair of the specialty group is Jim Dick. So I would advise you to reach out to him as well.
Okay, good idea. It's not has not been completed. Also, that's a very good idea to do. Thanks. Yeah.
Thank you, Marianne.
Yeah, very good idea. Other questions? Otherwise, we'll go to Silke. I should. You want to use this one?
Yes. So, thank you very much, Anneke. The detailed information about the income and outcome of the ABIOS I will show in the General Assembly in autumn. You can see that our income is rising. On the 31st of December 2021, we had an account balance for 3,500 euros, and at the 16th March 2026, it was 16,645 euros. So it's a good development, and I hope we'll get more money and more income. Thank you.
Yeah, so that's good news. We're, well, at this moment, a financially healthy organization, I think. And, later this year, there will be more details, as Silke said, about the expenses and all the things that come in. And, well, hopefully this Gcom turns out very positive as well. So that could add also to a better financial status. And then we can, well, try to make a lot of plans how to continue with the organization. So thank you, Silke. Well, and then there are several things that we should discuss that are related to the board, but also something very special about a honorary membership. We've discussed it for the last part of the year, and we decided to give this first honorary membership of the IMIOS organization, she already knows, to Ingrid Lundberg. Well, it was our plan, Ingrid, to already do this ceremony and give you, to hand over to you something yesterday already during the welcomes, but you were not there yet, so we had to postpone it. But we would like to, well, announce it now, and I'll talk to Rachel that there is going to be another moment that we are going to hand over this special prize and to get into more details so that more people will know that you deserved this honorary membership. They always talk about founding fathers, but I think you are sort of the founding mother of the Gcom organization. So, but we'll come back to with more people. So, but now we already know, and I really would like to congratulate you. Same for you, I think. Yes.
Well, Ingrid, without you, we would not be here today.
in this IMIOS setting?
Well, I was recently elected as a chair for IMIOS in November, at the same time point that Didem Saigin was elected as the vice chair, and that was the moment that Jens Schmidt stepped down as the chair, but became, fortunately, because he has so much information about the whole organization, that he is elected as the secretary. And Silke, fortunately, just stays on as the elected treasurer. And, well, leaving the board is Peter Korsten. He did a lot of work, but fortunately, he stays on as a board member, as an associate board member, for which we are very thankful also. And maybe, Jens, you can say something about Peter's contribution, because I think, well, he was one of the first that was involved in the IMIOS organization.
Yeah, it's really an honor to have worked with you so closely as founding board member. And I said that many times in the past, that we couldn't have done without you in setting up the Verein, the tax exemption, bank account and everything. So all of that credit goes to you. And I'm personally very thankful, because it was only possible that I can become elected as a secretary, because you were willing to step down from your role. And but I think for the time being, it's important to have some continuity of the information, as Annika just said, within our young society. So thank you for all what you did, and you're very active, and we will hear about that later today with certain projects that you will continue to do with, for example, a new webcast, and so you will stay very active in the IMIOS community. But still, thank you very much, Peter.
And there is something special for you, just as a remembrance to your period as a board member. But I'm looking at Stephen, but it's not. Also tomorrow. Okay, so that's going to be a... Okay. Thank you, Peter, for all the things that you did and that you're still doing. Well, and then unfortunate, and well, I really do not want to talk about it yet, but Olivier Boyer and also Karen Cheng have been talking about leaving the board, but or the associate board, but I hope they will stay a little bit longer until we found another person that can replace them. So that's also, again, the call for additional associate board members, and I hope you will help to find someone. Yes, Jens.
May I politely add something? So we had this call, what you just said, that we are looking for people from other geographical areas. Of course, that's wishful thinking. So if there's anybody in the room, or if you know co-workers, even from Europe or close by regions, then most of all it's important that we find dedicated people who really like to advance IMIOS at all levels. And I think we do have a very good collection of associate board members, but I think that it will also be natural that if someone leaves, that we have open positions and that we would like to fill them. So it will be, maybe you can mention, but I think you already said with the email.
It's on the end of the presentation.
Okay. Thank you.
Thank you for adding that. Well, and then Peter is going to inform us about the webinars. Maybe you can come this way. It was, well, planned already, and it's going to start now. And another thing that is about the web content, that this year a protected member-only area has been installed. So you can find a lot of information there.
Thank you very much. I'll be quick, I promise. Thank you for the kind words, more than I deserve, because I will still continue to work for IMIS, but not as a secretary. So we came up with the idea of offering webinars for dedicated topics relevant to the IMIS or the myositis community. And we are happy to announce now fixed dates. It's easy to remember. It will always be at 2 p.m. Central European time, to adjust for different time zones, to be as inclusive as possible. And we have very renowned speakers and topics, and I'm happy to listen to different talks from famous people that you can almost all meet here at Gcom. So I've always presented the CER home journal data, and in February the annual monothematic issue has been published. I think it has been a great success, and as always the publication costs are 100 euros per printed page, which equals the open access fees. So all papers accepted for the annual monothematic issue are freely accessible for a fixed fee of 100 euros per printed page. And also the abstracts of Gcom will be published afterwards, after the conference, as a citable issue published on clinical experimental rheumatology. And I've compiled those data for the article types and the number of articles published over the past years. So you see a slight increase in the number with 41 papers in total, a nice collection of papers dedicated to myositis. It's not only reviews. We, along with the CER editorial board, we decide for reviews which are considered invited and free of charge. But all the full papers are submitted, and you see an increasing number, or a kind of stable number, increasing from last year to this year, with 19 full papers, original papers, and 12 letters to the editors. So I think it's a very successful monothematic issue on a rare disease, which is a home for clinical experimental rheumatology, also for other rare disease in rheumatology. Thank you.
Thank you, Peter. And then it's I'd like to ask Rachel to come up and talk about the Gcom that we're at now. I added 2 slides because I thought this was really nice.
Thank you, Anek. Good afternoon. Well, what I'm going to present is just about up until the second day of the conference, so we should discuss this on Thursday evening when everyone, I hope, is super happy. But this is literally, these slides were chosen by Anek, but I'm pretty sure that she chose well. Chose well. Again, a huge acknowledge to our local organizing committee for everything, but also, although he's not here, a huge acknowledge again for the steering committee that helped a lot in organizing these. Just to raise the attention that we have grown quite a lot as myositis community, and this year we have nearly 700 participants, which is amazing, and they are coming from all over the world. All the continents are represented, which is super good. I'm really happy about it. And again, to raise the fact that we had nearly 400 abstracts submitted, which is great, and they all have a high quality, which make really hard to choose them for the scientific committee. Glad that I was not part of it. We did several oral presentations, several posters, so please, more than anything else, I hope you enjoy the fact that you're here. And like was raised already, all the abstracts will be submitted and will be available at the Clinical and Experimental Rheumatology, which is really good for the submitters, for the abstract submitters actually, for the authors. And again, I really hope you are enjoying the conference. just to remind that we have several scientific sessions, we have oral presentation sessions, we have this new thing in the program, which are the workshops that so far have been really well received for everyone. At least the feedback we have received so far was really good. And also the pre-conference on muscle ultrasound, which was also really well received for the participants. And really proud to know that we are actually we are 23 CME accredited in our scientific sessions, which is amazing. And I will hand over to Mary Hudson to Montreal, that I'm pretty sure that is going to be an amazing congress too.
But not before. Thank you very much.
I will be brief as well. For those who don't know me, I'm Marie Hudson. I'm from McGill in Montreal. I would like to thank iMyos for this great honor of having the great opportunity to host the 7th Gcom in 2028. So thank you very much. Raquel, you set the bar very high. I can see that I will be losing quite a bit of sleep over the next couple of years. So why Montreal? In a nutshell, Montreal, we have history, we have culture, we have food. Montreal is highly accessible, it's safe and affordable, and I really think that we are a good-sized city to host a meeting and to hopefully do as well a job as Lisbon. I'd like to also say that, some people, I'm not in this alone. I am surrounded by an amazing group, mostly of young investigators. I truly believe in bringing the young generation forward. So I will have two co-chairs, Valérie Leclerc and Océane Landon-Cardinal, who are here at this meeting. Yves Troyanov, many of you know Yves is full of ideas. Deborah Sayag is actually a respirologist interested in ILD. She is very involved with our group. Martin Jarry, for those who have not met him yet, and Karen, I don't know if you've met him, but he's an amazing patient advocate. We will have some good help from him. In our team, we have neurologists Erin O'Farrell and Oliver Blanchard, who are actually here at this meeting. Benjamin Elazam and Jason Karamchandani, amazing pathologists. We have a dermatologist, actually, Dahosa Lim, who trained with Vicky Worth in Pennsylvania, and Stéphane Fournier, who will be representing the allied health professional. So really a well-rounded, multidisciplinary team, hopefully to represent the community completely. So thank you, and I welcome you all to Montreal in 2028. I look forward to seeing you there. Thank you.
Well, very looking forward to going there. Thank you for your... and the exact dates have not been established yet, but working on it. Yeah. Okay. Thank you very much. Then, well, some additional things. When you want to be updated about everything that is going on, just sign up for the Emmaus newsletter. You have to do that. Otherwise, you won't get it, unfortunately, and Silke is putting a lot of effort into the newsletter. Also added to the website is the calendar of events. It's live now, and it will be fed by all collaborative institutions, such as MIRA, MATC, Mayonet, and, well, when you want to add something to the calendar, just send it to your local network. Well, and that was the update for today. I don't know if anyone else has a question or remark. Otherwise, we'll conclude the update here. And there will be a governance meeting in half an hour. But I think we'll have to see how many people, well, we'll see how to continue. But thank you for your attendance. And have a good evening.
Thank you. We can't we can't switch the schedule probably. You have the chair.
too. Why not?
It's true. So, yes, of course, the muscle goes away.